Do you know where Sycamore Valley Elementary? More towards it. Yeah.
It's just E.
Yeah.
So, and
Yeah. Yeah. Okay. So that's still out there. They didn't build much. It's just
it's I didn't have no.
yeah. What, do you still live in the Bay Area?
No.
Oh, okay.
E-E-G-O.
Okay, is that right? Okay, perfect. So tell me a little bit about Genesis. You guys are long-term care?
Long-term
Okay.
care. So. Placement, the service.
Yeah.
It's taking a picture. Yeah. They have medical partnership.
Okay.
But long-term care is.
Yeah. So you said okay.
Hi, good morning.
Okay.
Hi, I'm Frank. How are you? You doing?
Yeah.
Good.
Very
Doing Christina.
You know, we primarily work with the acute care location, the healthcare system.
They made our name descriptions on the back.
I know.
Outpatient and
Yeah.
in long-term care. So,
Thank
you know, this is a
And where
very
you on
flexible,
the-
customizable system, and you know, it's sometimes people for. acute
Oh,
care.
I see.
Lots of projects. All o'clock.
Yeah.
Really?
Kids have any meds today, so I'm taking home before.
Oh.
Yeah.
Yeah.
Where did you said
You
you
just have them in.
Okay.
The only way to make you have.
okay. Where is she located?
Are you?
Vitality Code, the science of sustainable performance. That's gonna be interesting. I'm from Los Angeles. Oh, really? Oh, okay. I don't mean you from Burbank. That's impossible.
Yeah. Where is she?
That's great.
Okay. Maybe is Genesis based on the East Coast?
They are.
Okay.
Well, they experience this. They.
Yeah. Well, I tell you, yeah, I will send over some info and yeah, anyone you think be best to review this and you know see a full demo, more in-depth demo than I showed you. I think it'd be awesome. All right. Yeah.
Get Elmer report. Yeah.
Yeah. I hear you. Oh yeah, the signing and adding is like the hardest we've heard. You know?
Yeah, it is.
All right, you got it.
Harvard's great. Yeah, no matter. Right, what do you see?
New Mexico.
Right. Right, that's right, yes.
It's
Your coolness precedes you.
There's nothing cool about
Oh. You're
Well,
right.
Oh, yeah, okay.
It's from the lady with chops.
I know.
Yeah.
Chops. So, I don't know,
Okay.
but it keeps my hair up. So what are we doing?
So, first you connect it to Wi-Fi. And then to your words, okay?
Um. Yeah, or just have come over here and grab one. That'd be better so we can get the backdrop. My phone didn't charge last night. No.
Oh,
So,
all right, I can have a good chance.
why?
For this conference.
This conference to why?
Uh-huh.
Crazy Carl was there.
Oh, Carl.
Amal was there, Safar was there. And now comes one night at dinner. It's just a fun time.
Oof. Sorry to hear that.
16 hours of
Oof.
Yeah.
So sorry to hear that.
So by the time you get back home, I just want to be in there. Just she said, one minutes to no.
Yeah, all good. Okay, I'll do it, thank you. Where's the, patents?
All right, North.
Okay. Alright, yeah, okay. Is there any coffee?
Yeah, they said we have nothing after lunch.
Oh,
Well, I'm on cheese.
Yeah, that's right. Yeah.
And I think. Good.
Yeah, are we gonna be able to project our presentations on screen?
I think So, consumed. And then. Also, the point presentation.
Wait, different videos. Oh, wow, that's an advancement.
I don't know what it is. I'm failing miserably.
I think they found it cheerful.
Okay. When there's something from here. I don't care, he's a salesman, get rid of him.
Uh-oh.
So like this, yeah.
That's a lot.
Oh.
On this today, period.
Yeah. Oh, there's 41 seconds.
Yeah.
I'm trying to learn into it.
Oh, it's sitting there.
Oof.
Just checking.
It's a zero markers.
Yes. So it's updated.
Okay. What? Thank you. Okay, please. What is it? Next. In UK. Oh.
No. Yeah.
Oh.
So where you from? That's not. I grew up across the bay. On the other side of the mountains, in town, and so. It's kind of nice.
Oh, thank you. Okay.
You're from Ellen. Yeah, I'm flying now. Are they? I was there last July. Okay. Getting slightly worse as we're I'm still alive. Yeah, I don't be able to tell anyone else. Trying to stuff. But now with this realizing thing. So. It like. Oh my. Yes. Why about this?
I was just.
The lines you catch her.
Really?
They don't have kids and was the consequences. I had a real idea. Yeah. Like 2 years ago, but I'm so these feelings so new. I mean, for 8 years.
And actually, it's like in 2004.
Oh, wow.
Yeah. Just took this long. It's all you're not to implement. Yes.
Yeah. 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 What about the words? I'm gonna try and do not play.
You can't do that.
I have a feeling we're the same.
I would imagine we are.
Not that bad. What's been procedure? Where's your trouble? Right? Confident. So. Xanax, sending on it. And I
Yeah, so I'm not sure what we're doing, so let's.
Oh, I was, okay. Mas o movimentos restam, eles ficam inside. No, stimulus. Oh, I know. Oh, do you know that? I think it was. Airports. We'll go into airports. Overstation on the clock. Just there's no. Okay. Time to represent school. So, yeah. She stop. See you first. So, pass that back. 18.
Yes. Oh, wow. Good job. That's fun. Okay, so we're gonna be doing Barbara's fabulous speaking voice will be. What's going on? Okay. And one is about to translate. Right. Then this is our driving and trying to and we're trying to it just makes sense.
That's right.
Now, are there any speakers on this list? Okay, so with that. Yes, no, so Dr. Coletti is on. Dr. Spar is not. So Dr. Groom, me, Dr. Christine Manukian is right there. Dr. G. Coming, okay, great, great. And then whoever your co-presenter for so your donations people were not.
But still introduce them, that mention that they will be present.
Yes, they will be providing the funds of business.
Okay.
And then
Share the links.
And who is going to? Because I'm not checked about that. If Roger is doing a video presentation tomorrow,
This will need to,
we just go down the list.
and then so it's Barbara,
yes.
that person who will come up.
Ramakrishnan. Did I say that right, Ramakrishnan? I'm just going to say Mr. Ramakrishnan, whose first name I sadly can't.
All right, and so Dr. Coletti, it will just be a video. And then Kevin will be presenting. And Brett,
Not big cheese that they want.
bringing their response. Oh, I see.
I missed it.
So that-
Yeah.
oh, yeah. Actually, that's the wrong.
So there was.
But is. Can I just write it for you?
35. Oh, no. Yeah.
Yes. Oh, wait, no, thank you so much, guys. So I see the projector there. Is that coming from that? What is there?
Yeah.
That, so every presentation is on.
Yep, it's all, everything right there is.
Oh, I see, okay. Great. Good. Now, is that particular person's phone?
No, it's recording.
You're recording here, is it? Great, can I see the shot?
I'll share the presentation.
Oh, I see. Is there a way to zoom in on this? Oh. Got it, okay. Here's the camera. Oh, okay, all right, would you stand over here? Got it.
Well, I know check out. And so I went to my Spotify. Bigger or. So
That's a really
that's like the
good
only
question.
thing I was like,
Is it in PowerPoint? That's right.
no. I said there's a separate
Oh.
on the email.
Max, can you go to the last slide from Dr. Christine? Yeah. Let's see.
Normal. As long as I have access to internet.
I would say, yeah, that's connected, so I would say just copy and paste it or is there, which email address? Computer.
I think there's no email address as of now. So
Yeah,
you
I
can
sent it
log
to
in
Kath-
your email.
I sent it to Catherine with the link.
It's not in your presentation.
No, it's a separate, it's a link to Spotify music.
How
So you can-
long is the link?
It's 5 minutes.
No, how long is how many letters is it?
Oh, it's, have no clue. It was at least like 2 lines, I would say.
Oh, okay.
Yeah, it's nothing like
You
short.
couldn't just dictate it to me and I would
No,
type it in.
no, we're not gonna do that.
If you wish,
Okay.
you can open your email. Just drag the link.
What I can do, I'll just play it on my computer. And it's not gonna be as loud as the speakers unless I can connect to the speakers as well
Yes,
too.
you can connect it. You
Okay.
can place your laptop here.
All right,
Yes, you
do
can
me a
place
favor,
it here.
stand there
Mhm.
so I can see the shot.
Oh, see, I won't be able to do that.
You can now see.
Yes.
See standing.
Right. Is there more light? If I wanted to, nope, this one. Oh,
I'm able to maybe share this. No. Nice to meet you.
sorry.
Oh, the reflection, right?
I
I
had
know,
an
and
office
I
on
so
Olive Avenue. You know what my
appreciate
office was about?
Oh.
It was a film company.
Oh.
Yeah, right there on Olive. So that's what I used to do is I used to make films and then I
Oh.
started taking them and putting them in hospitals.
Oh, wow.
Yeah, exactly. Yeah.
That. Do you still do that?
Oh, yeah, big
So
time.
you do
That's
production?
what we do. No, I'm out of production.
Okay.
Yeah, we just licensed the films. Yeah, but little, short comedies, and you'll see.
Oh,
Yeah, yeah.
The you don't do like podcast recordings and so more like film.
Just videos. Yeah, just videos. It's called Laughing and it's an app.
Choice medicine.
Yes, exactly. Yeah,
It is medicine. Healing is medicine.
right down
Speaking-
there. Yes,
Speaking the same language. I love that.
yes.
So yeah,
But
looks
what
like
I'm trying to do is see if there is a light here.
my podcast production, but I just do it at home and Zoom.
Mm.
Started looking at some studios to go record, but honestly, it was just too complicated to book it, and sometimes it
Oh
gets.
God, no! Doing it at home is definitely the way to go.
Just to worry. So I wonder if I can find the link, and you were saying I can email it to someone.
Well, the question is there, and I'm not great with PCs.
Mm.
So if they have email on this computer, you would have to email it to this computer, or you would have to. Oh, and you know what? You want to put each person, like a short person, is going to do that. So
Yeah, mine is like you're seeing my neck.
yeah, exactly. So, but it's good that you can see the person there. That's better than last time. I don't know where email is on this.
Does it have? If we just open up in internet browser,
Oh, that's an idea.
let's do that. Let's open up internet
Sure.
browser, and I wonder if I can.
I mean, there must be an internet browser.
I want to keep this simple. I'm gonna stress over this. That's not waste our time. I'm just gonna use my own laptop and to. It will be loud enough. It will not be too loud, but which is perfectly fine. Yeah, I'll just bring it.
Here you go.
Alright, so let's see this. You're locking. Let's see.
All right, Barbara, I was literally in the middle of writing my sentence. It's multiple connection. It's no evidence. What are these? I. Strange. Let me check it. But you can. That's what I call it. It's on the. Yes. Pioneering the use of human. Pioneering the use of human for scalable evidence-based.
It was me playing, it worked.
Oh,
Thank you, sir. But this is the big speakers though.
You know, the question for them.
It's not connected to the speakers, it's coming just from here.
Where is this? Vibrate?
Yeah, it's not connected to the speakers. But we found it at least.
This. It's gonna play off. Wait. Oh, this isn't connected to the speakers?
No, it's only coming from here.
Oh, so then do this. Playing it.
It's just here. Yeah. This isn't connected to the speakers.
Yeah, speakers.
Is it?
Yeah,
Yeah?
Yeah.
Okay,
Yeah.
because I thought it was just. Okay, as long as you
Right.
keep it.
yeah.
Oh, it's a good job. I'm so proud.
well, now that we've got our set, I would like to welcome everybody to today's day of the 15th World Health. Gosh, I can't think of the name right now. I'm sorry, I'm Dr. Barbara DeBrute, and I've been presenting with some I think this is my fourth conference that I've done with UCG. I was in San Francisco, then I went to Dubai, then we did Los Angeles, and I went back to San Francisco, my old stomping grounds. So, again, I'd like to welcome you to the 15th American Healthcare Nursing Digital Pharmaceutical Hospital Management and Patient Safety Conference. Please excuse my speech. I recently got some dental implants and I'm not quite used to them yet. Sorry. We're honored to host such a distinguished group of professionals, nurses, physicians, healthcare professionals, administrators, technologists, and patient safety advocates, united by a shared mission to shape the future of health. This conference is a platform for exchanging ideas, exploring innovations, and strengthening our collective commitment to safer, smarter, and more compassionate healthcare. From digital health to evolving nursing practices and pharmaceutical advancements, our discussions will highlight the essential pillars of a resilient healthcare system. Please take full advantage of the sessions and networking opportunities ahead of you. Your presence here enriches this event and contributes to the spirit of collaboration that drives real change. So my background, I am a doctor of nursing practice, a graduate of the University of Missouri, Kansas City School of Nursing and Healthcare. I've been a nurse now for 35 years, I think. I am currently the nurse practice educator for a large long-term care company, national company. So I do a lot of education. I stand up in front of people all the time. I talk. I tend to get lost behind the podium because I am so short. And I do move around. I'll try not to be too terribly distracting. So I would like to take this opportunity to introduce our first speaker today, Dr. Christine Manuthian. Well, first, let me introduce the rest of the keynote speakers for today. There's myself. Dr. Sahar Mohamed, unfortunately, will not be joining us for this conference. Mr. Frank Chindano over by the coffee, he'll be his keynote speaker today. Dr. Roger Coletti and Dr. Christine Manuthian, who's going to talk to us today about functional medicine leader and transformational coaching. Please join me in welcoming her.
Now we need to get to our slides. Spend time. Thanks, guys. Okay, thanks to Frank for figuring this out, which took us a while because part of my presentation, I will be leading a 5 minutes breathwork experience for all of you today. So let me find, there was our slides. Ah. See, I'm an Apple girl and this is not, this is foreign to me. Hold on. Yes, we got it. Well, good morning, everyone. So I'm going to start with a quote or just something for all of you to think about. Have you ever had that moment that you were really like trying to listen to your gut feeling, that inner knowing that says something has to change, like you can't keep going like this anymore? And sometimes we just keep pushing it away, pushing it away. We're just like, I'll deal with this one day, till one day you can't ignore it anymore. And this is exactly where I found myself. In 2015, I was from outside, looked like I had everything going on for me, graduating from pharmacy school, starting my career at Cedars-Sinai here in Beverly Hills. And again, having my family, kids, from outside, I had everything. I had figured it out. I've climbed up the hospital ladder, and nobody knew that internally I was struggling to manage motherhood, demanding career, and just trying to juggle all the demands of life itself. And this is what happens when you start sacrificing your own health for your career, for your family, or for whatever we're doing. And that's exactly where I found myself. I was morbidly obese. I had super high cholesterol. I was not eating well, not sleeping well, high stress, and just a little bit of hot mess. And just keep going through this grind day after day, putting the mask on every single day, going to work. And till that one day, it was actually Mother's Day weekend on May 11th of 2015, when I was sitting at the doctor's office, when my primary care doctor said, Christine, if you keep going like this, you're going to have a heart attack, because of being morbidly obese and again, cholesterol off the roof. And for me, that was the wake up call. And again, that inner knowing that says like, you gotta do something about it. As many, healthcare practitioners, we go straight to diagnosis and here's a pill for every ill. And I was offered to take a medication, but I just knew that there has to be a better way. Yes.
You should speak into.
Oh, thank you. Thank you.
Much closer.
Yes, thank you. But I just knew that there has to be a better way to heal myself without pharmaceuticals. And I went on a journey. What you focus on, you find. And this is exactly what I found. I found holistic wellness. I found functional medicine, and start really taking care of my health from inside out. And as a process, I lost not only 100 pounds, but I also start stepping on stages, doing fitness shows, bodybuilding athletes, and also really taking my health as my priority. And this is what I want you all to think about. Have you been sacrificing your health for the wealth? And to me, success without health is the ultimate failure. And here's me looking back, my own health transformation, to the point that my doctor thought that there was a lab error in my cholesterol panel. She's like, there's no way this, Lipitor did the job. I was like, by the way, I haven't been taking that, but instead I've been doing this. And so she was really like, not only surprised, but also it was like another way to educate our own healthcare practitioners too. Like, there's other options for us to consider before we go straight to pharmaceuticals. And again, I'm not anti-pharmaceuticals as a pharmacist, but I'm also so freaking passionate about healing from within. And Frank is going to talk about laughter as medicine, food as medicine. There's so many different tools that we have that we can use that every single day, and it's not costing us anything other than just us stepping into that. So again, looking back into my journey, I realized realized, like, my kids became my wake up call. I said, I'm not going to become a statistics. I was again told I was going to die in the next 5 years from a heart attack. And this is something that I had to turn, again, my excuses into my my why. Again, many people say that they don't have time to work out, they don't have time to do meal prepping. Again, those are all excuses. But when your why is so deep, it's like, I want to be healthy and I want to live like past 100, like thriving in vitality. This is when you really start taking action. And again, have you been sacrificing your own health to create your wealth? And most disease, begins with inflammation. And most people don't realize the connection between inflammation and nervous system dysregulation. And this is where I want to spend some time today talking about it. When we are operating from this survival mode, from this dysregulated nervous system, our body, our brain is prioritizing safety, which is overriding the analytical, the creative, and the compassionate parts of our mind, which is our moneymaker. This is where your creativity comes in. But again, if we're stuck in this burnout mode, which was me in, many years ago, again, we're really trading our health for whatever we're doing at that moment. And it's not just emotional health crisis when it comes to burnout, but it's also financial crisis. I'm a business owner myself right now. And again, as a high performer, which many of you in the room, like, again, this always goes back to, it's not because we don't have good time management skills and we're causing burnout. It's not because we don't have the mindset to operate at a higher level. It's because we're operating from this dysregulated nervous system. And it's also this misalignment with our soul, what our heart wants, compared to what our ego, which is our brain, is asking us to do. This is exactly what happened to me, because in 2020, again, during the global pandemic, I had to really pick and choose, like, what's my future going to look like? Here I am being praised as a healthcare hero, working in a hospital. My spouse, my husband, is also in hospital pharmacy and management. Again, we're both outside of home taking care of everyone else while I have nobody taking care of my kids. And seeing them suffer, like, we're not there, we're not providing them the comfort. There was so much unknown going on. It was just heartbreaking. And this is, for me, became that, again, that inner knowing, like, I have to make a decision. In attending a couple of events and really getting into that mindset of, I can do this. And I actually did turn in my 2-week notice and walked away from my career and start creating my new lifestyle. And again, this is a time when I said, I'm not going to sacrificing my family for my career. And I turn my pain into my purpose. I say this because so many of us are struggling internally without letting people know what we're going through. And to me, it's like, if you share your story more, if you really open up yourself and give someone hope that they can create their new lifestyle, is going to be such a huge game changer, not only for them, but also for you as well too. And I took my journey, and in the last 5 years, published 5 #1 bestseller books. My latest book, Breathe, Heal, Surrender. I do have 1 copy. One lucky person can grab it. If you enjoy this type of work, you can read it on your flight back home. But again, a lot of people saw me quitting my job in the midst of COVID, and they were thinking, like, I'm going through a midlife crisis, but my inner knowing knew this is my path to my purpose. And when I walked away from corporate, this was, again, my identity. This is everything that I worked so hard for, past residency, doing all these incredible things. I had to put it aside and I had to make that big decision. What is my calling? And my calling is to create the holistic wellness revolution. So it's not just functional medicine, but it's also energetics, Ayurveda, Chinese medicine, herbalism, all this energy healing modalities that we have. And if you see on my website, my company that I started, Store Institute, we're a board certification to provide training for practitioners and aspiring coaches to become a board certified holistic wellness coaches. And I spell holistic with a W because to me, it's that whole body health with holistic principles. And there's not just one modality. We have to have multiple tools because not everyone responds to one way. And becoming a new entrepreneur, if any of you have started your own business, you can definitely relate to this. And again, I thought leaving my job will fix everything, right? And however, the truth is entrepreneurship has different kinds of burnouts. Again, I wasn't living my life. I was actually surviving in a new costume. So thinking that, oh my gosh, everything's going to be so beautiful because now I'm my own boss, I get to do everything. However, I didn't know what I was preparing myself for. And I brought in that hustle mentality back into my business, and I found myself being burned out as a business owner. And this is where I had to make that big decision again. I was suffering, experiencing burnout again, and I had to really decide, what is my next step? What am I going to be doing? And this is one of my favorite quotes by Richard Rohr. It says, if you don't learn how to transform your pain, you will transfer it to everyone around you. And I didn't want to be that person. I said, I need to do something. I have to take care of this pain now before I pass this to my family, to my loved ones. And this is something that I had to really listen to my inner knowing again. And I said, no more sacrificing my freedom for my business success. This is where I packed my bags, flew to Bali, spent a couple of weeks healing and going through this reinvention, rebirth, I would say. It's such a beautiful spiritual space. And I keep going back there, hosting my own retreats and taking others through this journey. But again, I had to really burn everything down and start from the bottom, like start again from a different mindset. I had to heal myself so I can heal my business, putting things in place that before I didn't have, such as boundaries of how your clients or your partners are treating you, or how your team is dealing with you. So a lot of these things that I didn't have experience with till I start actually being in the business part. And the cost of success should not be your health. Vitality is wealth. I like to joke around that I went from being a legal drug dealer to a healer. And during this process, I spent so many different trainings and certifications, becoming certified in Reiki energy healing, NLP, tapping, clinical hypnotherapy, life success coaching, and attended several functional medicine schools, of course, my own Story Institute, IFM, FMU, SAFM, all these different schools. I was like back to school again, just learning and take it all in, and really understanding, like, again, we're always learning and we're always growing. And more you start getting into this space, you will realize there's so much things that are missing. And to me, this is the missing link in healthcare. A lot of us think that we can just jump into the healing and taking care of ourselves. But however, your body will not be able to heal if you don't feel safe to heal. Okay. And our nervous system regulation is that entry point to help our body to feel safe first. And breath work is one of my favorite modalities that I have created that is going to help you to access that subconscious mind, access that inner knowing, for you to feel safe to go through whatever you need to release, whether it's trauma, whatever you're going through. And again, when we combine both nervous system regulation and breath work, they bring it together, and this is going to help you to unlock vitality and clarity to your health. And the truth is, we take about 20,000 steps, I wish steps a day, which will be amazing, but 20,000 breaths per day. So this is an opportunity for all of us to stop, pause for a second to connect with our breath before we go on our hectic day. And self-regulation is your superpower. And intentional and deliberately using your health is crucial for your mental health and nervous system regulation. And so this is, again, learning all these different modalities, I found a way to combine them together. So using with a nervous system regulation first, cross breath work to create a neuro breath work, which is my proprietary way of delivering vitality. If you're new to breath work, I have several free resources on my website, drchristymanukian.com. There's about 35-minute breathwork experience on my website. It's free for you to download, or you can check out some of my Forbes publications that talks about also offering breathwork as a wellness initiative for the corporate wellness programs. Okay. If you are all into vitality, you can definitely, follow the journey when it comes to, like, again, so many free resources during this process. I put it out, whether it's my podcast, Holistic Vitality Podcast. And again, during this reinvention phase, I realized that vitality is your ultimate edge and nervous system regulation is your doorway. So where am I going with this? You heard me talk about healing, getting healthy, going back to the burnout, going back to healing again. It's this ongoing cycle, right? But the first thing is for us to recognize that we're stuck in the survival mode. Most of us are operating what is called functional freeze. We're functioning day to day, but our body is about to shut down. We're in the survival, fight or flight mode. And once you make that, recognition is like, I gotta do, like, raise your hand and just say, I need help. I know it's hard for many of us to ask for help, but again, you have to be your own CEO of your own health. And again, when you're stuck in that survival mode, you first need to start working into, how do I feel safe so I can start healing, right? And after you feel safe, you go on your healing journey, which ultimately brings into vitality. And this is, again, what I have created using vitality framework, and each letter stands for different parts of us that we do healing. So letter V in vitality is voicing your truth. I stands for inner child healing. T is transformation begins within, breaking generational patterns. A is for alignment. L is letting go and forgiveness. I is for intuitive and intentional living. T is trust and surrender. And last but not least, Y is yielding to holistic vitality. Again, there's so many different parts of us that needs work, and our internal, external capacity to receive is the reflection of what internal capacity can actually hold. And if we don't do this work, disease will become a real thing. Burnout is real. We all are going through that in some shape or form. And what if I told you that burnout was not the price that you had to pay? What if you could rewrite your own story? And I hope this is becoming your wake-up call, hearing my journey. And again, your story is not over, it's just beginning. And I invite all of you to, again, as you go through today's presentations, to have that open mind of, as you listen to different speakers, like, what is it that's something you can bring into yourself, to your own lifestyle, and to incorporate it and advocate for it, right? So this is the beauty of being surrounded with so many different experts. And for me, it's leading this holistic wellness revolution. And future healthcare, to me, the way I look at it, is not just clinical, it's this holistic approach. And it's time to train our next generation of holistic pharmacists and leaders, so we can bring in this to more organizations, and also for our own life as well too. And this is one of my favorite mottos and quotes I would love to all of you to listen to. I say that everyone deserves a second chance to rewrite their story and become the best version of themselves. So next time your inner knowing is whispering that something has to change, my question for all of you is, will you listen? So I hope you enjoyed this brief presentation, but I will be guiding you all through a 5-minute breathwork experience. So with that said, I'm going to actually go ahead and close the slides for me. Let me just minimize it. Thank you so much. Oh, there's all these different tabs. Oh my gosh, great. Oh, Jesus Christ. Okay. Exactly. See, Frank, now you're saying that. Yeah. Okay, so how do I get back to the internet part? But while Mr. Frank is helping me to get all situated,
It's Professor Frank, by the way.
Professor, there you go. Thank you. Okay, where's the
That's
internet
you.
part? Yes.
Oh, you want to go straight to the web?
Yeah, because I have that. There you go.
Thank you.
Perfect. That's it. Thank you. Beautiful.
We did it.
Voila.
Okay.
Thank you. So what we're going to be doing first is I will be showing you with a different breathwork pattern. So for this breathwork experience, it's a 4-part breath. So you're going to take 4 inhales through your nose and 4 exhales through your mouth. And if you enjoy tapping, or if you believe in tapping, we have a lot of energy parts in our body. Using your fingers as you're doing the inhales, use both of your hands. I have my mic here, but just close your eyes and you will just follow that pattern. Don't count. You're not here to count. Just use your hands. If you don't, this is too complicated for you, that's okay. Listen to your body, whatever you feel comfortable with doing. If you would like to receive more, you can put your hands on your knees, like facing up. This is for receiving. But if you need more grounding and just feeling more secure, you can just put your hands down safely on your lap and just, again, listen to your body. If you are going to be one of the, let's go, we're doing this, just use your hand, just tapping. Again, 4 deep inhales through your nose and 4 deep exhales through your mouth. We're not stopping, we're not taking breaks. This is a very short breathwork experience. So we'll be breathing this, and I will guide you through when we're part of the meditation piece. I will tell you, stop, go back to your normal breath. So just listen to me and go on this beautiful journey, okay? And with that said, let's go ahead and start closing your eyes. Feel safe to do that. And let's go ahead and start with our breathwork practice. Inhale, 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 exhale, 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 exhale. In, out, 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 out. Keep going. No pauses. Beautiful. Just get rid of all the chatter in your mind. Just focus on your breath. That's the only thing you're focusing on. Continue with your breath. Connect to your heart. Beautiful. On the next breath, just take it even deeper, louder. Beautiful. Connect with your heart. Again, connect with your soul. Inhale, 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 exhale, 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 exhale. And you're feeling any sensations in your fingers, in your body, that's perfectly normal. You're safe. Just connect with your breath, connect to your heart. Beautiful. Continue with your breath. Again, make it deeper, make it louder. This is your journey. Beautiful. And with our next song, you can go ahead and take your breaths on the normal pattern and just focus on your breath. Take all the inhales and exhales through your nose, just soften your breath. And again, connect to your heart, connect to your soul. And on this experience, I would like for you to start visualizing someone that you would like to forgive today. And forgiveness is for our own soul. Forgiveness is for you to feel free, to get that peace in your life, in your body. For some of us, you have to forgive yourself first. So visualize. We're not accepting what has happened. We are just acknowledging the feeling. And if you just join us, just close your eyes and breathe and just listen to what I'm saying. Just start visualizing where in your body you feel that pain, that anger, that frustration that you're still holding on to. Just visualize. Does it have color? What size is it? Does it have a shape? Just visualize in your body. Is it on your throat, on your chest, on your stomach, in your head? Where are you still holding on to this anger, to this frustration? And I want you to start expanding whatever visual that came to your mind. Visualize getting it bigger and bigger in your body. And grab it from your body and take it out of your body. See it in front of you. The color, the shape, the size. I want you to just smash it on the floor, just in million pieces. Physically see that. Grab one small piece of that. Exactly where you found it. It's so tiny that you can't even feel it's there. Just feel the peace in your body, in your wow. And again, send love and compassion to whoever came into your minds that are needing for you today to forgive. And if you're forgiving yourself, welcome to your healing journey. You can just visualize your life, how much it has changed. Now you shifted your energy from this anger and frustration and more in the peace and the calm and abundance and gratitude. it has taught you a lesson. It has made you brave. And when you're ready, you can slowly open your eyes and come back to the world. Welcome back, everyone. How are we all feeling? Thanks for playing around. Awesome. Well, here's a little glimpse. Yes, thank you, thank you. A little glimpse into my life of how I lead and how I want to bring in wellness and vitality and healing to the world. And again, I think my healing journey has given me permission to be open and vulnerable. We talked about forgiveness, and that has been one of the key pillars for my own healing journey, that I had to find the strength in me to heal and forgive my dad that I haven't had a chance to speak with for over 25 years, and to finally face him and have that conversation. So this level of work is deep, and you're stronger than you think that you are. And I want you all to know that whatever journey you're on, this is your path, and you never know who you're going to help and change. So thank you again for this lovely morning, and cannot wait to hear everybody else. So thank you.
Don't go away.
I didn't know. See, first time newbie here.
Close.
Thank you, Christine. That was a great presentation.
Thank you.
I found myself, my visualization of my distress was a great big orange spiky
Oh,
virus looking
that's me
thing.
too. Yes.
So
You know, when the COVID came out, that represents
yes,
that, and
that's
the
what it
orange,
looked like.
red. Oh my God, we had exact. And where exactly was it in your body? Do you remember? Mine is right here.
Mine was up here.
Yeah, mine was like right here in my gut, and it was just getting so big and big. I was like, same shape. Isn't that wild? It is.
Just in my head.
Thanks for sharing.
Well, Christine.
Oh.
Max is gonna take.
Thank you. Appreciate it.
Thank you so much. Sure, you're welcome. I hope to see you at another conference.
Yes.
I need some more. Now, if you please, welcome me in Miss Humayun Nassim. Did I say that correctly? Because I'm not Humayun Nassim. She's going to talk to us today. Her presentation on trauma-informed care and mental health advocacy. The bike ride, healing the past, empowering the future, understanding childhood trauma. Thank you so much.
I can stand there. Because if we do it, we cover it, right?
Yeah.
Ivan and Karen. The Mike. Until you make your unconscious conscious, it will keep running your life and you will call it fate. Ladies and gentlemen, isn't that true for chronic illnesses as well? That we keep calling them fated and a play of genetics without understanding the root causes. Today in this session, I'll be presenting 3 points. Chronic illnesses, their root causes, and how to heal them holistically by understanding childhood trauma in the light of this case study. Meet Baya, an adventurous, bubbly, full of life little girl. Let's travel back in time to one cool summer evening of Karachi. Baya's dad was about to return from work and he was bringing a brand new BMX cycle for her elder brother. The whole family, along with Baya, was impatiently waiting for her dad's return. Excited to celebrate this great milestone of Baya's elder brother. Everyone celebrated this milestone of her elder brother being graduated from a tricycle to a giant bicycle. Clapped, cheered him up while Baya's dad gave him lessons how to ride the bicycle. Baya, being an ambitious little girl, was also waiting for her time to come when she would be riding a bicycle as well. Fast forward, years later, she was ready. She was not expecting a new cycle, but she was expecting the same enthusiasm and care from her family. Unfortunately, she was not met with this expectation. So she decided to to ride the bicycle herself. And off she went onto the streets, failing and falling multiple times before she learned how to ride it. Excitedly, she went inside the home, told her mother that she is successful in riding the cycle, but much to her dismay, her mother was tired from work. She was in the kitchen busy preparing meal for the family and she refused to join her. Baya was heartbroken and shattered. She sobbed silently and 3 things happened. She formed 3 beliefs very early in childhood. Number 1, I am not worthy of love, care, attention of my parents. I am not good enough to be celebrated for my achievements. And number 3, I don't need anyone. I can clap for myself. Now, these 3 feelings, they look subtle, harmless. But just imagine if they become an algorithm in your life for the rest of your life. And you take all the choices and decisions based on these 3 beliefs. Imagine how isolated you will feel, how abandoned and unloved and uncared for you will feel. And as a result, what will happen? So, in the light of this case study, we will understand the relationship between childhood trauma and chronic illness and how to heal childhood trauma and the transmission of trauma through generations. Coming back to the case study, when we form these thoughts and beliefs in the early childhood, they become our blueprint of how to lead the rest of our life. And not only Baya, these are similar experiences shared across humanity because emotions don't change based on caste, color, creed, anything. We should all feel the same emotions around the globe. So imagine if these beliefs become a part of you. How are you going to handle those emotions? Are you going to suppress them? And if you're going to suppress them, these uncomfortable feelings, obviously, they are not comfortable enough to be shared or talked about. You just put them under the carpet, so much so that one day your lungs will shrink with the weight of those feelings and won't be able to take much air inside. And maybe you can be diagnosed with asthma then. Or maybe in order to cope with these uncomfortable feelings, you will have a pattern of emotional eating to cope and soothe and pacify yourself from these feelings whenever you hit a milestone or whenever either in your personal or work life you are hit with a similar incident. Because now you are living your life with the same belief that you have made early in that moment of time. So your emotions will then dictate your behaviors. You will have tendency for people pleasing because remember what Baya believed. She believed I'm not good enough to be celebrated for my achievements. So she's going to, be a perfectionist, trying to, work hard to prove her worth. And then in order to gain love and attention from others, she would start pleasing people so that she can be seen and heard as well. And then, when let's say 10 years, 20 years pass by during this course of life, these things then are diagnosed and are manifested in the physical life in form of diseases. That is, an imbalance in our human body, which is indicated then on the physical level in the form of chronic illnesses like depression, diabetes, obesity, and in many cases, when you have suppressed negative energy so much inside, you can be diagnosed with cancer as well. So these are the root causes from the very first incident. If you nip in the bud, you can prevent and even cure illnesses later in life. Now, Baya's story did not end here because it never started with her. So Baya's story never started with her. It started generations back, a generation back, and Baya's dad wanted a bicycle too. So now I want you to understand how intergenerational trauma plays in our life. What is intergenerational trauma? Intergenerational trauma is the passing down of a traumatic memory that gets stuck in our body in the form of emotions. And even after 2, 3, 4 generations, maybe a war has happened, migration, famine, relocation, and a certain person in that generation experienced these things and it got stuck within his or her system. And later it was passed across generations. Well, we all know the impact of epigenetics in this and the experiment that had been done on rats, as a matter of fact. So I would like you to um, this is a short video Anyways, I will explain it to you. Some rats were exposed to a certain kind of a smell and they were given electric shock as soon as they were exposed to that smell. And this memory was so intact in their cells that even after 4 generations, the fourth generation of rats, when they were exposed to the similar smell, they felt the same emotions, the same fear as the first generation of rats had experienced. So this is how important it is to nip in the bud to heal the incident at that very instant where at the very root of it. So this is how trauma is passed across generations. Moving forward with the case study, as I mentioned, that that little memory that was stuck in Baya's system was passed across from her father, who also wanted a cycle. And his story was that Baya's grandfather could not afford a bicycle for his son at the time where they had migrated. At the time of partition, they had migrated, lost their property, left the land, came settled in a new place, and he would, if he managed to afford one bicycle, in a community-based living where they were living alongside 2 orphans, he could not afford 3 bicycles for the 3 kids to ride and go to school. So that memory of Baya's dad was an unfulfilled dream that got projected later in his life, where he made sure that his son is not deprived of what was missing in his life. And that little girl at that time could not understand the feelings from what the things had happened and could not realize, and had, had this photographic memory imprinted in her memory. This is how we need to address the root causes so that we do not fall prey to the uncomfortable feelings that later become a part of our system, and we then need to it's better, prevention is better than cure, I believe. So our cellular life as an egg begins in the womb of our grandmother. So it is better to have an integrated preventive approach to healthcare, wherein we not only cure the disease, we take preventive measures in advance, and break the cycle of not only chronic illness but also trauma. So I am a holistic healer, and I provide this 4-layered approach to healing childhood trauma and chronic illness. The first layer is the spiritual health. We need to understand that everything happens for a reason, and we need to strengthen our connection with the divine source. Once we are grounded enough to understand the divine decree, the second layer comes the emotional health. That is the debris that we have collected across several years. We need to clean it. We need to understand it. First, we need to accept it. And once we have accepted it, we need to forgive not only others, we have to forgive ourselves. Thank you, Dr. Christine, for that wonderful meditation. Then the third layer is the psychological health, where our focus, our attention, the coping mechanisms of dissociation come from the perfectionism, impulsive eating, all these things we need to understand, and we need to take care of that. Then our physical health through lifestyle, nutrition, exercise, and then fourth, if there is any drug intervention needed, then we move towards that. So this is the 4-layered approach that I use to heal my clients. So wrapping up the 3 points, the chronic illnesses that we talked about, the root causes and their connection with childhood trauma meets Baya. So that little girl standing right in front of you, I'm a Dubai-based holistic healer and an author. I've been recognized by the House of Lords as a Global Women Power Leader 2024. And apart from all these credentials, I'm a storyteller mom. And the story ends with us. The trauma ends with us. The bike ride, healing the past, empowering the future, understanding childhood trauma. So what did Baya do to heal herself? She rewrote her story. Later, she not only rode the bicycle with her dad, this is a motorbike that was gifted by Baya's grandfather to his son when he graduated from college. And it's the most preserved and cherished possession of my father. So we together rode that bike as well. It's still there, very much shining and in a very good working condition. And not only healing the past, empowering the future as well, so that the cycle ends with us. So Baya made sure that her children are not left behind and they are equally taken care of. So these are my kids, and you're fulfilling the dream, and that stuck, reliving that stuck memory once again to heal myself, to heal my family, the past generation and the next generation. Trauma is passed in the form of pain across generations until someone in the family line feels it and heals it within herself. So let's come together to break the cycle and say it ends with us and build a healthier future one generation at a time. Thank you so much.
Next to get his picture. Wonderful presentation, thank you. So please join me in welcoming our next speaker. Please tell me if I pronounce your name incorrectly. Dr. Nithya Ayanar, okay, from the UAE. She is a forward-thinking researcher in AI, and she's going to talk today about revolutionizing patient safety, the AI imperative. Thank you so much.
Good morning, everyone. So my topic is totally different from the last two speakers who spoke about wellness and who spoke about mental health. It's very, very important that we as humans have to concentrate on that. But I'm going to take you into a science fiction that is artificial intelligence, which has nothing to do with emotional health or mental well-being. Okay, so why did I choose this topic? As I am from the smart city, Dubai, where you have robocops. You have flying taxis, which is going to come in next year, and you have radars, which can monitor you 24 by 7. I chose this topic of artificial intelligence, where Dubai is going to be the smart city, and it's also going to engage artificial intelligence into healthcare by 2030. So today I'm here to ask you a question. What is AI, artificial intelligence? How does it impact healthcare? That is what we're going to look at. So, we know that AI today can diagnose diseases, it can write an essay, it can actually write a poem, it can do anything. It can also drive a car, right? Okay, so can AI reduce the medical errors, which is the third most important cause of deaths in the world? That's a question we ask. So today, I'm not in front of you as a quality expert or a clinician, but I'm here in front of you as a passionate advocate of patient safety. So it's every human being has a right for safe practice and healthcare. So now, today, we are in a turning point of healthcare where we have a tool which thinks like us, which does not forget, which does not miss out anything, and more importantly, it does not have emotional connect, but it does not get swayed up by human emotions. It does what you have to do, and that is artificial intelligence. So, are we ready to take this artificial intelligence as a diagnostic tool in hospitals? Or are we ready to take this as a guardian angel to enhance patient safety? So that's what we are going to talk about today. Now, I'm going to ask AI why, where, what, how, etc. So I thought, what, where, whom should I ask? How do I get these answers? So what I did is I asked AI itself. Okay, so ask these questions to AI. AI, are you Gen Z? Do you listen to millennials? Okay. Are you a filter of TikTok with PhD? These are the questions I asked. And it said, no, doctor. I'm not that. I'm not Gen Z. I'm not Alpha. I'm not Omega. But I'm like you. I answer your queries. I assist you. And I also correct you when you're wrong. That's what it gave me. The next question I asked AI was that, where are you from? So I expected the answer, are you from Silicon Valley? But it said, no, I was born here in Stanford in a lab. Okay, that's where I was born, and I had my first job diagnosing what? What did I diagnose? I diagnosed blood infections, and without salary, I suggested antibiotics to the healthcare professionals. That's what my first job was. And later I evolved, and in 1980s and 1990s, I became a clinical support decision making, helping your clinicians to take decisions. And in 2010s, I started reading x-rays so that I can help you to diagnose and just suggest a doctor, okay, maybe you have to go back and look into that x-ray. You missed out a tumor. That's what is AI. And then came the pandemic and the COVID era where I evolved. Okay, AI was at your doorstep, in your office rooms, in your home, as telehealth, where COVID came in, and then we had telehealth and remote healthcare where AI played a major role. So that's the history of healthcare. Now, when we talk about AI, we always talk as artificial intelligence, right? But how many of you know augmented intelligence? Okay, so artificial intelligence and augmented intelligence, to put in a very simple word. So artificial intelligence is nothing but you just tell a robot, okay, robot, do my surgery. And it does the surgery, provided you expect that it does the sutures as well. Okay, the next one is augmented intelligence. That is superhumans. That is a combination of artificial intelligence and human power. So, augmented intelligence is that, for example, for radiology department, you have artificial intelligence which reads out a lot of X-rays and prompts the doctor with differential diagnosis. And this is a combination. At the end, the decision making is a human. The human intervention is there. So that is augmented intelligence. So this is about the history of AI. Now, to understand better of AI, this is not a technology presentation, and I'm not a tech expert. I am a doctor. So I try to understand AI in my own way. And this is how I take AI and teach my professionals and my colleagues about AI as well. So imagine AI as a building with a basement. Okay. So the basement, in all construction, the basement has to be strong. So the basement of AI is filled with data across the globe. So there is n number of data across the globe from your EHRs, from your surveys, etc. So this is the data bank, the basement of the AI. The next comes is the algorithm pattern, the first floor, where it starts connecting the dots between these data and then does the prediction. So what happens is that, okay, high BP, low temperature, high fever, okay, so this could be sepsis. This is how the prediction arises. The next floor is the machine learning. This is something magical. So for example, if I'm a clinician, I see a patient diagnosis and say, okay, I have seen this before, but a machine would say, I have seen this 186,787 times before, and I have learned from this and have modified the protocol. So that is machine learning. And then is the clinical decision support in the next floor, which is basically a doctor's consultation room. So you have an AI whispering into the doctor's ears. It's assisting the doctor. The doctor listens to the patient, looks at his history, everything, and then the AI whispers, okay, doctor, so maybe these are the signs and symptoms. You should be looking at this lab test, particular test, and modify the medication to this particular dose. So AI is just an assistant. It is not replacing a physician. And the last part, the penthouse, is the continuous improvement. And it's my favorite part. I'm a quality expert. It's just like quality improvement, like quality department is never out of the audit loop. It is never ending. Same way, the data and the improvements which is collected from all this learning is utilized for improvements. Unlike humans, AI learn from their mistakes and correct it. So that's a brief introduction about AI. Now, AI in healthcare. So if I had to open a hospital which is run by AI, except for a CEO with AI, okay, so what am I going to do? Where am I going to apply? So I would be having AI mostly in the diagnostic, because diagnostic is the crux of any healthcare system. Then you would have patient monitoring solutions. These are AIs like superhumans who never sleep or never take a coffee break. Okay, you cannot expect that from humans, but these AIs, when I would be speaking in my further slides, will get deep in understanding these patient monitoring solutions. Next is operational efficiency. So this is allowed by the management, okay, because it's going to improve your professional efficiency and it is going to enhance your operations, reduce costs. Okay, so we are going to learn about that. And deep learning techniques. So there is a lot of deep learning. This is something little bit psychic. I would say it learns so much of data and produces so much of information, which sometimes it's hard to believe. And next is natural learning process, language processing. So a doctor's writing, it's very difficult to be read by another human. Okay, I asked AI and AI said, yes, it's the same with me, but I will try. So with lot of natural language processing, AI is now capable of reading different scripts, handwritten scripts, and then process it into a comprised document which is used by the clinicians to take decisions. Okay, so that's where it makes our life easy and makes the nurse's life easy more. Okay, and the pharmacist. So predictive analytics. So predictive analytics is like a fortune teller. Okay, so it takes up a lot of data and then predicts what, like we already listened in the morning, that what with the childhood trauma, what future illnesses you could get. The same way, data from your previous health records and previous systems can actually predict what are the future trends of health issues which a human can face. Now, enhancing patient safety with AI. So, this is the crux. Like, yes, there are a lot of things AI can do to enhance patient safety, but we are interested in numbers. So, there are proven studies across the globe which says there's 30% decrease in diagnostic errors and 40% faster diagnosis. So, what is very important, you don't want to wait for your radiology reports or lab reports. Like, okay, I just gave my blood, I need the reports right now. So AI enhances that. And there is 25% of early detections rates and 50% reduction of false positive. And this, my cardiologists love it because it reduces the anxiety and panic attacks because of the false alarms caused by the ECG. So that is completely taken off and gives them a confidence in the ECG monitoring because of AI. So that enhances patient safety. So now let's talk. Why did I say diagnostic is very important in AI? So diagnosis plays a lot many important roles. So AI, from diagnosis of skin lesions to detecting of lung cancer, today AI has developed from the early 1980s to 2020s and going on. It is going to read and be very accurate just to replicate a human decision or human diagnosis. The future of diagnostic is basically going to combine with genomics and genetic medicine. And tomorrow you would be guessing your future diagnosis with this kind of AI intervention. So the measurable impact of AI in diagnostic is operationally reduced turnaround time, as I said, like you would be getting, you just upload your images and you get your diagnosis less than a minute, and you have a CT and MRI which can be read by an AI in less than 2 minutes. And this is going to cause less physician burnout, mental health, etc. is very important for the clinician community. So AI enhances that, and so there will be a reduction in the errors made by the physicians because of this AI support. And AI acts like a triage nurse within your system where it prioritizes the high criticality of the reporting which is required. Maybe a patient in the ICU who is suffering from stroke requires his reports to be done at a priority basis. So that's what AI does, prioritizing critical results and also prioritizing tests, and also prompting differential diagnosis for the clinicians so that you do not miss out anything. Now, let's come to the next part is the medication safety. So medication safety is the crux for clinician and the nurses. So we know that medication errors can be very fatal. A wrong medication also can lead to death. Now, what happens when you use AI into medication systems? So it automatically identifies drug interactions, any kind of allergies. So it also has a monitoring capacity to monitor the adherence of the medications by the patient. So if the patient has missed 3 doses, it alerts the clinician, okay, this patient has not taken 3 doses of his medication, you have to alter his next dose. So that's the intervention the AI enhances to enhance patient safety in medication. The next one is AI in early warning system. So this is a most important part, early warning detection system in your intensive care units or critical care units. Just like having a 24/7, a second brain working for you, as I said, superhumans in your ICUs. So what it does, so you have heard about alarm fatigue. You have always in ICUs when you go in, you have this lot of this beep, 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 which causes a lot of alarm fatigue. And sometimes as humans, what we do, we miss out. Okay, it's a normal sound. We don't identify. But AI today has played a very important role in enhancing patient safety by early warning sign detection. So there's proven evidence that 40% of code blue flu crash was identified by AI by giving a early warning sign to the clinician team in the ICU by at least 15 to 30 minutes head start. It is also important to understand that timely intervention is very important in intensive care because you have to have a better clinical outcome. Now, data-driven decisions are very important. So it sometimes when the patient is in ICU, it depends like five clinicians come together and then decide, okay, should we shift out the patient outside, step him down to the room, or you still need to monitor him ahead. But AI does that for you. It collects all the data points from your physician notes, nursing notes, medication, lab, radiology, and then it's sitting like a scientist behind you and then telling you, okay, this patient can be transferred out, and no, this patient has to be here in the ICU for further management. So that was AI's intervention in the critical care unit. Now and AI is just enhancing clinical decisions for a physician. As a physician, AI is like a super GPS. Okay, super GPS, which takes to a destination where it'll avoid any kind of speeding tickets. It'll not take you into any kind of bumpy roads. It'll not get you any kind of fines. So this is what a navigation system, the AI is for a clinician. As physicians, using AI appropriately can enhance your clinical practice. Next is AI in infection control. So after the COVID era, infection control has become everything. We never knew that we had to wash our hands for 30 seconds before COVID, right? We never knew what is social distancing. I couldn't even speak to my mom. I couldn't even speak to my brother during the COVID time. So it taught us a lot of lessons during the pandemic. Now, AI in this era has so much of data insights or infection control before the next pandemic becomes the headline. So AI analyzes the data and gives you that outbreak which is going to happen in future. That's the intervention of AI in infection control. And of course, it gives you real-time data on all the microbial patterns which is available in your hospital when you use this kind of AI in your system. Next is the backbone, that is the nursing care. We recently celebrated the International Nursing Day on May 12th, honoring all nurses. Florence Nightingale said that nursing care is very important. It's not only the responsibility of the nurse to cure the patient, but it's also her or his responsibility to be there for a patient and give that human empathy, which no machine can deliver till date. So here, what does AI do? AI does all the administrative tasks for the nursing. So the nurse can spend more time with the individual in the bedside. Okay, give that empathy, give that sympathy, and give that human touch, which is very important for healing out. I agree, the previous speakers would agree that how much of human intervention is required for any kind of healing. So that makes a lot of difference. So nursing AI is a backbone. It's just like a co-pilot which helps the nurse to take off the plane of nursing care appropriately and so at a super speed destination arrival. AI and remote patient monitoring. So in future, the hospitals will be transformed into a NASA area, okay, instead of how NASA monitors all the satellites and all the planets and the stars, etc. So you are going to have a big hall in the hospital monitoring all the patients, all the remote devices, all the wearable devices from a big control room. So that depends upon the hospital operations, and countries like UAE intend to extend this remote patient monitoring to all its citizens. So that's going to be a massive development in AI, where AI would help in monitoring patient at his or home. So, and that's how to enhance patient safety. Now, AI in patient experience. So, what is patient experience? Of course, going to a hospital, booking an appointment, waiting for the waiting for the physician. So these are the important parts for patient experience. So the recent conference I attended in Dubai stated that one of the speakers told me that in the future, my AI in my phone is going to talk to the AI in the hospital. Both of them are going to talk to each other, book an appointment, select the doctor for you based on your signs and symptoms, and you do nothing, just relax, sit at home, have a coffee. That's it. Okay, that's it. So AI will do that for you. Okay, so that's about patient experience. Now, personalized medicine, it's just like fashion. One size fitting all is not the future. In fashion, you have to have customized. So, personalized AI medicine customizes medicine as per your genomics, as per your DNA in future. Now, quality and patient safety dashboards are very important. So you get to have real-time dashboards which are breathing, which allows you to do and data analysis. We do not go on doing a RCA after a patient fall or an adverse event. Instead of that, we would be monitoring all this data and ensure that the corrective actions are put in place before the next shift. So that's the future of AI. The future of AI is got a lot, as we already discussed. So there would be some barriers associated, like data privacy. You need to train your staff. You will be facing resistance from clinician professions because they think the AI is going to replace them. And then AI algorithm bias is the most important thing which we need to understand, that AI gives you a lot of information. ChatGPT gives you a lot of information. Copilot gives you, Gemini gives you a lot of information, but there could be algorithm bias. In medicine, algorithm bias should be eliminated. For example, the learning of AI is through the data. Today, we do not have availability of data across all globes. So algorithm bias could lead up to missing out certain population. So this could be misleading in future. That has to be looked into ethical consideration. So we as healthcare providers, when we select any AI, we have to look into ethics of it, whether the vendor is providing you your AI without the algorithm bias. And today we do not have a strong regulatory framework like how the WHO or the JCIs do have standards for the hospitals and healthcare for patient safety and other things. So in future, all the stakeholders, regulatory, technology, and healthcare leaders should come together and evolve the regulatory landscape. Now, this is very interesting. So when it comes to AI purchasing, everyone wants to drive a Tesla. But when you want to purchase one, you will just go back to your garage and say, okay, my Honda is fine. I can still drive it. Okay, fine. So that is what, okay, it comes with a cost. The management would prefer to buy an MRI machine rather than investing in AI, right? So my CFO would ask me, this shiny dashboards of yours, is it going to reduce cost or it's only fancy? So I still haven't figured out that answer yet. Okay, and the CEO, okay, you have to allocate resources. You have to allocate a lot of strategy into AI implementation. That's the future. So the smart city like Dubai has introduced AI into school educations now. So AI has become a mandatory subject in schools, and very soon AI is also going to become a mandatory subject in healthcare, in all healthcare fraternity. So AI is very important, and to enhance AI, adopt AI, and to improve patient safety, you have to have that appropriate training. So I come to the last of my presentation with this important quote: AI will not replace healthcare professionals, but those who use AI will replace those who do not. That's the future. So remember, AI is not replacing humans. Okay, it's going to make your job easy. It is going to reduce all your stress. It's going to think for you. It's not going to forget. It'll enhance your work. It'll give you a work-life balance so that you can spend more time with your family and have that mental well-being. So use AI. So thank you all. So this presentation was created by augmented intelligence, but presented by a real human. Thank you.
Thank you so very much. That was certificate for you. Next. so much. That was really enlightening. I've always put AI on a back burner as far as I thought it's so very complex. But having a conversation with my husband the other day about how AI is now used in creating art and creating literature. How does that impact the artist and the writer down the road? It's going to be very interesting to see what happens. Thank you so much.
All right, I'm up and I am Professor Frank Chindamo, certified humor professional, and I'm here to MC our performance. So can you switch this for me? So that we go to the next one. Thanks. So a couple of things. One is that I'm going to be, using the timer, so please stay within your time. It's okay to be shorter. And the next thing is that we're very grateful to UGC and to Max. Let's hear it for Max. You see, applause actually stimulates blood flow, so I'll applaud for anything or anyone at this point. All right, so first coming to the stage here, we have Dr. Vadya Bala, and Dr. Vadya Bala is going to talk about the Integrating Healthcare, a comprehensive review of the convergent model, literature, and impact on health policies. Did I get that right?
Thank you.
All
Yes,
right.
you did.
All right, then, and you're coming to us from Australia.
That's right.
All right, well, welcome then.
Thank you.
Okay.
So Max, what do I start from the slideshow? So just this button. All right. Good morning, everyone. And thanks, Professor Frank, for your introduction. Vadya Bala, origin from southern India, settled in Australia for more than 30 years now. Come from a town called Wollongong in the state of New South Wales, which is about 90 km from Sydney. And my role is I graduated as a rehabilitation physician back in 2004 in Melbourne. And currently I work as a senior staff specialist in rehabilitation medicine. And I'm also a medical co-director for the population and public health for the district. So this is a great opportunity to share my role as a medical co-director in the healthcare and hospital management. And when I heard the first two speakers, I wasn't sure whether I was in the right place because it was very holistic talk, because my talk is going to be completely dry, hospital-based management. It's about policies and things. So kindly excuse me if you sleep. All right. So there's quite an extensive discussion about the integrated care across the globe. And my view is that, and when I asked about integrated care, unfortunately, nobody's able to tell me what it is, at least in my workplace. So they all thought about, oh, we're combining together, but what have we done about it? Because the current healthcare evolution model is it's very diversified across the globe. I mean, I'm sure it's very highly specialized, but highly diversified. And we do everything well in isolation, extremely well. But what have we done to integrate that to do well? So there's quite a bit of a big divide between the specialized care towards what the community exactly knows about as specialized care. So I saw that as a big gap, and I thought there is a model that we could probably embrace and promote, which is more the convergent model of care, which is what my proposal to my health management. So today's learning outcomes would be for you, what is convergent model of care? And how do we go about developing this model? And what are the core components? And this is not something that I've invented. I mean, there are some very, very good programs in the United States that they have actually embraced this convergent model, and they have done it very successfully. What are the big impacts on the health policy? And how do we monitor and evaluate as usual? So the convergent model of care is an emerging approach in the healthcare, which emphasizes the integration of various models of care from acute to subacute to community care. And it also integrates multiple care approaches, because we probably know that the care approaches from the acute care, which is the medical and surgical, which is what the majority of the community is quite aware of it. Everyone knows about cardiology, everyone knows about neurology and nephrology. How many of you know about what a rehabilitation physician do in this room? Can anyone tell me what a rehabilitation physician do? What's the role of a rehabilitation physician?
To use all the services available, physical therapy, occupational therapy, speech therapy, to improve the health of individuals who are not at an acute care level.
So you're a very good nurse, you see, because doctors couldn't tell me that. Because even in my own place of work, and also and back home in India, where I originally came from, so rehabilitation is perceived as physiotherapy. And I'm not actually sort of downplaying one particular specialty, but the acute care medical people and surgical team, they manage rehabilitation care with utilizing one physical component of therapy. So a rehabilitation physician is a team leader, an 8 years trained physician in Australia, who actually is a team leader, coordinates the medical care alongside incorporating the physical, functional, psychological, social, vocational, avocational aspects of medicine. So that's very good. I mean, you got me there. That's good. But this is where we wanted to. It's just one specialty, but if you look at it holistically, globally, how can we do that? From the acute hospital-based care to the community assets of multiple agencies, pharmacies, nursing practitioners. How do we utilize them to bring about a coordinated care approach? So exactly the rehabilitation approach, but at a very larger scale, is more the convergent model of care. The key concepts: healthcare services in an organization to provide a comprehensive patient care, incorporating the organizational structure and collaborating between different healthcare professionals. Because currently the biggest challenge we have within the hospital is the clinical engagement. Does everyone know about clinical engagement, medical clinical engagement? So what it is that there is a big, very nice paper on that one. And how do we engage doctors within the hospital practice? So a clinically engaged physician or a surgeon is someone who actually works for the service and not for himself. So essentially, he contributes something to the service, but also contributes to his self-progress. Because essentially, if you look at it, not sort of me, myself being a physician, but if you talk to someone, they talk about what they have done rather than what has been done to the service. You can do this experiment yourself. It's a social experiment. So a clinical engagement is basically for doctors to add value to the service rather than merely adding value to their career. So you've got to engage the doctors clinically and improve that as an outcome measure in order to achieve a desirable results in a convergent care. And again, encouraging the patients and the healthcare providers to self-care to maintain their health and well-being, which actually pretty much aligns with my previous speakers as a holistic care. So look after yourself in order to look after somebody else. And also tailoring healthcare services to meet the specific needs for individual patients. So how does it impact on the health policy? So the policy development is adopting a convergent model of care can lead to developing policies that supports integrated care delivery that includes policies that promoting collaboration amongst the healthcare providers, as we talked about the clinical engagement, and use of precision medicine and patient empowerment. The funding. Funding is a very crucial for all the health-related policies. With the convergent model of care, it leads to changes in the healthcare funding. Now, I'm not familiar with the health funding in other countries, but we have what we call as an activity-based funding in Australia. So based on your activity, how much you participate, what's kind of a surgical, which is in the acute model, it's an episodic funding. So based on a particular episode, which is either a knee replacement or a hip replacement, or if a patient has got a particular episode of illness, they're funded, blocked. In the subacute care and rehabilitation, it's more an activity-based funding where the patients will have to engage in a particular therapy for a minimum of 2 to 3 hours, based on that activity, it is funded. So by incorporating the convergent model of care, there will be a slight shift in this activity-based funding. The main core outcome here is to avoid any financial leakages. That's what we want to achieve. So to avoid any cost variances and financial leakages, which is a significant problem in the budget that we have. And then going up to another level of regulatory frameworks when implementing the convergent model of care, which requires changes to the existing regulatory frameworks, which is going to be a significant challenge, and quality of care, where policies that supports a convergent model, which can improve the quality of care. Now, it's all big mumbo jumbo, but what is more relevant is, has that been done? Yes. That's what the most important thing is. Incorporating all these aspects, we have some examples. So let's study the case examples of the convergent model. Probably you might know who lives in the United States is basically the Kaiser Permanente integrated model. It's a brilliant model. In fact, I actually saw on the way when I was walking in the Van Ness Avenue, there was an office. So this is the leading example in the integrated care model. They haven't said it as a convergent model, but this is one of the example. It could be augmented. I wouldn't say improved because they do it very well. So this model emphasizes a coordinated care across various specialty services. So they talk to each other very well and ensures best possible outcome, receiving comprehensive care and continuum of care, which is the most important one, and incorporating the primary healthcare physicians to the specialists, along with the therapy practitioners and allied health clinicians, and an excellent communication system with one particular medical records, EMR, so that everyone can actually see. The impact, what did that have? Was the studies have shown that Kaiser Permanente's integrated care model leads to better management of chronic disease management. So essentially, it sort of helped with patients with chronic diseases and reduced hospital admissions and reduced emergency department visits. So that's a very desirable outcome. And I think they also conducted some patient outcome measures, which was quite satisfactory. Second example is the program of all-inclusive care for the elderly, which is a PACE program, which is again providing a comprehensive medical, but in this model, they've incorporated the social services for the elderly people. and allowing them to maintain in their communities. And this is very nicely done for culturally diverse but inclusive programs. It integrated primary care and specialty care together, along with social services, which is a very rare thing because to integrate the community assets, which is more the primary care physicians, to specialists care, and then you have the social services. Now, of course, in Australia, we have this the social services as what we call as a complex program, which is for hospital-based patients, where when they go home, they get some nursing care, they get some personal care for a period of 6 weeks. Some of the patients we provide what's called as a transitional aged care program, which runs for 3 months. So these patients can actually go home with the tax, which is they get physiotherapy, occupational therapy, nursing care, and personal care for a period of 12 weeks. There is a quad program, which is mainly for physio and OT for a period of 6 weeks. So these are all the community services. But are they integrated with the specialist care? No, it's isolated. So the PACE program has addressed that. So in fact, my take-home message is for me to take this on board and go back to my executive board to see whether we can actually incorporate some of these models over there. The other one is the Camden Coalition Healthcare Providers. Again, this is another example where they were able to coordinate patients' care, again, including the medical and social services. But they incorporated one particular component to it, what's called as the hotspotting approaches, identifying and targeting the patients with the highest needs, providing intensive care. So they have actually made it patients with higher needs will get more intensive therapy versus the patient with the lower needs will get less intensive. So compared to the other models, which they will be provided the similar duration and the intensity across the board, in this case, they've actually sort of identified the high risk versus the low risk. So even within this integrated model, so you can see the differences of how they've approached it. Again, the impact factor was very nice with that one. The other one I actually saw that was community health workers approach in Brazil, which I'm not very familiar with, but I think that's one of the programs they've sort of come up with the family, including the family health strategies. This is more going into not only the patients, but also the family, which is a good thing. Sure. The last one is the Veterans Health Administration Patient Aligned Teams, which is the PACT program. Again, focusing on the veterans health, providing patient-centered approach. It actually showed better coordination of care within the veterans. Then finally, the health leads. The health lead partners with healthcare providers addressed the social determinants of health. So you may or may not know about the key social determinants of health. Some of them are food, the services, community services, the housing, the income, the family supports, social supports. So this project focused more on the key social determinants of health and addressed it. And it successfully improved the health outcomes by addressing the root cause of health disparities. As you probably know, in America, I'm doing a doctorate program in North Carolina in Campbell University. And one of the projects that we looked at is that in that area where you have housing loans approved for the blue area and the green area versus the red area. So there was quite a community diverse home loan approvals, which means the poor becomes poor, the rich is richer. Unfortunately, that has happened for a while. So that's the key social determinants, and that was taken on board. So summing up all the core components of the convergent health model is assess the local needs, what is required in your district, Mapping the community assets, that's the second step. Then stakeholder engagement. So identify how you're going to engage these stakeholders, and then adapt a model that will suit the community. Be culturally sensitive and inclusive, and a phased implementation approach, and tailoring to a specific need for the community, and capacity building, because training is very important. What's required for the community to train people is you need to train them appropriately, and secure funding and resources, and update your policies accordingly and framework, and monitor and evaluate. So in conclusion, the integrated healthcare model has been quite extensively discussed, but practically when I spoke to people, they know what an integration word meant, but really had not had any value in terms of the community practice. So my role as a clinician and health manager in my district, I mean, I can't change otherwise, but in my district is to educate my medical and allied health in the community in terms of convergent model of care, in terms of how do we unify the hospital-based diversified specialist care to the primary healthcare and community nurses, and mapping out the community assets and integrate them. And evidence have shown that we can significantly avoid the financial leakages and cost variances. So for the next 5 years, my project is to work on the convergent model in my district and promote patient outcomes. Thank you.
Thank you, Dr. Garland. I see quite a few similarities with your integrated care model and the care management model of the University of New Mexico Hospital. I was care manager there for 17 years. Where the care manager really is the hub. She manages all of the acute care needs, gets together with all the teams, has a daily report, says, yes, this can be done, no, that can't be done, we need to reconsider this. And then it extends into the community also with the clinic case manager. So I'd love to talk to you more about this.
Absolutely.
But thank you so much.
Thank you.
All right, well, coming to the stage now, we have, oh, certificates, thank you. Now you see why Barbara's in charge.
Barbara has control issues.
Thank God. Good that these are in order. Oh, thank you very much. Thanks for letting me go through every single other one before you pointed that out. Yes. Thank you. All right.
Thank you.
All right, thank you. All right, thank you very much. That's yours to keep. Yes. All right, now coming to the stage, we have my friend, a woman who is suffering from control issues, so she'll be able to talk about that a little bit. This is Dr. Barbara DeGroot, and as you've seen Barbara emceeing our show so far, and Barbara is the director of nursing, a doctor of nursing practice, and her presentation is called Medication Non-Adherence in Community Dwelling Adults, Causes, Consequences, and Home Monitoring.
Okay, let me file close that.
So more applause, please. Both our previous speaker and Barbara. Thank you.
Well, thank you. Thanks, Frank. You know, I've worked in a number of areas of nursing, I've been an acute care case manager at University of New Mexico Hospital. I've done home care. What else have I done? I've been an educator for a number of years. One of the things that was kind of a constant theme throughout my nursing career has been medication non-adherence. And we see it all the time. A patient comes into the doctor's office, the provider says, well, how are you doing with your lisinopril? Oh, I don't take that anymore. My blood pressure is cured because I don't feel bad. Okay. So what I want to talk about, hopefully within the next 25 minutes, are some of the causes and consequences of non-adherence in the US, and these are in community dwelling adults. Identify what methods we are currently used, that we use in our particular settings to reduce some of the non-adherence, and then apply that information to your setting. So way back in 1985, C. Everett Koop said, drugs don't work in patients who don't take them. Absolutely right. And how wise that was now, what, 15 and 25, 40 years ago? So the significance of this is our continually aging population. Our life expectancy has been extended. We need to, I believe, shift from acute illness care to chronic disease management. So the issue of poor medication adherence is a principal worry to all healthcare providers, nurse practitioners, nurses, physicians, PAs, everybody. The condition acuity, I'm sorry, I have to scroll over here. So acute versus chronic conditions. Chronic illnesses typically require very complex regimens of extended duration that increases the potential for poor medication adherence. And despite the chronicity, medication adherence is probably the most influential factor in treatment outcomes. So when we have poor adherence, we can expect poorer outcomes. I looked at, now this data is 3 years old. I looked at prescription drug use and disease chronicity, and you can see that 70% of the population, the US population, takes at least one medication. 50% takes 2 medications, and 20%, that's 1/5 of the US population, takes 5 or more prescription medications. For the chronic conditions, 60% of the population has one chronic condition, most likely hypertension, and 40% has 2 chronic conditions. So there are 5 factors that influence medication non-adherence. They can be person-related, condition-related, treatment-related, system-related, or socioeconomic reasons. So person-related factors, the personal attitude about meds, sensory and physical limitations, gender, personality, culture, and understanding the health conditions. I was a home care nurse up in rural northeastern California, in Modoc County, high desert, lots of ranchers out there. And my job is to go around to these rusty, crusty old ranchers and tried to explain to them what high blood pressure was. And it was very interesting. I came up with a lot of analogies. One of my favorite ones is you have a spigot on your house and you have the hose on it, and you take the hose and you make a big circle with it, and then you reconnect it to the top. So now you turn on the faucet. What happens? And I do this with my nursing students. What happens with this? Well, the pressure inside the hose, the blood vessel, with that high pressure over an extended period of time, starts to damage the intima of the veins and the arteries. So it starts to degrade the hose. What happens, I would ask these cowboys, what happens when the hose, is old and it's been laying out in the sun and high pressure? Well, it breaks, it fails. There's your description of high blood pressure. This is what it's doing to your body. And go on and talk to them about that. Personal attitudes about medications. I have many, many friends all around the world, some of whom are naturopaths, don't believe in Western medicine, don't believe in medications. And I'm not saying that's a bad thing, but I think what we need to do is to kind of cross over and work together so that we can have lifestyle changes. We can integrate meditation and other activities, but still continue with the medications that are proven to help reduce the effects of the illness. Sensory and physical limitations. Some people have difficulty getting up and down out of their chairs. Some can't walk across the room. They may have visual issues. They may have sensory issues from perhaps diabetes. So those factors also come into play. There was a study done, and I can't recall the author, that looked at the adherence rates between men and women. Women, of course, because how do I say this? Women are raised to be more obedient, I think, than men. So women had higher adherence rates than men. Personalities, you have some very strong personalities and rusty, crusty old ranchers. Trying to find a way to get into that person's brain and find out how they learn, what they need to learn, what they know. Why don't they think that this is going to work? Those are all very important factors. Cultures also, various cultures from around the world have different beliefs about medications and how health conditions should be treated. And then understanding the health condition itself. One of the topics that I'd like to spend time with my nursing students is diabetes. And I tell them it's not just about the high blood sugar. You can control that. You can take a little insulin, bring the blood sugar, But what happens to the rest of the body? So that high blood sugar damages every part of your body. And I say, people go blind. People have heart attacks. Their lungs don't work right. Their kidneys don't work right. Their nervous system doesn't work. That's why I tell them that's why people who are diabetic and have neuropathy, always nice soft socks, good hard shoes, because if they step on something, a tack, they're not going to feel it, and they will walk around for days with a tack stuck in the bottom of their foot. It damages the blood vessels. So now the oxygen and the nutrients aren't getting to that wound on the bottom of the foot. What's going to happen? Well, the wound's going to get worse. Okay, so the wound's going to get worse. What else? We've talked about amputations and how diabetes is just such a devastating disease, and people need to understand that just like they need to understand about how hypertension, lung diseases. So it's our job as nurses to, again, find out how our patients or our residents learn, how they process things. Move on here. Condition-related factors. Psychiatric conditions, I hadn't considered it when I did this little study. And then I was watching something on TV one night, and it was about schizophrenic patients in New York City, always going in and out of the hospital. And I thought, okay, well, that makes sense. If they have a condition that prevents them from understanding how important it is to take their meds. You know, they go into the hospital, they get them stabilized on their medications, they go back out into the community, they don't have access to the medication, and they fall off the wagon, and it's just this revolving door. So psychiatric conditions can play a big part in influencing medication adherence, as can symptomology. You know, they call high blood pressure the silent killer. You know, I didn't know I had blood pressure. And then one day I went to the doctor and I was like 150/98. And they said, oh, you have high blood pressure. Okay, take a little pill. And now everything's fine. But I understood the effect of the disease on the rest of my body. Some people say, I feel fine, I don't need it. My father was a perfect example of this. I don't need that damn pill. I feel fine. And arguing did no good, trust me. Treatment-related factors, polypharmacy. Oh, I get 2 pills from my family practice doctor, and then, you know, I have some cardiac issues, so I take 3 pills from there. I have a lung issue. Oh, and I have this, and I have that, and I have arthritis, and I have to take all this medication. Again, as Dr. Bala said, we need to have a centralized person who helps coordinate and manage that care. Otherwise, polypharmacy just gets out of control. How often do they have to take it? Well, at 8 o'clock in the morning, I have to take A, B, and C. And then at 1, I have to take this one here, this little blue pill. And then, 3 o'clock, I have to do this. 6, but in the bedtime, I have to take a whole bunch of pills. So it's that complexity of the regimen. How often do they have to take it? Do they have to take it with food? Does it have to be on an empty stomach? Does it have to be an hour before or an hour after? The duration of therapy for acute conditions, you know, short-lived, but chronic conditions. And in this country, as we said, we have 60% of our population has at least one chronic condition. Lifelong therapy, and they have to understand that. This is, again, the people who just dig their heels in and say, no, I'm not going to do it. I don't want to do it. I don't want to take a pill every day for the rest of my life. The perceived and actual side effects. My grandma had terrible headaches when she took this medicine. Okay, well, that was your grandmother, not you. You know, or the actual side effects, it makes me so nauseous every morning when I take this. Well, maybe you should try instead taking that medication at night. And you can probably sleep through a whole lot of that. And then frequent changes. I'm going through some difficulty with my high blood pressure right now, where my blood pressure is dropping down into the 80s over the 50s. So I'm self-adjusting with the knowledge of my physician, my doses, so that I'm trying to stay in a more normal range. Health system related, number one is communication. Communicating with your healthcare provider. The nurse communicating with the healthcare provider saying Barbara's blood pressure today was, 84/52. What do you want me to do about it? Long wait times in clinics, in pharmacies, the continuity of care. Our homeless populations come into the hospital. They're there for 3, 4, 5 days. They're sent back out into the community, and they don't have, or they have referrals to clinics, but they don't follow up with it. So that continuity of care that loop has been broken. And then confusing prescription labels. I found this interesting. So if you tell your patient, I want you to take this pill 4 times a day. And you and I know it's every 6 hours. And the patient may go, okay, well, it's every 6 hours. But then they get a prescription label that says, I want you to take it at such and such a time. So it could be the same thing, 12 and 6 and 12 and 6. But older adults sometimes have difficulty with understanding that change in instruction. Take with food, take without food again. Socioeconomic related, cost of medications, of course, are skyrocketing. Lack of transportation. How do they get to the pharmacy? Many pharmacies today, fortunately, will deliver. Walmart pharmacy, where I live in Albuquerque, has just recently started home delivery. Unstable living conditions. Again, our homeless population. They're out there on the street. They're out, in jails. And then family support has also been shown to be a good predictor of medication adherence. If there's family available to help the older adult manage their medications, they have increased adherence and better outcomes. So the consequences, of course, are worsening health, avoidable hospitalizations, increased healthcare costs, increased fall risk, which is my second presentation today, and premature death. So monitoring, how do we monitor? Well, we can ask the patient, are you taking your pills? Oh, yes, I'm taking all my pills. Or are they really taking their pills? We can have home care nurses go in and do pill counts. I used to have to do that with some of my patients on home care who were taking narcotics. I would have to every day go in and count their pills, make sure they weren't slipping an extra 1 or 2 in there. We can directly observe they're taking the medication, but again, that necessitates somebody being there with the resident. Multi-compartment pill boxes, we're all familiar with the 7-day flip it open. But we also have the automatic pill dispensers that I have found to be quite reliable in the people that I've taken care of who take multiple medications multiple times a day. Pre-packaging, the bubble, the blister pack, that's all numbered. And then combination therapies. And when I think of combination therapies, I think of the HIV medications that now are a combination of three medications in one tablet or one capsule that can reduce the burden of, oh, I got to take all these medications. Instead of taking 3, I'm only going to take 1. I can do that. So the benefits of adherence, the benefits are monitoring of adherence and the condition, simpler medication regimens. Again, instead of taking three pills, now you have a combination medication, you can take one. And individualized plans to improve adherence. And I'm going to scroll down here. Let's see if I can find what I'm looking for. So electronic health records can help. Especially with medication reconciliation.
4 minutes, Barbara.
Gotcha. I'm almost out of here. So in summary, medication non-adherence is probably one of the highest priority safety issues that we have in patient care. Nurses can be employed. AI, thank you for all the AI stuff this morning. That was wonderful. When the nurse goes into the resident's home, they can reconcile the medications with what the instructions are and how many pills should be left in the bottle. And then they can identify and intervene when concerns about non-adherence arise. And I say it's not just nurses. It can be family members who go in and see that, mom isn't taking she's got pills left over every day. She's not taking her pills as necessary. Contact the healthcare provider, contact the home health nurse to make sure that somebody knows about this and orders can be placed. Okay, these are all references. Come on. And that's the end of that. Thank you so much for listening. Get out of here.
All right, Barbara, you have trained me well, so I give you a certificate.
Oh boy.
Here you are.
Wow.
You get to be on camera. Where's our photographer? Max. Come on out. I have a
Lower.
microphone.
Laura, you're right
Lower.
short.
Okay.
Thank you.
Thanks.
All right. Thank you very much, Barbara. You get to keep that. Yes. All right, while that's happening, I am going to have my biggest challenge of the day, which is to pronounce the name of Mr. Shanmugavalan Ramakrishnan. How badly did I do?
You did great.
Oh, okay, all right. Wow, thank you very much. Shanmugavalan, you'll be coming up to the stage in a minute here. Hang on one second. You may not want your edge in front of your presentation. Okay, Sean McGowan is from Shine Tech Incorporated, guardian of health, ensuring patient safety in a digitally connected healthcare environment. And apparently he's also a professional photographer as well. All right, so you'll do 20 minutes.
Great, thank you.
Give you a warning at 5.
All right, great. Thank you. All right. Good afternoon, everyone. Okay. I just wanted to see how many of you are still awake. It's still good morning. All right. So I'm going to tell the hospital administrators and the nurse practitioners, all the clinical practitioners, how to save about $150 million a year, and the rest of the clinical practitioners how to be a superhero wearing a scrub um, outside of your job within the hospital. Now, if you're all wondering who is this crazy bug that has walked into a room filled with clinical practitioners trying to save lives, teaching them how to save money. Well, my name is Shanmugavelan Ramakrishnan. I'm originally from India, but I've been here in the States for the last 10 years and about 3 years in UK before that, practicing risk management. I work for ShineTech. It's a startup company trying to empower all the organizations, including within the domain of healthcare, on streamlining cybersecurity services. All right. So, what is cybersecurity? Passwords, firewalls, identity protection. Let's forget about all the technical jargon for a minute, right? It's about protecting everything you rely on to provide care, whether that's a patient's lab results, whether that's a digital X-ray image, whether that's a smart infusion pump, delivering precise medication doses. Cybersecurity ensures three critical things. Availability, so to make sure that the systems are up whenever you need them, no delays in accessing the healthcare records. Confidentiality, patient information stays private. No breaches, no unauthorized people accessing these records. And integrity, right? The data is accurate and trustworthy. The dosage you have diagnosed is the dosage that is entered into the system, is the same dosage that you would see when you're designating the dosage to the patient. Imagine, right? Like you have entered a dosage, you have diagnosed the patient with the dosage, you have entered the dosage, and that data is being tampered with. Somebody has entered the system, changed the dosage, and the nurse practitioner by the ICU, sees a different dosage and has awarded that dosage to the patient. Imagine the colossal damage that would have caused, that would have happened, right? So, what is a digitally connected environment in healthcare, right? Think about electronic health records. That one is most of you would have known. Think about the infusion pumps, the digitally connected infusion pump that is, sending the IV to the patient. Think about the remote patient monitoring systems that you're all accessing on a daily basis. Think about the telehealth infrastructure, and think about the smart hospital beds. Guess what? Everything is connected to the internet, and everything is hackable. So why this matter, right? Like why this would matter to clinical practitioners? Now think about it, right? Would you let a stranger access your patient's ICU room while you're not there, or even while you're there, right? Imagine an unattended medical cart that's left inside the ICU with a key card of a nurse practitioner or any clinical practitioner for that matter available to access that card while that personnel is not present. Now, think about the digital hospital, right? Like it's a double-edged sword, right? Like while there are benefits of digital healthcare, that you can, the EHRs reduce medication errors, as the studies point out. Remote monitoring system saves lives because, guess what? While in the span of time that you take to travel to a hospital, you could have gotten care already with telehealth. But it also brings out the risks, right? Cyber attacks can shut down systems, like it can cause power outage during a code blue. Hackers can steal the data to commit insurance fraud. Last week, somebody tried to open a credit card in my name. I mean, I'm not disappointed that they opened a credit card. I'm just disappointed they did not send it to me. It went to somebody else, right? So they can tamper with health records, lab reports leading to wrong diagnosis, and change the dosage that we talked about earlier, causing colossal damage. Okay, so I come back to the cost that I'm really interested in, right? So here's the real world case study. About 19,000 patient appointments in UK were cancelled back in 2021. Computers locked out, denying access to critical care to a lot of people. A lot of chemotherapy appointments were cancelled as part of that as well. Like, you would think, what would be the root cause that led to cancellation of 19,000 appointments? Well, old computer systems were not upgraded. They were still using Windows XP machines. A great job, NHS. Systems were not patched regularly, of course, when your old systems were not upgraded. They've hit the end of shelf life, which means no security patches are available. And guess what? You have not patched any of these systems. And this one's my favorite. Antivirus systems were not kept up to date, causing a WannaCry style attack. It's a ransomware attack where the hacker takes control of your healthcare network and asks you to pay in bitcoins. This impacted 35% of all NHS hospitals. The cost was estimated to be 92 million British pounds. Attackers demanded Bitcoin, and nurses used paper charts for weeks until the service was restored. So how do these hackers enter into our environments, right? And here are the healthcare entry points for these hackers, right? Usually they try to enter into an attack mode called phishing, right? You might have all seen this with scammers trying to call you up, selling you a service that's too good to be true. And the moment you provide the credit card, money is gone, right? It's a similar style of attack. So these are fake emails trying to pretend that either your passwords expired or try to create a sense of urgency, right? Once the nurse or a clinical practitioner clicks, the hacker tries to install a malware. It's an automatic bot that tries to steal information from within your computer. You don't have to do anything here. And there are weak passwords, right? Like spring 2025 or summer 2025 is cracked in 1 second. I put this entire deck manually. It took me about 5 hours, and I could still crack that password within 1 second.
Wow.
Think about in an AI age where my friend here has put together her entire presentation automatically using augmentative technologies. think about how much of time it would take for an AI empowered system to crack your passwords. And then unpatched devices, right? Like these are like using expired medications, right? Old software, always has known flaws. They moved on to better softwares for a reason, which is to, not let these flaws continue. So you all continuing to use an old system means that you are, not addressing that risk, but are continuing to live with that risk. It's always open to it's the stories that the hackers would love to hear. So here's the anatomy. Let me break this to you again. Here's the anatomy of healthcare cyber attack. So usually it has a phishing email, which creates an urgency, and it always throws you a link to click on. Then there is a malware download piece. Once you click that link on, the malware gets automatically downloaded and gets executed inside your computer, which can read your keystrokes. So guess what? You try to enter into your hospital network, trying to enter your username and password, which you think is secure and private. Now that malware can transfer all of that information over to the hacker that's sitting thousands of miles away. Now, once the hacker has gained your access, you don't need to be an administrator who can award elevated privileges to access these records. The hacker knows his way, and he can laterally move through within your system, trying to elevate his privileges. And once he gets enough privileges to lock down your system, he will lock all of you out of that system. That's what happened with the case in NHS. So let's see, right? Like here's an exercise to all of you, right? Let's see if you could spot a phishing email. This is a phishing email. Let's see how you would spot it, right? Like there is a from your IT department. There is a to your email at hospital.com. The subject says, urgent, Dr. Smith needs you to review a patient chart right away, right? And it says, dear user, Dr. Smith needs you to review a patient chart. Click here, regards administrator. Let me ask you all, what are the risks you see here? Feel free to comment. Yeah, go for it. Yes. Absolutely right. Yeah, there is a typo. Yeah. Okay. Anybody else? Any other tries? What are the risks in this email? Perfect. It addresses dear user. It's addressed to general audience. It's not addressed to you. Okay. Anybody else? Any other tries? Yes. Perfect, right? Nobody would put a click here link, but if at all a click here comes, right, always scroll over that click here part, and this is a presentation, but yeah, it's going to show you, if you scroll over that click here, it'll show you the actual link that it is going to take you to, which says malwaredownloadnow.com, right? So I'm just joking. It wouldn't tell you explicitly that it's going to take you to malwaredownload.com, but it's going to take you out of your hospital network, which, and you don't have to click. You can just scroll over and see where that's going to take you to. Okay, there is one more risk in this email. Yeah, I think. Sorry, what's that? Who's what? That's a good one, right? Yeah, I didn't think of that, but yeah, it just says just review a patient's chart. It doesn't call the patient's name there. And the other risk that you all should be aware of is the urgency that it's trying to create, right? Like if it's so urgent, the doctor would come down to you or call you to review something. It's trying to create a sense of urgency there. So here, that's That's how you spot a phishing email. Okay. Moving on. So here are the medical devices, right? These are the silent vulnerabilities, right? So all the IV pumps, pacemakers, imaging machines, they all run on software. And we have to get away from this notion that everything is built, extremely securely, right? And we all have to do our part in creating a secure environment, despite the fact whether that software is built securely or not, right? Because we don't know what happened behind the scenes. We don't know which software developer built, but what we know is what we do on a daily basis. So that part we can all control. So I think a couple of years ago, Hospira pump was hacked to deliver fatal doses, right? And FDA had issued a warning about that. And why? Because default passwords, like admin, for instance, are never changed. So, again, so the call here is for you all to be the human firewall, right? Like you protect the patients, right? There are 3 rules, right? Stop and think before you click, and report any odd behavior, right? Slow computers,
4 minutes.
slow computers are always equal to possible malware. Now, if you're all playing video games on a $200 Chromebook, and if your Chromebook is acting slow, then that's not due to malware, right? Just so you all know. And never share passwords, right? Even with folks from IT calling you directly, asking you to share your passwords. Nobody asks passwords, do not share. Okay. So password hygiene is like hand hygiene, right? So Nose Jenny 2024, 2025, that's not a good password, right? Because it contains your personal information. And anytime you have personal information inside your passwords, the hacker has to work less to crack your passwords down, right? So a good password usually would contain a mix of letters, symbols, and numbers, right? And I think a few years ago, when I was reading some novel, it said that the world is moving away from passwords to passphrases. So, so that is one example of that. So you can remember that easily, and yet it's complex enough for the hacker to work, days or months, not just hours or seconds. Okay. And I think for the hospital administrators here, use a secure password vault, which keeps changing your secure keys instead of, users having to enter passwords each time. That's, guess what? It's not convenient. And when it is not convenient, people are subject to write it down somewhere, or, put it in a place that is not easier to retrieve, or it is easier to retrieve for the hackers. Okay, so telehealth and home care, they all bring risks, right? Like now, as healthcare practitioners, educate your patients, right, to use secure VPNs while accessing these calls, or to avoid public Wi-Fi's for your appointments. Because guess what? Like I could go on to any of the hotel network here and see what each one of you are doing if I am sophisticated enough. And guess what? Hackers are, right? And this, once again, administrators build a culture of safety here, right? So like fund annual training for your employees on digital security, not just physical security, right? Like imagine, right? Like safety cultures, you all know it produces infections, right? But if you include digital safety culture into your safety cultural practice, then that can reduce cyber risks too, right? So always advocate for training budgets and educate your personnel. So yeah. So there are 3 simple rules: pause before you click, protect your passwords, and speak up when you see or feel something, right? Like, so yeah, again, weak passwords are like masks. Weak ones let the threats in. So, and always be alert. There was a nurse in Mayo Clinic a couple of years ago saved about 10,000 healthcare records from being exposed. So always be alert, be that hero. You can be that hero. The road to top is always lonely, but we all have each other, right? Thank you all. That's it. You can
Thank you, sir. Thank you. Thank you. This was also. Thank you. So, thank you. Excellent. So I'm going to start. My name is Maciej. I'm a physician. However, before I became a physician, I actually used to be a CNA and I used to help out in healthcare in other roles. And I was fortunate enough to get together with a couple of other clinical people, Alvin and Alan, and we started making medical devices. And we're not talking anything cool like AI, nothing as interesting as cybersecurity. We're talking about the bare bones, the actual nitty gritty and unfortunate care that you need to provide to elderly patients or people who are disabled that cannot take care of themselves in terms of their functions, in terms of their essential human functions like urination and bowel movements. So we have more and more people that are older. This is a global phenomenon. A lot of countries in the world right now have a higher death rate than birth rate. Japan comes to mind. Some other places in Europe come to mind. And one of the things that happens as you get older, you can't control your urinary function as well as before. It affects up to 50% of women. Now, I suspect that this data is actually wrong. I suspect that women are more open to discuss their issues when it comes to a medical problem than men, because I think men actually have this problem as well. They just don't want to talk about it. It affects your quality of life. Urinary incontinence can cause problems such as shame. It can cause social isolation. People don't want to go outside and notice that, you wetted yourself, or there might be a malodor or something of that nature. And people tend to hide this. There's a big propensity now of people utilizing adult diapers. Again, I think this is more of a men versus women thing, because women will be more used to wearing a pad or something. They'll be more considerate of it, whereas men are not. But let me go on. Now, this is a big problem for people that go home too from the hospital. When patients are discharged, a lot of times the physician, and I've been guilty of this many times, and I'm sure others have, will not talk about what's going to happen once you get discharged home. Let's say you have a hip replacement. Let's say you had bypass, even something as mundane as new medications that might limit your ability to be mobile, or something that's going to make you go to the bathroom more often. Let's say you're using Lasix or any form of other diuretics for your congestive heart failure, leg swelling, anything else. And unfortunately, people go home and they're not sure on how to deal with this. Most hospital discharge planners don't include any discussion about what to do with just basic functions. So a couple of years ago, this external catheter was developed specifically because there was a family member had a stroke, and the alternatives turned out to be less than adequate. We can talk about the general ones, such as diapers. However, diapers have a higher propensity for dermatitis, urine incontinence associated dermatitis, which also leads to urinary tract infections. They're also actually extremely expensive if you actually look at the cost. They are covered by Medicare, but they're not the best and ideal solution. The big player on the market right now is called PureWick. I don't know if any of you are familiar with it. It's interesting. It was developed by a physician. However, there's two problems with it. One, it was designed to look like a sausage. That's the only way I can describe it. It's a cylinder. It is. It's, if you ever see it, it's really strange, and does not adhere to human anatomy, which is kind of bizarre considering that, it was developed by a physician. The other thing is it has a perpendicular suction on it, which makes it literally suck onto the skin to get the urine out, which the nurses affectionately call the wicky hickey. Unfortunately, it causes a pressure injury. And if you're, I think somebody touched on this actually in one of the earlier presentations, it can cause pressure injuries. Anytime you have a pressure injury, the probability of you having a bigger problem is pretty severe. More people die from pressure injuries per year in the US than car accidents. So it's 40,000 people die from pressure injuries a year. And it's a big problem. The cost is astronomical. So I know we have AI is actually kind of an interesting concept to actually get into pressure injuries, because they can utilize images in order to see if the pressure injury is getting worse or not. But the first thing we should do is prevent the pressure injury in the first place. So the current models out there, like the PureWick, the new Medline product out there, all utilize suction, which is perpendicular to the skin, which causes pressure injuries just from the suction mechanism. So a bunch of us, and I mean, we're all healthcare providers, none of us are business people, and a couple of engineers, we got together and we developed this. It's literally a jock strap. That's the best way to think about it. It covers the entire genital area and actually has a nice barrier that goes right at the perineum. So with a lot of the devices, the PureWick and everything else, fecal matter can travel from the rectum up into the urethra and cause a urinary tract infection. So we prevented that. We actually have a barrier on the bottom there with the perineum. Also, our suction is parallel to the skin. So the urine actually gets collected within the wicking material and then gets suctioned out through the tube. And we started using it on her family members. We actually tested it all out on ourselves. We are FDA registered, so nothing crazy like that. We're not like some, fly by the night outfit. We actually make this in the US, by the way. I'm not trying to sell you the equipment. I'm just trying to give you a little bit of a background, because not too many people know about it. And started spreading by word of mouth, and we are actually selling them now. And we started doing basically a survey, trying to make sure that we are doing the right thing. We're very always eager to talk to everybody. So I want to go through the little bit of a background on our methods. So what we did is, since last year in May to October, we sampled our patients. We asked them to fill out a survey. Most of our patients utilized diapers and PureWicks previously to using our UniSuck, which stands for Universal Suction Urinary Catheter. Alvin, who's originally from Southeast Asia, he named it UniSuck, and he insists that the name is UniSuck, but everybody calls it UniSuck, and they get a big giggle out of it, but it's UniSuck. So just so you're aware, but if you want to call it UniSuck, we're okay with it. So a lot of people get a good laugh out of it. So we asked people to score our UniSuck catheter and PureWick catheter on a scale of 0 to 5. 5 being the best, 0 being the worst. And then we I asked to 100 people, and that's how many people we got to respond to us. And then we utilized appropriate mathematical statistics to check for differences. So most of our respondents were actually over the age of 80, which makes sense because that's when people have the greatest disability. We had a couple of people actually below the age of 60, and we talked to them, and they unfortunately had things like MS and Parkinson's, and they needed to need help. Predominantly, our users are female, and this, I think, goes with the fact that women tend to live longer, just based on the population. Also, I think women tend to be more, again, I think they speak about the problems they have, and they try to find solutions that make sense. And 90% of our users are actually female, which is so fine with us. We don't mind. Our system actually is malleable both for men and women. It's actually completely unlike the other devices out there. You can actually fit it to a person that's very, very skinny, or a person that's very obese, or has scrotal swelling or edema. So it doesn't matter. We asked a couple of people to fill out the survey too. We had quite a few caregivers fill it out, and we had 25% were just the end users without any support. Most of our users are limited mobility. They can do some things, but they cannot get out of bed, or they cannot fully go to the commode or onto the toilet. So we sent out the survey, and actually, really interestingly, I was blown away by this. I have a background in research. 80% of our users were very satisfied with our system, which was really nice to hear. We got a lot of personal thank yous initially, but when we started doing the survey, we really got to see the data out there. Our general comfort, satisfaction, time savings, improved sleep, ease of setup, ease of use, improved dignity, and UTI reduction. We had basically statistical significance and clinical significance over the PureWorks system. And I think it just relates to the fact that our system was designed by clinicians for clinicians and the patients. So I'll go through some of the results. And like I said, some of my presentation is very dry. So if anybody has any questions at any point, feel free to ask. I'll be happy to answer them. So do you have a pointer? No? No. I'll speak louder. Is that okay?
Yes.
So the most important thing for us was the satisfaction. Was the patient satisfied with what they were using? Because we have so many, as clinicians, we know patients hate some of the interventions that we do to them, some of the medications, some of the maneuvers that we have to sometimes do, and sometimes the devices that we use. For us, we had 85% of the people were satisfied or very satisfied with our catheter. Whereas with PureWig, only 24% of the patients were satisfied or very satisfied with the system. They do have a nice distribution in terms of mathematics that basically they go up like this. We have a very skewed distribution towards satisfaction, which is very, very rewarding to us. And we are definitely statistically different. So if anybody just wants to know the statistics, I can talk about that too. And I have a nice little graph showing here the difference between us and PureWig. PureWig did a really cool study approximately 5 years ago where they compared PureWig to diapers and to no intervention. In our data, we looked at diapers as well, and we found the same exact thing. Diapers were better than no intervention. PureWig was better than diapers, but we were better than PureWig. Now, utility scores in terms of the comfort. Once again, this is a question of body habitus and the way people's bodies are shaped. Our device is able to conform to people's body. We actually had a hospital in Rochester asking for it for their pediatric unit. It's totally usable because you can literally squeeze the frame to make it smaller for a person. And our patients really do find it more comfortable than anything else, 91% versus only 33% for 33% for PureWig. So again, clinically and statistically better. So our overall comfort is much better. And again, you can see that distribution, that PureWig has a normal distribution, whereas we have a skewed distribution towards being satisfied more than others. We have an important characteristic, at least for us, it was the dignity, the question of dignity. A lot of times when we do, when we have a intervention in medicine, we don't think about, is this going to be dignified? People identify themselves as somebody that's worthy of having dignity. And a lot of times when we do something in medicine, unfortunately, we don't think about that. With our device, we actually are able to give patients dignity. They can actually feel more appropriate because, like I said, the current devices out there, I mean, the PureWick literally looks like a phallic device. It's just weird. Whereas ours, it looks like an underwear and you can put it on. And it came out in the results of our study. Patients felt much better about it. We also looked at some other things that are important to clinicians, to the physicians out there and the nurses. First of all, our dryness levels were much higher than PureWick. Patients found themselves to be drier at 77% versus 37%. And I think that stems from the fact that our device suction is not perpendicular to the skin, but parallel. We are able to get all the urine out as soon as possible. We actually have videos on YouTube where we show where we dump like a liter of fluid into the crotch area and it gets suctioned out really quickly. I think it takes approximately 30 minutes for the entire crotch area to dry with our system. So there's actually no residual urine. It's really cool. And then you only have to change the liner, the diaper of it every 12 hours. So it's really nice for nurses. So there's less work. And we are literally cheaper than both diapers and the PureWick. We are. So it's pretty cool. Also, we noticed because of the dryness, improved sleep. You know, we're talking about one of the first presentations was about relaxation and the stress level. The best meditation you're going to get that's basically natural is your sleep. And if you don't get enough sleep, you're going to be grumpy the next day. You're going to feel crappy. People taking care of you are going to be sleep deprived. And it's just a cascade of unpleasantness that goes down. With our device, 85% people said that they had improved sleep versus 45%, which is still good. I'm not going to disparage PureWick on this. They did improve some sleep, but ours is just basically better. And some more statistics. This one, as a clinician, I personally don't like that much because I wish we could do it in a setting where we could test the urine because this is the perceived reduction in UTIs. But our patients did say that they feel like they had fewer UTIs using our system than other systems such as diapers or no systems at all. PureWick did have a reduction in perceived UTIs as well, which actually goes along with their previously published results. And I think this one is really interesting, especially for the elderly. We had an basically 90% reduction rate in nighttime bathroom trips. Anybody that takes care of the elderly knows that anytime they get up in the middle of the night, there is a risk of some form of fall, anything from a hip fracture, wrist fracture to an intracranial bleed secondary to head trauma. And that's just a cascade for mortality. Because I mean, although it's improved a lot in the last decade, it's still a fairly high chance of dying just from a simple fall and having a broken bone. Whereas if you don't have to get up, it's much better. And I do have to give credit to PureWick as well. They do reduce the nighttime frequency for patients, 72. So it's nothing to sneeze at. So I'm happy that they're doing it. I'm going to talk a little bit about the time savings and the cost efficiency. Patients do find that our device is much better at time savings in terms of their urinary function. And I think it's just because it's so easy to set up. It's literally, like I said, a jock strap. You put it on, you can put your underwear on it. You can put a second diaper on it if you have fecal incontinence. So this way you don't have to do anything with that. PureWick does have time savings, but once again, Unisoc, external catheters, we beat them by quite a bit. Now the cost efficiency, this is where we really kill PureWick because we are way cheaper than they are. Our patients really enjoyed it. They said 74% they thought it was cost efficient, whereas PureWick literally is much more expensive per use than we are. So most of the patients said that it was not cost efficient. Go. And again, I apologize. We have a lot of data, so it's not very sexy. It's not like the AI lecture, which is very interesting. You can talk about, or the IT. Ours is predominantly the results of our study. The ease of setup was, again, rated very high by our patients versus PureWick. I mean, it goes back to the fact that it was designed by clinicians for other caregivers and the patients. It's meant to be as easy as to use as easy as possible. Also, the ease of use, it's literally you just put it on, you contour it to the person's body, you plug in the suction, and you're done.
3 minutes.
Well, thank you. I appreciate it. PureWick is also easy to set up because it's literally a sausage that you place on your genitals. The problem is it just wobbles around, and I know some nurses literally duct tape it in place. Yes. Some people have some very interesting methods to go about it, and unfortunately it still moves around. If the patient tries to lie on their side, it will fall off. If a patient rolls to the other side, it will fall off. Let's say something happens where somebody has to examine their back, any form of other interventions, it will roll off. So the ease of use is simple to place, but it just walks off. So in conclusion, our study validated that our external catheter has a higher ease of use, comfort, reduction in perceived UTIs, nighttime. It's much better than the PureWick. We are going to validate these results, and we're doing outreach to facilities to do trials. We actually had some hospitals buy our product now. Actually, it's kind of funny because the patients insisted when they got into the hospital to not be on the PureWick. And we're trying to get more data. Hopefully, we'd like to get a study done with a total of 2,000 patients, but that's going to come down the road. It's just the 3 of us right now, and we're all still work clinically. So if you have any questions, please let me know. Thank you. Any questions? Yes, ma'am.
The material that you line the brief with,
Yes.
does that create a barrier between the resident or the patient's skin and the wetness?
So it's a one-way material. So it does create it. Once the person expels the urine, it goes through the material into basically the chamber and gets suctioned out. So yes.
That was one question. Thank you.
And it does not get into the clothes because that one is one way, but the blue part is completely impervious to fluids. The fluid actually gets collected down into the bottom. So it's actually gravity dependent initially, and then it's suctioned out. And we've not to sound weird, but because we're not business people, we don't take a salary from this or anything like that. We've actually invested quite a bit of our own money. We have our own machines in Orange County. We actually make it on site.
Oh,
Yeah, we do. We're the janitors, the distributors, everything. And we're very open to any nurse's suggestions. We actually changed our product quite a bit from nurse feedback. Yes, ma'am. I did not. I apologize. Sorry. Look, if you give me information, I will send it to you if you want. So the issue with insurance is if you buy it, you'll have to file the claim with the insurance yourself. We can give you the codes for it. So there's 3 of us. You literally could not have the time. You have all the information. So if somebody wants to file for a reimbursement with the insurance with Medicare, we have actually a patient right now who's asking us. Optum Health they asked for a product, but Optum Health told them to go buy PureWick. And we actually are trying to reach to Optum Health because we're like, look, our product is cheaper and the patient wants it. How do we go about resolving this? But it's trying to deal with the insurance company is like trying to talk to a 2-year-old. It's very strange. So, but yeah, I'll send you some samples. It's not a problem. If anybody else wants any stuff, and again, I'm not here to sell you anything. I'm just here to present the product. Give me your cards and I'll send you any samples you guys want. We also have a bed fan too. That took 3 years to design. We interviewed over 200 nurses when we designed. It's called the Easy Bed Fan. If you ever want to see it. So we cover both number 1 and number 2.
all right. Mr. Ricos, thank you again very much. All right, thank you. Okay, we are moving right on schedule here, and so we have for you Dr. Kevin Kalouris. Kevin is going to be speaking, obviously, about the barriers to communication, improving patient safety. He's from Stanford University, where I'll be tomorrow. And come on up, Kevin. Thank you very much. Use that one.
All right, great. Well, thank you. I hope to not need any of Dr. Whitco's inventions. So let's see. Do I just which button to push to advance?
Let's just get you closer to the mic. Each down. There.
Oh, okay. Great, thanks.
Sure.
All right, so thanks. Little change of pace. This is going to be a little bit about patient safety and how we communicate with patients and the families can improve safety. So just briefly, as was mentioned, I'm at Stanford. I'm both an internist and a pediatrician who does critical care. And I've also, for those of you in public health, also study public health and teach courses in that. So why is this important? Well, much of what we do as clinicians is communication. In the hospital, it's a high acuity setting, especially in children's hospitals. The children who are hospitalized they have complex chronic conditions, and there's a lot of team members involved in their care. And so it requires good communication to make everything come together. So, and because they're in the hospital, the care isn't just Monday through Friday from 8 to 4. It goes through the night, it goes through the weekends, it goes through holidays. And, parents and guardians are going to be coming in and out during that time, and they're going to have questions about what's going on, and they're going to be making decisions. So, have a communication system that allows for flexibility. So, and there's a lot of literature out there in both the adult literature and the pediatric literature to say that good communication is going to improve care, and that if we do this, we're going to do better. A lot of the stuff that's out there in the pediatric literature is focused on what they call the family-centered rounds, or it only looks at specific populations or specific technologies, and a lot of it is also on end-of-life care, which wasn't really what I was focused on. So myself and several others did a project while I was at Yale, where we looked at how we could use the qualitative interview process to discover where kind of we fell short in terms of our communication with families. So what we did was, this was a 19-bed unit. We had a motivated medical student who learned how to do qualitative interviews. And during the period of about 6 months, we set up interviews with families to kind of find out how they perceived our care and communication while they were in the hospital. So, and we looked at, children admitted acutely versus those who had kind of more chronic issues, looked at how long they were staying, whether they were somebody who got admitted frequently, primary language, the ethnicity, race of the family, and also educational background, and tried to make sure that we sampled from all ranges of those spectrums so that we weren't just focused on one type of family. And then we also looked at our staff, because the staff is communicating with the family, so we wanted to see kind of what their perceptions of communication were. So we talked to both nurses, residents, fellows, and attending physicians. And so for those of you who don't know what a qualitative interview is, rather than a survey asks certain questions, and it's either a yes, no, or a Likert scale, and you're getting a range of things. So in a qualitative interview, you go in, you've got some preset ideas about what you want to ask, but you're really trying to leave it open-ended to let the family, the patients guide you in terms of what they want to say. And so it's really that kind of style of like, is there something else, anything more, kind of communication style, where you're really trying to not just shut down what they're saying by saying, okay, great. You're like trying to encourage them to talk more. So it does take a while. But you record this during the time. And actually, from the time we did this to now, there's actually these great transcription apps that you can now use. So you can do these interviews, and rather than having to pay for a service with these apps, which probably have some sort of subscription fee, but for a much lower entry cost, you can now get transcriptions of these interviews, which makes this sort of project much more, the barrier of cost is rapidly diminishing. So as I said, we had these recorded, then transcribed. If we were interviewing a family that didn't speak English as their primary language, we did it in their preferred language and used an interpreter. So we ended up being fairly successful in getting almost 60%, not quite, up to 2/3 of the families agreeing to interview. Our age range was 2 to 8 years old. We had a balance between acute illness versus chronic. We had balances in length of stay and also ethnicity, in terms of about half were white Caucasian. We had about 14% African American, and Latin 21%, Asian 14, and Middle Eastern about 2. So this is just some demographics. Just as I said, we tried to get a range of ages that we were looking at, ranges of languages that were spoken, so it wasn't all just native English speakers. And kind of a mix of, were we talking to all mothers, or were we talking to mothers and fathers? Were we talking to guardians? And then our staff, it was split very evenly between nurses, residents, fellows, and attending physicians. And, a range of experiences of people who had literally, this was their first month in the intensive care unit, to people who'd been doing this for a decade or more. So, and then just the race ethnicities, where it was a predominantly Caucasian white staff. That's the reason behind that. So, as I said, we would do these interviews and try to, ask these open-ended questions about, why do you think your child's here? What do you think we're doing for your child while you're here? Are there things that you feel like we could have been doing better? How do you feel about the communication? Are there things that we're doing that make it hard for you to communicate with us? And then for the staff, we said, kind of the same thing, but, tailored slightly different of, how do you think communication is going? What do you think the issues are? How would you tell us how to do things better? And, are there strengths? We don't want to make it all bad. Are there strengths in the way we communicate? Are there, what are the weaknesses? And so, that was all part of the interview process. And so we came up with, so the way qualitative interviews work is you do all these interviews and you have these transcripts, and then you try to go through them and look for themes. And and then you look at, are those recurring themes? Are those one-time themes? And so one of the ones that came up was seeming like people want to talk, but they're not really communicating, or there's, people asking for information, and then there's like a very long delay in us actually getting back to the families. And so when you have these complex patients and you have all of these consultant specialists coming together, it can become very difficult to get a single message across to families. And this ends up leading to mixed messaging, confusion. And so, part of what we learned from this is that we're all talking to the families, but we're talking about different things. And this ends up resulting in them not being sure of what's actually happening. And so the ways we tried to address this was that, previously we would have like the resident of a service come by, and they would listen and they would gather, and they'll say, okay, I'll get back to you. And then they don't get back to us for half a day, the next day. And we're like, this doesn't work. So we said, okay, when we're involving you in a patient, we're going to meet at this time, and you're going to be empowered to make a decision, so that we could then say, okay, as of 10 a.m., we've met with this service. This is what we're doing with them. And we decided that, because the, attending consultant always wanted to weigh in, and we had to make them give up that control of having the final word to say, okay, I trust this person enough to make a decision on my behalf. We also found, we had a great interpreter service, so we thought. We found out we weren't utilizing it nearly enough. And that what we found when we actually talked to families, that we think they're agreeing, they're like, nodding and saying, oh, okay, yes, yes. And then found out that when we actually talked to them in depth, they didn't know what was going on. So we made it a standing policy to say, okay, at 9:30 a.m., we have 3 Spanish-speaking families. We need you there for rounds to speak with the families right at that time. Or we also had some families speaking Farsi, like arranging for a Farsi interpreter. And we then got Vietnamese. And so just, trying to anticipate that we're going to need those interpreters to help us provide good communication. And in those cases where we didn't have somebody in person, we would use the iPad, kind of video conference interpreter. But we found that the in-person interpreter was far better communication than using the iPad. And we just wanted to make sure that we didn't have residents or somebody trying to translate, but they don't really understand all of what's going on. And so they kind of mistranslate things. The other thing we found out was that, theme 2, like say we're going to do X, Y, and Z, and then we do X and Y, and Z never happens. And then the family's like, well, why didn't Z happen? And so we realized we needed to do a better job of when we got to, decision points, branches in a patient's care, and we decided something different, that we needed to go back and communicate that with the family and not just let them think we didn't do what we said we were going to do. So it was really more this touching base with families in the afternoon to say, hey, this is what happens. This is what we've, gotten as results. So now we're going to do this differently than what we said this morning. So it was just really learning that the lack of communication after rounds left parents thinking that things weren't done when in fact plans had changed. And then, as I said, from this, there's this huge emphasis on family-centered rounds, and that, have the family involved and do all this. But so we thought we were checking that box in terms of communication, but what we learned was that that wasn't enough, that we needed to go back in the afternoon or the evening and talk with the families or give them a call to let them know what had changed. And so, the other thing we found was that, I don't know how many of you are in inpatient settings, but, you ask a family to be part of rounds and, it's a kid getting a major surgery, and there's literally 20 people standing outside the room ready to talk about the child, and the parents like, I got nothing. They're just not comfortable talking about all the things that they want to bring up. So what we learned as a result of that was that to go back into the rooms, just 1 or 2 physicians by themselves to say, okay, we did rounds and such. Just wanted to find out, did we address what the questions you had for us today? Do you have clarity on what's going to happen? And so we found just that little extra step did a remarkable job in terms of improving our communication with families. And then, like I said, we did that, and we also, the changes that came about as a result of this were going back in the afternoons or even in the evenings to say, hey, this happened today. This is how your child has responded, or these are the results we've gotten back. We need to adjust what we're doing, and we want to make sure you're aware of what's being changed. The other thing was, parents felt ignored. Like, they're living, some of these children are born with congenital defects, and, it's like a 1 in 50,000 patients who have this. And so the parents become like these experts in their child, and that they felt that the medical professionals ended up ignoring what they had to say about their child. So what we did is we tried to make sure that we acknowledged what the parents had to say about their child. We didn't necessarily agree with their, statements, but we had to at least acknowledge that they had a perspective on what was going on with their child, and we had ours, and see if we could come together for kind of a shared consensus on what would be best. And the medical providers, when we did these interviews, we were really blind to this as a problem, that we didn't realize how much we were ignoring what families had to say about their children. So the way we did this was we, said, okay, yeah, we know you're with your, I come in here, I examine your child. That takes me, 10 minutes. I then get reports from my team throughout the day, but you live with your child, you're in with this child all the time. So you know your child best, what is it you're perceiving about what's going on? And so, and this really, families with children with a lot of complex needs become very comfortable in a ICU acute care setting, and they get very nervous about the idea that, okay, there's now not going to be somebody checking on their child every 30 minutes, that now it's kind of like, okay. And we tried to change the way we talked about this, of like, okay, your child's getting better. That means you don't need all of this, because our ultimate goal is to have you at home where there's no medical professionals. And so this is kind of a graded transition out of this, acute chaotic environment. And then, things, because it's a 24/7 operation in a hospital, you can't be there all the time. And so developing ways in which we transferred information so that the next team coming on was aware of what was going on. We ended up, having boards in the room where we would say, what are the goals of the day? And we would write those on there, so that, and then, that the parents knew exactly what we were trying to do. And we, would make sure that the, night team or such would know, like, hey, we did X and Y, we never got to Z. If you can get Z done tonight, that would be amazing. And so that then, the families could see that we were acting as a team. It wasn't just kind of a caretaker role overnight for just emergencies, so that they felt like we were involved all the time.
1 minute left.
Okay. And then, trying to say that, we're not trying to burden the families with, having to take care of their kids, that we're there to take care of their kid. And, but if they see things we're not doing, to please let us know. And so that, and also that, because they might have had the same surgeon for the last 8 years, and that person's away on vacation, like, there's other people equally competent and able to take care of things. And I talked about the handoffs. And as I said, we changed our handoff, and we went through many revisions of that to try to do better in terms of the information, making it concise but not too lengthy. And then, we've ended up publishing some work after this on, how involving the caregivers, how involving the interpreters and such. And we really, not that the Press Gini scores and such are all empowering, but we did see a noticeable improvement in those scores once we had implemented all of these measures in our patients, thinking that their care was satisfactory. With that, this is a picture of when my boys were much smaller. They're now both taller than me. But thank you. And if there's any questions, happy to do my best to answer them. Thank you.
So in a hospital setting, I've come across the same stumbling blocks that you identified.
Oh, great.
One of the things that the hospital changed was empowering the nurses to follow up on lab results, tests, anything like that. And have the ability to then query the team themselves or the unit secretary, checking the orders and saying, oh, well, that NG tube was supposed to be pulled, today. Has anybody done it?
Mhm.
Yeah, I know Stanford. I did my preceptorship there years and years ago. Are the nurses there empowered?
Oh, very empowered.
To really speak that? You're a magnet hospital, correct?
Yeah. So they're very empowered. They're very, they're able to follow up with both the patients to share results and the team to say, hey, Dr. Flores, did you see that blood gas result came back? And so, yes, very good back and forth with making sure that we're sharing information as it's becoming available.
I'm gonna bring the microphone out here because if anybody has any questions, I'd love to hear them as well. But my question, Dr. Caloris, is this: Stanford is pretty much the gold or the platinum standard. How might you advise less well-endowed hospitals to go about some form of this procedure?
I think the biggest one, it's very simple, is just when you're communicating the plan of the day, to write it on a piece of paper or the whiteboard in the patient's room, to just say, today, like if the whole goal of the day is to get the patient out of bed, like out of bed today, or if it's, that we're going to get that equipment delivered so you can go home tomorrow, like making sure the equipment's delivered. And so it's really simple. It just requires follow through.
All right, thank you very much. Let's hear it for Dr. Caloris, please. Remember, applause stimulates blood flow. You all right? Sir. Instagram. All right, thanks. Just speaking to you before you go. Okay, right on, thanks. Okay, oh, and here's your certificate. Okay, Brett, will you come on up? Brett is one of our sponsors for today, or pretty much the sponsor for today. And Max, would you put his presentation on screen, please?
We don't have a presentation.
Oh, okay.
Yeah.
All right then. Well, then Brett is the sales director helping healthcare providers digitize their competency experience. The title of his presentation is Stand Out as an Employer of Choice: How Hospital Leaders Can Build a Powerful Brand to Attract and Retain Talent.
Thank you.
All right.
Yeah, unfortunately, we do not have a full presentation today. The colleague of mine that was supposed to be presenting is unable to make it. So I just wanted to come up here and thank you all, wish you all happy conference, good afternoon, and tell you a little bit about Dossier and why we're here today, and happy to talk to you all during the conference today about our platform and what we do in healthcare. So Dossier is a competency management system. We primarily focus with acute care hospital systems on helping teams transition from paper-based, fragmented competency management setups. So you think about your onboarding, your annual skills evaluations, checklists, unit-based competencies that are being done on paper. We help those teams transition that to a digital platform. So we work with nursing departments, we work with pharmacy, radiology, laboratory, all clinical and non-clinical areas in the hospital, and also in outpatient and ambulatory settings as well, with streamlining the competency process. So this eases the ability for managers and directors and educators to track completion of competencies through our dashboards, and also be more prepared for surveys and audits. So when Joint Commission, DNV, Department of Public Health come into the building and they say, show me these staff members' audits or these staff members' competency transcripts, through Dossier, we allow healthcare departments to be audit ready and be able to pull those surveys or those transcripts in a much easier manner. So that's really what we're helping out with. I'm going to be back there in the corner all day, so feel free to stop by at any time. And I'd love to speak with you all. I know some of you may have more to do with competency management or know the people at your organizations that are involved in that, and some of you may not. But happy to discuss how we're helping healthcare teams with digitizing competencies and getting away from paper. So I appreciate you all, and thank you for allowing us to sponsor the event. And I hope it's a successful day for you all. Thank you.
Right. You do certificate.
Wow.
You're special.
I am.
Well, we're actually ahead of schedule. Just setting up lunch. Frank has run down the hallway. We would like to get a group picture. But I think if we can wait for Frank to come back, that will be great. If I start yelling, Frank, Frank.
Yeah.
You think I? When we do our photo, if we could stand against that wall there, the big banner, that would be great. So take a few minutes to breathe and mingle, and we'll wait for Frank to return.
All right, everyone, we're gonna gather up for a group photo here. That's beautiful.
These guys.
Let me do 2 rows. So you're in the middle. Come on in, everybody. So we need everybody from here to here. So now you can go.
Short.
Yes. It's true. Okay. Slide. So once it's that far. Well, then we want you sitting. And I was just sitting. You're cold. Well, look at. Thank you. Yeah. Now lunch. Yeah. Yeah. Oh, try it. Right.
You're traveling. Yeah. 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 Yeah, we found about 45 years ago in Oslo, Norway. Yeah. Like, okay, let's go.
Okay. So
I'm.
I talk about comedy videos, but my presentation, I don't have a comedy video. So is there a way to go to YouTube on this so that I can play a little funny video? I need a shot of me that is about like that, just from that button up. And
Is the presentation here? Yeah. Oh, okay, so I don't have to bring my laptop.
so is it from here up? So it should be about here to here, just like that. Yeah. Yeah. It's perfectly well. Great. Okay. Smells.
Yeah. Here I went twice. Yeah. We mentioned August, remember that? It's a perfect move.
Ladies and gentlemen, if you could get your attention, we're gonna go ahead and continue on here. We're gonna get done early today. Anybody wanting to go to Fisherman's Wharf and eat?
Yeah.
All right, I'm there with you. It's not, listen. So welcome back. I hope everybody had a good lunch. I think this morning went very well. And that's a good picture. I would like to introduce our first speaker for the afternoon, Dr. Carlos Archiacati. He's going to talk to us today about the social determinants of health and the effect of readmission risk and surgical needs. Carlos?
And then we get started. Okay. I can do without the slides here. So it's just a regular. Okay, like without the notes. If not, it's okay. Well, good afternoon, everyone. If the worst thing is to speak before lunch because everybody's hungry. The second worst thing is after lunch when the blood flow is going to the GI tract and not to the brain. But anyway, we're here. This is something that I have spoken multiple times before. I hope you guys enjoyed. I'm going to try to finish a little bit early, but there's a lot of data here just to entertain some questions. So I'm a pediatric anesthesiologist. I work at the Moore Children's Hospital that's in Orlando, Florida. To go up and down, just here. Okay. So some of the things that I'll be covering today will be a broad overview of surgical cancellations and post-surgical readmissions or readmission after surgery, overview of social equity factors in health, surgical cancellation due to MPO or fasting guidelines, social determinants of health and the effect of adherence to MPO guidelines, and primary health results of a study that is just coming out very soon. That is a multi-center study that we study this issue in 13 leading children's hospitals across the nation. Post-surgery readmissions and these social determinants of health on post-operative readmission rate. We're going to talk about some cost and review the literature, and I'm going to go over a quality improvement project that I did over a couple of years and share the results. So according to the Kaiser Foundation, in 2022, they did a meta-analysis of about 50 studies, and they determined that a third of the total death in the United States can be influenced by structural social factors. And that include education, race, social support, and poverty. And you look at the effect of social and environmental factors on an individual, depending on the area that you live in the country. 80% of your health is determined by social and environmental factors, more than even your own genetics or your own medical predisposition. So this is about MPO, fasting guidelines. This is very important because we want to decrease the risk of aspiration. Someone is going for surgery, so it's not that we anesthesiologists we want to be mean to you. We just want to be sure that you're safe during surgery and during anesthesia. If patients do not come with adequate fasting, that can lead to delays in surgery or even cancellation of surgery. And that has a very negative economic and emotional impact and impact of health because the surgery now will be either delayed or postponed for another day. It does have an institutional impact because of the staffing models. Now you have to readjust if surgeries have been canceled or postponed for later on today. Cost of delays and cancellations, in addition to wastage of hospital resources, so that has a significant cost on hospital systems. It has also psychological stress on families, but also can cost families if they took the day off for surgery. Now half of the time they don't get paid this day off, and so definitely have more not only expense on the hospital system but on the families. This is the cost of surgical cancellations in different areas of the world. The UK is about $400 million a year. They have probably a little bit better ways to kind of help their patients to show up for surgery with the adequate fasting. In the EU, it's about $1 billion. But look at the United States, up to $10 billion. I mean, I know the population of the EU and the US is almost equivalent, but you can see the difference in cost just from surgical cancellations alone. And somebody remember COVID and all the shutdown that we had to do in the operating rooms, that cost about $13 to $18 billion a month when we shut down the full ORs across the United States. This is a study from the Indian literature, kind of looking, this is in pediatric patients and pediatrics, so most of the data that I'm going to be showing is about pediatrics, but you can extrapolate a little bit in adults too. You can see the most important factor for us to cancel surgeries because the patient has upper respiratory infection, very common in kids. Also, shortage of time, meaning the surgeries are longer than expected, therefore there's no time to do the surgery, so that could be a reason for cancellation. For adequate enough fasting is about 1.5, 1.8, 1.6%. Just to give it in that perspective, that number is about that. In most institutions, it can be as low as 0.4%. This is a study about NPO violations depending on the social determinants of health. This is from the ENT literature, and they saw that children that are Spanish speaking, this is accounting for one of the social determinants, in this case is language spoken at home. They accounted for about 22% of the cancellations, even that the patient population accounted for only 11%. So it's more common in people that have a non-English language at home. This is a good friend of mine, Dr. Tobias, in North Carolina. When he was at Nationwide Children's in Ohio, they study about 42,000 surgeries, and they have a cancellation rate about 0.4%, which is a little bit in the low side. And about 0.3% of delays due to MPO violations. So in the literature, you're going to see all over the place, somewhere between 0.4 and 10%. Most institutions experiencing about 1 to 1.5%, which is significant. This is, I'm gonna skip this one for the sake of time. This is a study that is gonna be publishing very soon in the Anesthesia and Analgesia Journal. This is something that we did across 13 major children's hospitals across the United States. And I'm gonna show you the preliminary results. It has been accepted, publishing probably this summer, so look out for this. It's gonna be, it's amazing. When you look at all these numbers, when you actually take into consideration the amount of patients across the United States. So age, that's one of the social determinants of health. As you can see, most of the patients that get canceled surgery, those are younger than 5. And you can see highlighted there the percentage, and that you can have also, it was found to be statistically significant. When I look at the numbers of the whole population, they're very similar to what I'm showing today. This is almost like 2/3 of the data. In terms of gender, no difference. And we've seen this across the board in all the children's hospitals when we look at them individually. When we look about race and ethnicity, definitely what we call non-whites have a higher percentage of being not being MPO compliant or fasting compliant for surgery. When we look at insurance, when we talk about public insurance, Medicaid or public or government sponsored insurance, you can see the percentage is extremely high in those that have public insurance compared to those that have private. So social determinants of, so that's about the MPO time, the MPO violations. So you can see that certain factors can influence social determinants of health, the increase in amount of MPO violation, which can lead, as I mentioned before, lead to cancellations, delay of surgery, of course, delay of care for that patient. So we looked also at another thing that is very important, especially when hospitals get audited by some of the government parties that frequently do our visits every 2 or 3 years, is this post-surgery readmission risk. And why that is important, because those admissions, they don't get paid. The insurance is bundled in the United States. That means they pay for your surgery. If whatever happened afterwards, even if you went to the ICU and cost $1 million, they're not going to reimburse you. So this is a significant source of revenue losses for the hospitals. That is a reason for us to kind of be very vigilant about this and be sure that we can do everything we can, not because of the cost, but also because what's right for the patient. So that's something that I always talk. People, when they talk about topics like this, they talk about what is just, what's right for the patient, but also try to make an economic argument to the equation. As I said, readmission risk is something that can impact the health of the patient and patient outcomes. As a financial impact, you can see, depending on the government agency, it's about, we're going to use the 30-day readmission rate. It can be 30 days, it can be 90 days, or even 365 days. But for our purposes here, it will be 30 days. The door open and got it. Yeah, please. Thank you. So it's about $41 billion, $2.5 billion in pediatric hospitals. So we're talking about a tremendous amount of cost. And again, this goes mostly unreimbursed by insurance companies. So it's a significant impact on hospital systems. In addition to that, of course, it can increase the hospital workload. You were planning X patients, now you have an increase in 10 or 15% of readmission rates. That means you have 10% more patients. That means you need more staffing, you need more medications and all that. So it can affect and disrupt hospital operations. This is kind of what we have seen across the literature in terms of the rate for readmission. You look at adults somewhere about 14%, which is very high. We're talking about 1 in 6 patients, almost 25 patients get readmitted. That's significant. In pediatrics, thank goodness, it's a little bit lower, somewhere between 4.5 and 8.2%. If you look at another agency, a federal agency, it's about adults, about 14%. Medicaid, which is a proxy for children, is about 10%. So pretty much similar rates. This is a study about from JAMA looking at readmission rate. They're using here 365 days in terms of 30 days, and they noticed it was significantly higher in those patients that are not Hispanic Black children compared to Hispanic children and other populations. So this is something that has been in the literature for a while. I'm going to be showing you some data how this is actually presented in our own institutions. This is a little complicated. All I want you to do is look at this area here. depending on the comorbidities. So patients that have multiple comorbidities, the readmission rate increases depending on the number of comorbidities. If you see one, we're talking about double. 2 times. If we're talking about 2 comorbidities, we're talking about 4 times the risk for readmission. We're talking about 3 or more comorbidities. We're talking about 6 times more readmissions than your average rate. So this is a quality improvement project that I have planning to publish sometime soon. We did it between 2019 and 2021. So our hospital system is the largest pediatric provider in the East Coast of the United States. We have 2 major hospitals, one in Wilmington, Delaware, which is close to Washington, D.C., one in Orlando, Florida, where Disney World is located. So this is the data looking at multi-center, multi-state data from our own institution. This is something to show you the geography of the area, why this has a significant impact depending on how far you're located from the hospital system and the care that you need. So in Orlando, you see that little star. So Hispanic household is a kind of orangey color. African-American households is about that kind of gold yellow color. And you can see Orlando, see the star, is located in an area that is very centralized, good roads, good, but also is between 2 large pockets of Hispanic households. When you look at Delaware is a very small state, a very low population. So most of the patients come from the Philadelphia, South Jersey area to come for care. So you see the distance, number one. Number two, you see there's largely African-American households that feed the system in Delaware. And again, that has some implications that you'll see later in some of the numbers I'm going to show. So we looked at close to about over 60,000 surgeries over this period. And we look at social determinants of health, the normal ones that you see in any medical record. We're talking about gender, race, ethnicity, and language. But we also added some ones that we actually call the patients and ask them about this reality within the family household, which is access to primary doctor after hours, access to transportation after hours, access to prescription after hours, and the highest level of education of the primary caretaker. And these are the numbers. So our organization baseline was 8.3%, which is in line with what we see in the pediatric literature, between 4 and 8.8%. So just keep that 8% in mind. When we talk about some numbers later, it will be reference to that 8% baseline. So this is the analysis. So we look about the period of time in terms of the most common services that will have readmission, pretty much follow how common the surgeries are. The most common the surgeries, of course, the higher readmission rate. The readmission rate is in this first column here. And some of the services are more significant statistically than others, but in generally, they tend to follow the most common type of surgery. The more common the surgery, the most likely that you're going to have as readmission because of the higher number of surgeries. When we look about the diagnosis, this is very interesting. Just pay attention to this and you'll say, what am I missing here? What happened? The most common cause of looking at 2 large 60,000 surgeries, 2 large hospital systems, fever is the number 1 cause for patients to come back and be readmitted to the hospital. Tonsillectomy bleed. We do a lot of tonsillectomy. ENTs have bread and butter what the type of surgery that we do. Dehydration, respiratory distress, constipation, vomiting, pain. All those highlighted, you think about there's something we can do preventive about it. You know, we can treat the fever. We can have good instructions about pain management. We can say, hey, you have vomiting, maybe prescribe something, maybe have a way for patients to escalate this. All these things that clog our hospital system with readmission are preventable in most of these cases. So the analysis, in terms of gender, as we saw before, no difference in gender in terms of one gender having a higher readmission rate. When we look at race, you can see statistically significant patients that are Black or African American, and patients that are multiracial have a significant increased rate of readmissions. Remember that 8% baseline. You can see for African American patients, is about 9.5% and multiracial about 11.2%. Again, this was found to be statistically significant. What we saw in that's the reason I showed you the geography and the map of where this hospital are located, that in Orlando, Florida, actually our rate is 6.5% for African Americans compared for Wilmington, Delaware is 11.1%. What I'm trying to show with this, that even within the same hospital system, there's gonna be some regional differences that you need to pay attention. You need to customize your reality to your own institution. Know what's happening out there. Yes.
Am I missing Hispanic on this list?
No, because that goes in ethnicity. Next slide. Ethnicity. Higher in Hispanic households. 10.3%. It was found to be statistically significant. So the way that these questions are answered is Hispanic whites, non-Hispanic whites, and things like that. They tend to put Hispanic not as a race, but as an ethnicity. So again, yes, you're right. So language spoken at home. What we notice is 85% of Hispanic household, which is our number one ethnicity in Florida, of course, and even across the United States, is that 85% of the households speak English as the primary language at home. So that's the reason we don't see that much of an issue with the language, but we still wanted to consider that. So when we actually study this, statistically significant 10% for those who speak Spanish, and 29% for those who speak Chinese Mandarin. Again, it's not about second a non-English language. Sometimes it can be different between one language and the other. Now, the percentage for Portuguese is higher compared to the 8% baseline, but there was only 4 patients, so it was a very low number. So that's the reason I pulled down the statistical significance. But my guess is more numbers we'll see an effect of the language. Access to transportation, cannot emphasize anymore. This is the big one. And it's something that we can do something about it, especially leveraging technology. And then, so again, the readmission rate from the 8% went to 14.4%, and that was found to be statistically significant. Look at the difference in the regional differences. That's the reason I showed you the map. Orlando, good roads, not complicated geography, 9.7% is still higher. You lack transportation, but look at Delaware, 25%. Why? Those patients are coming from 2 hours away from Southern New Jersey, Philadelphia metro area. Again, customize the realities to your own specific institution.
Carlos, how are you defining transportation enterprise?
Enterprise, when I say the word enterprise, is our healthcare system. We call it enterprise. That's the combined from the 2 hospital systems that we studied. It's not it's not a brand, but yeah. Access to prescription after hours. It was higher, 10 point, almost 11%, but it was not found to be statistically significant. We just don't prescribe much in pediatric patients. They tend to have a lower, especially the little ones. What you do is Tylenol and ibuprofen, or acetaminophen or Panadol. And ibuprofen, it's not like we use narcotics a lot, and opioids a lot in very young populations. So that's the reason prescriptions is not that common. Like in adults, they send you home with like 3 or 4 prescriptions after surgery. In pediatric patients, very rare that we send patients home with a prescription. Access to primary care, again, a little bit higher, but it was not found to be statistically significant. Higher level of education. This was very interesting. You will expect the lower level of education, like 8th grade or less, that will have a higher readmission rate, which is from 8% to 10%. That was found to be statistically significant. But look at patients that have family, the primary caretaker, have a doctoral or master's degree. It's almost like a protective. So the readmission rate is lower, 5%, 6% from the 8% baseline. It makes sense. You know, you have a more affluent household, you have a higher degree, you know what to do, you know who to call, you have more resources to tap into. But we hypothesized that it makes sense, but we have to measure it. And when we measure it, definitely there was an element there, and it makes sense. I mean, when something happened with my kids, I just take care of myself. So I'm a physician. But imagine someone without that, any little thing is something that they're going to blow up, and they go to Dr. Google, and Dr. Google say, this could be the worst possible outcomes and conditions that you can imagine. And what do? They go back to the ER and say, I think my kid is having cancer. So it's just the way it is. So again, it makes sense, but we wanted to measure it. Comorbidities, again, it's pretty much across, and if you have a comorbidity like I showed before, it will increase your readmission risk. So it's pretty much across the board. So that's the reason there was no statistically significant, because pretty much everything will go up. But we put comorbidities and put another social determinant, in this case, race, African American. You can see that patients with ADHD and asthma have a much higher readmission rate that if they didn't, if they have that comorbidity, and they will be white patients. So again, when you actually put multiple factors together, and I can show you multiple slides, but we don't have the time, about matching different two social determinants of health with each other, you'll see different increase in the readmission rate.
4 minutes.
Yes, perfect. So again, conclusions, what we saw in terms of our rate is pretty much what has been described in the literature. In our institutions, the most important social determinant that had an impact was race, ethnicity, access to transportation, and number of comorbidities. When we look at the most common readmission diagnosis, I showed you the slide, we conclude that they're preventable with minor interventions. We observed that there were regional and geographical differences, which I showed you in transportation and in the transportation slide. And we conclude that evaluation and potential interventions to address this disparity should be tailored to the reality of your individual institution. Don't look at the system as a whole, just look at your individual institution. And just personally, we have to do this because it's the right thing for patients. We want the best outcome for the patient. It's just right. But we have to start envisioning the healthcare system as something more like a tech company, that they do something that they reward you if you do the right thing. If you think about it, it all makes sense, but I don't know why healthcare hasn't caught up with technology, even now, so many decades after technology have come out. We need to harness the power of technology to bridge the difference between what is happening inside the hospital and outside the communities. We need to foster some partnership with non-medical companies, technology companies that can help with, for example, transportation, the Ubers, the Lyft of the world, that they have a foundation arm that can help patients actually finance their transportation if they have a problem. And we have to see patient care customized. That's what tech companies are good about. It's what you want, the way that you want it, to the address that you want it, in the time fashion that you want it. And we need to see the healthcare as a continuum. What happens before they come to you and what happens after they leave the hospital. We tend to be focused on what happens within the walls of our own hospital. And I always say healthy people create healthy societies, and healthy societies create prosperous nations. If we want to be a prosperous nation, if we want to be the nation that we want to be, we have to have healthy individuals within our society. And thank you. If there's According to this, I have 3 or 4 minutes, but I mean, I can't say any questions.
Please.
Yes.
We'll start. Oh, I'll go ahead. You start. There you are.
I just have a quick question. Did you guys actually go back and talk to the families that actually caused or brought a patient back to ask them why, in terms of like a detailed interview, not just a questionnaire?
And I know that's your area, which I enjoy very much, your talk. The answer is no. So definitely you measure, and the second part is intervention. So we're doing some intervention, and one thing that we realize is that each of these items that I talked about is a medical record, it's an epic, that we have epic, it's a medical record. So we can actually look at, like you said, look at the individual that had an increase, and we can say this individual had a risk of readmission of 25%. And when you start dissecting out what this patient has a comorbidity, high ADHD, and there's a patient that speaks Chinese Mandarin at home, and then we can actually not only have something that is for everyone, but patients are pooled similarly to each other, but for a specific patient to say you have a higher risk, we can do an individual customized plan for you. But you're right, we're moving into the implementation phase of ideas, but we have a lot of work to do still.
Right.
Do you do that record review pre-operatively?
Pre-operatively, this is all pre-operatively. And then we see what happened afterwards, after the surgery. One thing that we have done is the intake point for most of the surgeries, the clinic level. Patient comes and say, I think I have something, and then they get identified that they need surgery. So we are doing this work now as soon as the patient enters the system through the clinic, not really The days prior to surgery, we call and try to do an intervention. We're trying to do this intervention and measure this as soon as they enter the hospital system. So that has been one of the implementation points.
It is great that we are trying to eliminate the disparity in access to healthcare. Like, besides being just and right thing to do, what is the incentive for folks who are trying to fix the disparity?
I always say that we have to do what's right for the patient, first and foremost. But money talks, especially in the healthcare system in the United States is very insurance driven, cost driven compared to other countries that is a little more, you have a money that is allocated by the government and we treat everybody equally, more, socialized medicine as people call it. I would say that look at the costs. If we can actually cut the readmission rate by just half, we save $20 billion in the healthcare system as a whole. If you look at each institution, it's $2 to $3 million readmission cost per institution that is just given away. Let's reduce it in half. We have $1.5 to $2 million per hospital system. So if this doing the right thing for the patient is not enough for you, there is definite financial incentive.
Dr. Carlos, did you put on screen a distribution of the age demographics of these patients?
Yes, good point. So we treat patients from 0 to 18 years of age. Rarely we have 18 to 21, usually cancer patients, heme patients that we keep them for a little bit longer because they have been in the system for so long. But most of the time, this is just, most of our patients are 0 to 18.
So I can't speak for Delaware, but I know that because you talked about using technology like Uber and Lyft, but there's a company called Waymo that is working in Orlando right now.
I'm sorry, yeah, I heard about that, but I haven't seen it yet.
Oh, they're here too. Well, of course
they're here everywhere.
Yeah, of course.
Yeah.
I'm surprised there are cars with drivers in San Francisco. But they are experimenting in Orlando, to my knowledge, and they're looking for good press, good stories. So just imagine if a Waymo showed up at a kid's door and you get in a driverless car, the kid is going to be very incentivized to do it, and Waymo will be incentivized to, help in the community. So.
Great idea. I will tell you, the kids will jump on it like that. Parents will say, let me think about it. I'm a parent, so thank you so much.
All right, so here, let's get your picture. Okay. Dr. Carlos.
Okay. Thank you.
All right, and let's hear it for Dr. Carlos. Thank you very much. You're welcome. All right, now coming to the stage, I used to work in comedy clubs. This is why I did not go to medical school, much to the chagrin of my parents. Coming to the stage here, we have Ms. Maki Najuka. Ms. Maki Najuka, who is the CEO and founder of Good Neighbor Care Services in California. And her presentation is called Leading with Compassion, Transforming Care Services and Empowering Communities. Let's have some blood flowing applause for her. Thank you very much.
You mind check for more? It's taking the video, was recording myself then. Yes, thank you so much. Thank you. Good afternoon, everyone. My name is Maki Naijuka. I'm the CEO and founder of Good Neighbor Care Services. I'm not out of state, I'm in state. We are based off in California. We service the whole entire California. It's an honor to be here today to represent Good Neighbor. It's a privilege to meet all of you. And I'm gonna speak about today, I want to show how compassionate leadership, especially in home care and nursing, is not just a nice idea, but a critical and a transformative force in American healthcare. Our focus will be on care services, nursing, and patient safety. The agenda, we'll go through the compassionate leadership, how compassionate leadership looks like in healthcare, how home care and nursing are shaping the healthcare landscape, key patient safety strategies, challenges we face and real solutions, case studies from our own agents, Good Neighbor Care Services, and a call to action, of course. Introduction to compassionate leadership. Compassion is not weakness, it's a strategy. When care providers lead with empathy, trust is built, stress is lowered, and outcomes improve. In a time of staffing shortages and burnout, compassionate leadership reduces turnover, increases moral, and promotes holistic patient care. So the Good Neighbor, just before I said Good Neighbor, myself, I was doing it. I'm a CNA, so I would go in and experience the real thing. So it's not that I'm doing something that I've never gone inside to do. So yeah, everything I'm talking about is I've faced it in real lifetime. And I still face it up to now. Literally, before coming here, there was a patient who was like, can you please come? Because my mom, I can only trust you. Do you think you have a good nurse? I'm like, yeah, my nurses are just like me, so don't worry about it. So anyway, so I've witnessed this firsthand during COVID. We saw care teams work with resilience, not because they were forced to, but because they care deeply for their patients and their fellow staff. The role of home care in nursing. Home care is one of the fastest growing sectors in healthcare. Why? Because most patients want to be cared for in the comfort of their homes. Not everyone prefers being in nursing homes. Last week I was with a patient. They'll pay a lot, but they prefer in their home. She's a doctor, she knows exactly what to do, so she prefers nurses coming to her home. It's more safer. And if I had also my parents, I would have them be taken care of from home, not from nursing homes. Yeah. They have their good side and also their pros. I don't want to go there. So yeah, nurses and caregivers become the eyes and ears of the medical system. They notice small changes in a patient's behavior or environment that a doctor might never see in a short hospital visit. That's where real preventative care begins. So for example, when you see for the patients that are in senior living communities, in hospitals, compared to us in the home care sector, we are very preservative. Like we look at everything. We tend to look out on anything. There is changes into this, there is this. But when you go to like maybe senior living communities, there are so many people there and you might skip something. There's something that you might not notice on a patient. For example, during COVID, I remember when we're in these senior living communities, you have so many people you're taking care of. But when you're on one-on-one at home, it's very easy to observe whatever is happening, the changes in their in their lives and all that. It's very easy. It makes life easy. So I think most patients prefer at home. Those who care though, especially their children, because it's always a struggle here and there. So yeah, patient safety strategies in home settings. Safety isn't only about avoiding errors, it's about creating systems that protect and empower patients. In our agency, we implemented daily symptom checks, electronic reporting, and family communication protocols. We also trained our caregivers on how to identify early signs of infection for risk and medication side effects or from the patient's home. I think you can see how easy that can be. Yeah, it's a little bit of course, costly than when you're the other side, but at least it's a one-on-one. It's very easy to supervise and also let me say, if I have my mom in a home, at my home or at her home being taken care of, and at a senior living community or at a nursing home or at a hospital, it's very easy for me to supervise that caregiver, give them instruction like do this, than when it's the other side, you just have to obey whatever you're being told, because really it's not your home. You just have to behave. So yeah, and also of course it comes with challenges and also solutions. When we have caregiver burnout, yes, it's real. I've gone through it. Again, like in COVID, I remember when I used to work for 24 hours non-stop because people were dying and you have to stay and save a life. You burn out, but you signed up for it. So yeah, it's one of the biggest challenges we have is caregiver burnout, because we literally put ourselves, I don't know if it's the same thing. I'm not a doctor, so I don't know if it's the same thing with that, but we literally put ourselves in their shoes. If they have no hands, we are their hands. If they have no mouth, we are their mouth. Like, we represent them in whichever way, like help them in everything, their activities, daily activities, whatever they need to fulfill, we represent them, we stand in for them. So yeah, doing that, you really have a burnout. I literally have some days when I don't want my phone buzzing or anyone calling my phone. I just want to be quiet because of after giving myself so much out there. Yeah, it's real. I've experienced it firsthand. And again, we have lack of federal home care standards, inadequate reimbursements, but the solutions are also within reach. One, provide emotional support and peer groups for caregivers. If you have somebody who's taking care of someone sick or seniors, they need that emotional support. For example, one of the challenges you find is, of course, Good Neighbor being my business, you have to compare, you have to balance. We have patients, when they're going through pain, they don't care. So we always put ourselves there, like, you know what? You can do to me anything you want. You can tell me anything you want, as long as you feel fine, as long as you feel okay, that's okay. But what do you tell a caregiver who's being, run over? If there's a patient that is running over them, telling them anything, but you have, as an owner, you have to come back and understand your caregivers and tell them like, hey, you know what? You're doing your job right. Just put yourself out there. I remember myself when I was still doing it like on a daily basis. I remember one patient I told, she could tell me whatever she wanted to tell me, but after apologizes, and I was like, you know what? As long as it makes you feel okay, that's okay. But after I'm done with that shift, I need emotional support. So yeah, this is one of the things that we need to support the caregivers, even from home. I don't know if one of you has taken care of your patient, your parents or anyone sick. It's not funny. It's not easy. Yeah, and especially if it has to do with pain, it's not easy. No, it's not. So yeah, provide emotional support and peer groups for caregivers, advocate for stronger regulation and recognition of home care at the policy level, invest in tech tools that improve documentation and reduce human error. I'm gonna tell you something. Okay, it's not something that is already out there. So after working so much with the senior living communities and different patients in nursing homes, I literally came up with these smart incontinent products because I was tired of seeing how much caregivers burn out. You cannot keep track of every patient and know that, okay, this one needs to be changed, this one needs to be changed, this one needs to be changed. But if there is something that can notify you on time, like an RFID chip that reads moisture, temps, and all that, that's easy. It makes life easy. So this is what I mean, that there has to be an invention of tools that can improve documentation and reduce human error. You soon see my products on market for sure. I promise you that, because it's something that I did out of a heart, out of experience, after experiencing what was happening. Patients don't get changed on time. And it's not the caregiver's mistake or the nurses in hospitals. No, it's not. They have a lot to do. They have they have so much work going on. But if there is this notification that is notifying them, at least you keep track. It's like when with my own emails, if let me say if I have a bunch of work going on, I must write something that anything that is very important, I have to write it down and highlight it. It keeps reminding me that you have to do this on this date. Make sure you do it, not later than this date. So if there is such tools, such tech, such solutions in the hospitals, in nursing homes, out there helping caregivers, nurses, even doctors, whoever is responsible to help them, notify them, alert them. There's a way it sensitizes you and helps make your work easier. Yeah, I remember when we used to work in the senior living communities. I'm sorry, because that's where I had my biggest experience with patients and all that. You have literally about 24 patients to take care of on your shift. Tell me how you're going to keep track of everyone needs to be changed. This one needs to shower. Some have mobility challenges. Some this is memory care. Some are for risks. But if you have those notifications, it's very easy. At least you even call for help on time. So yeah, if there can be an invasion of tech tools that can improve documentation and reduce human errors, that would be such a good solution for the challenges going on. Case studies, I'm going to share one quick example of one of our patients. Of course, there are so many solutions that we come up with, especially when there's one of recent. She's a cancer patient, so she was throwing up a lot, like the whole night throwing up, and we're giving her back-to-back meds, back-to-back. I was like, okay, so she's throwing up and then there's no food and it's back-to-back meds. Doctors, I don't know how you do it, but that's what we're instructed by the doctor to give them meds. Yeah. So one of our caregivers suggested Ensure. Actually, I saw Ensure there. It reminded me of Ensure. So yeah, we suggested Ensure to at least try it because it's one of the common drinks that we give to the patients, and it really helped. So there's always a solution. There's always an answer somewhere, somehow. It might be small, but at least when our caregiver suggested Ensure for the patient, the nausea stopped because it was as a result of not eating anything and taking back-to-back meds because she was in excruciating pain, a cancer patient. So yeah, just small solutions, they just add up and bring different solutions and help to the family because the family was helped. They didn't know what to do. It helped them not to take her to the hospital again. And a call to action, whether you're a nurse, administrator, doctor, policymaker, or a caregiver, you have to lead by example. Create a culture of empathy. The field we are in is, I always tell people, it's not about money. No, it's not. It's compassion. It's empathy. If this is life here we're talking about, and anyone can be in their feet, can be in their shoes. You can be there. It's just, as a Christian, I would say it's the grace of God that you're not one of them. So as a leader, you just lead by empathy, by compassion, even towards your employees, the caregivers, the nurses, associates, the ones you're taking care of. They have to see a heart that cares, a heart that is willing to help them. Yeah, and also train your teams on communication and emotional intelligence. It needs somebody who is strong. You don't easily break because you're dealing with different human beings here. You're dealing with different challenges and different problems. You have to be a very strong emotional person, emotionally very strong. But also it's something that you need to pass on onto the caregivers, the nurses, your associates that you're working with, even the people you're treating, because they need it. They might not show you that they need it, but they need it. I've seen a few patients that could never get rid of my agents because of how much I stepped in. Yeah. I could not cure the disease they were having, but at least my emotional support was so strong for them. It was such a hold for them that they felt like, oh, okay, I can fight back and get my life back. I'm not losing my life. Because if somebody who's not going through the same, what you're going through is telling you that you can fight back, then why not? So yeah, and also another one is partner with community-based services like ours, like our agency. advocate for systematic change that uplifts the voices of care workers. As we close, we shape the future of healthcare. Let us not forget that at the heart of every system, every policy, and every institution is a human being. Let us lead with compassion, not just because it's kind, but because it's powerful. Thank you so much. That was my brief speech.
All right, thank you, Maggie. Who has questions for Maggie?
No other questions.
Thank you.
I'm gonna get him. Super.
Thank you, sir.
Anyone else here? Yes.
It's more a discussion rather than a question. Carers burnout is a significant issue for us. And do you have a questionnaire in terms of quantifying the carers burnout in your practice service?
Do I have a what, sorry?
Questionnaire to quantify the amount. I mean, how do you validate? How do you measure
How do we measure them?
carers?
Okay. So one, I don't know if you're talking about the agency care, Good Neighbor Care Services, right?
Right.
It's if you're from here in America, first of all, you have to be fully licensed and registered. The state itself will take you through it. You cannot, yeah.
Yeah, that's a competence issue. And I'm talking about the measuring, for example, in particular, about a person who cares for an individual. How do you measure the carers burnout?
Okay. Through their training.
No, it's been in terms of how severe is their, for example, in terms of identifying their degree of severity, in terms of how they are affected. We do a carers burnout impact questionnaire in Australia. So how it measures is basically it's a more a subjective questionnaire, but in terms of how they are impacted, based on that, you can actually roster them in a way that they can take some time off.
Yes. Oh yeah.
So similar to that, do you have any a questionnaire that you administer?
Yes, we do. Yeah, we do. Yeah. And also, we always have one-on-ones.
Yeah.
And also flexible schedule. Yeah, they are able to choose their own schedule. You don't like it can be like back to back. Yeah, that's the beauty about America. Yeah.
Oh.
Yeah.
There are some very reliable surveys that can be given to staff that rates their burnout.
Yes. Yeah.
One more question in the back. Just pass the microphone back, thanks.
Oh. How do you hire people to have the same compassion as you do? It's not easy to find people who have a lot of compassion. So what's your screening tool, or how do you do that? It's hard to train compassion.
It is, yeah. So like I said, care has to do with compassion. Trust me, if I meet you, if I interview you and I've done it, I'll know you can do it or you cannot do it. Yeah. I don't know how I can explain, but if I meet somebody and sit down with them, I know you can do it or you can do it. It's that simple. Yeah. But also, because some people are always looking for a job and to eat money to feed themselves. So we have different jobs shifts for them. You find this one who needs like a sitter, like a companion, just come watch TV with me. That's something anyone can do. But these that need really like this intense emotional support, it has to be particular trained caregivers. Yeah. Okay.
All right. Maggie, thank you very much. Step out here. And that's for you. Yeah. All right, there. All right, thank you. All right, let's hear it from Maggie again. And I'll put that. All right. And Max, if you can give me a hand with this.
Thank you, Becky. That was really a good presentation. Next, we are going to have our very own Professor Jim Donald. He's going to talk to us today about pioneering the use of humor for scalable, evidence-based therapeutic benefits.
All right, so since I'm the presenter, I also have to do the slide thing here. So first, okay, so since what we're talking about is going to be the use of laughter and humor in the medical environment, let's see if I can get you to experience the recording.
Two more minutes.
No. So as you can see, you're getting a little bit of a smile on your face here, yeah? And that's pretty much what we do. So I'm going to close that and go to my presentation now. And here we are. And let's full screen this. How do we do full screen here? This is what you're for, Max. Come on. Yes. Max, how do we go full screen? One would think slide should do it. This is my presentation there. Okay, great. All right, then. So I'm going to tell you very quickly about myself. I am not someone who is well-versed in medicine. I am the least educated person here in medicine. So hopefully that makes you all feel good about yourselves. I started in New York City working on shows like Saturday Night Live, SNL, and on movies like Ghostbusters. I'm old. And when I was working on SNL, my dear dad was passing from cancer in a hospital. And I wished that there was some way that we could get what we were doing at SNL over to him at the hospital. And of course, in those days, that was impossible. But as Carlos spoke about technology, technology has been improving. And so we're able to do it. And so I formed a company called LaughMD because by then I was a comedy filmmaker making comedy movies for companies like HBO and Showtime. And in doing so, I realized that the best, highest goal, the best thing that I could possibly do with those comedy movies was to play them for patients. And so we ran comedy channels on the TVs at Kaiser Permanente and at Cedars-Sinai in Los Angeles. And that yielded lots of smiles, no data, no money either. So we were told that if we wanted to do this, we needed to have evidence and we needed to make it scalable. So that's pretty much what we did. So what we're conquering right now with LaughMD is stress and pain, both on the provider side and on the patient side. And you've heard many presentations today talk about how stress is something that increases its comorbidity and all the different issues that you know all so well. We all want to have our stress reduced, and we've heard some good presentations today on how to do that, right? Pain is something, well, how many people here enjoy pain? Anyone? No? Okay, great. Well, one person. All right, then. So you'll be very popular late evening. So pain, not something that we want, something we want to lower. And that's what LaughMD has been doing. So this is the team that I've put together. You probably recognize the gentleman with the mustache. That's Dr. Patch Adams. There was a movie starring Robin Williams where he played the famous Dr. Patch Adams, who was the pioneer of using humor with patients. But we've also got Dr. Ron Burke from Johns Hopkins, and you're here from Johns Hopkins. We also have someone here from Dr. Sandra Kufel, who studied at Stanford, and Sandra ran a wing of her hospital down in San Diego before she was 30. She's now raised over $1 billion in healthcare. And then Rick Barnett has been CEO of 5 hospitals. And you know me, and Dr. Amitabh Mazumdar is our chief medical officer. He's an MD. He's an oncologist. He pioneered the use of stem cell research in oncology. He's been a professor at both USC and NYU. So it's a pretty formidable team of folks. And this is why we're doing it, because there are 400 studies that show some ameliorative effect of laughter in one way or another. But after 400 studies, do you know what was done? What action was taken after 400 studies? Nothing. Exactly. Nothing. Nothing was done. There is a channel of comedy videos on the TVs at Cedars-Sinai, but other than that, nothing. Nothing was done. And we all know this is good for us. Laughter is the best medicine is an axiom around the world, in German, in Chinese, in Spanish. We all know this to be true. We know it in our hearts. It's true. So why has nothing been done? We're the first company to try and do something about it. So everything that we hear today is about evidence. Everything Carlos talked about, everything you talked about, everything that we're talking about are studies and evidence. And so it has taken us since 2011 to gather all this evidence, and we're continuing to do so. So here is, for example, the first study that we did when I was a professor at USC in Los Angeles. We brought in healthcare providers, did a before and after study with them, subjective data, but 94% reduction in their stress levels after 60 minutes. But who here has 60 minutes free? If you did, you'd sleep, right? Well, so we did it in 3 minutes when I was now teaching at Chapman University. In 3 minutes, we were able to lower the stress with one funny video, like the little funny baby video that I showed you, a little funny cat video, a little, person falling off a bicycle, that sort of a thing. In 3 minutes, we were able to lower stress statistically significantly by 13%, with an N of over 30 on that one. Then we formed a group at USC, and this is Dr. Jacek Pinsky, who's a pioneer in oncology there at USC. And this group did a study called, Does Viewing Comedy Videos Improve the Patient Experience? And we asked questions such as this. Did you enjoy the videos? Did they improve your mood? Did they alleviate your pain or your stress? These were the results. So that's pretty much close to 100% yes on almost all of the questions. I'll talk about the pain question right here, because 91% of those with pain said it lowered their pain levels. 91% of the patients with pain said it lowered their pain levels. Is that statistically significant? Is that meaningful to you? Okay, one person nodded. I'm grateful for you, sir. 89% said it made them less stressful. How many people would like to see their patients less stressed? Okay, we're up to 4 now. This is good. The rest of you learn from her. All right. So then we did a study at A.T. Still University in Arizona. And at A.T. Still University, you can see the numbers here. This has taken years to gather this, but you can see between the baseline on day 1 and day 28, pain levels in chronic pain patients went from over a 10 to a 4. What does that look like? This. That's what pain levels look like by watching a half an hour of comedy videos that we have curated specifically for this purpose in 28 days. Is there a drug that does this in 28 days? Any drugs? No? Okay, good. But laughter does it. So that's why that's why we're doing what we're doing, just not very well. You'd think we'd be better at this. Microsoft PowerPoint is not responding. Max? So to put it in graphical terms, the difference between a level 10 pain and a level 4 pain is like the difference between getting hit in the head with a hammer or a pillow. Raise your hand if you prefer the former. Oh, you'd rather get hit in the head with a hammer. Okay, you two should talk. She likes pain and you want to get hit in the head with a hammer, so that works. And of course, the PowerPoint crashes during my presentation. I will tell a joke. Let's see. How many terrible presenters does it take to bore an audience? Just one. Yes, exactly. And I'm doing that. And now we have a blank presentation in front of me here. So, oh, thank you, Max. Did you know Max has a degree in this? All right, let's keep going. Yes. Good. Okay. No, it's crashing there again. Go to the next slide.
Yes, if you're applying to show this to someone, you're recording.
I am recording this. Thank God we have an editor on the team because this has crashed twice now. I'm more than halfway through as well. Okay, let's do this. Hold on. Let me do it from here. This is an excellent time to get to know your neighbors, by the way. Yeah, why is this crashing? No, there's 24 slides. So can connect to laptop. Sure. Yes. And HTML. Okay. Sure. I have a computer. Yeah. All right. So here we are again. Great. Okay, so the result of the study, we all talked about how great that was. You were here, you remember. This is the poster from the study. Anybody who wants to run up close and look at that, you're more than welcome. Otherwise, I'll have it on my screen later. And this is the current study that we're doing. This is our team here. That's Dr. Mazumder in the middle there at the Oncology Institute in Glendale, California. And right now we're looking to see if we can reduce pain. USC as part of the Reef Institute there. We're winners of the Association of Applied and Therapeutic Humor Best Business Award, Charm Health, Health 2.0, and yet nobody knows who we are. So this is what we're doing, and I have posters there. I have one sheets for all of you. If you would like this app on your phone, it is in the Apple App Store. You can just get it there, or there's a little QR code. that you can get it off of the sheets that I have out there. And I'd love to help you with it. I am not just the founder, I'm also the tech support guy. So I'll help you get it onto your phone. And we do need your email address in order to give it to you because this is proprietary right now. So this is what we do basically. It's that we're, you can see my pointer, great. So we're asking you to fill out a survey, not you, of course, but the patients. Fill out a survey about their pain status. So in the previous study, it was the McGill pain questionnaire that you're all familiar with. Then watch a half an hour of comedy videos, and then tell us how it went. So these are some of the videos. We have everything from sketch comedy like SNL, classic TV shows like Seinfeld, pranks, stunts, funny babies, funny animals, things that are suitable for non-English speakers as well. So that's the prototype. All of the data that we're collecting at this moment is subjective. However, there is a way to gather objective data, and that is through the use of apps, some of which are invented right here in San Francisco, that will measure your healthcare status. So there's one called Bina, B-I-N-A-H, and Bina is out of Tel Aviv, Israel, and Bina is one of those apps where you just look at your phone and it'll tell your blood pressure, your heart rate, your hemoglobin A1C levels. It's almost miraculous. So with that, and with other facial recognition software, we can not only tell your healthcare status before and after your laughter session, we can show you the difference. We can show you how your blood pressure went down. We can show you the effects of your comedy session. And one of the good things about comedy videos is that it's something that we pull towards ourselves. It's not like homework. You don't look at it as something like, oh, this is a chore, I have to do this. When your mom sends you an email with a video link on it, is it usually a comedy video? Is it usually something funny that a cat did? Yes?
Yep.
Exactly, right? And so comedy is not looked at as a chore. It's looked as something that you pull towards yourself. You will pay money to go to a comedy movie, right? So by being able to measure this, we'll be able to also personalize it and see what works better for you. You may like cat videos. You might like sitcoms. You might like pranks. Now, our target users, obviously you've seen us work with patients, and we're working with patients right now, the Oncology Institute. But for today, our target audience is you. 5 minutes, thank you. You are healthcare professionals. We want you to try this. We want your feedback. We want you to experience less stress. We want you to experience less pain. We want you to hopefully even share this with other folks at your institutions. So this is the competition right now. You can look on the App Store all day long and not find anything like what we're doing. The closest competitors are meditation apps, guided breathing, things like that. As you're seeing here, none, zero have to do with laughter. So we are first in that landscape. And in 2026 and beyond, we want to expand this to millions of patients using agentics, as you've heard, using virtual reality, all kinds of things like that. So that's our roadway, and that's my presentation. Even with the technology break, I'm still early. How about that? So let's take your questions, please. And who's going to run around with a microphone the way I do? All right.
This is great. We know this. We feel this. That's the reason TikTok exists and all that. So I mean, it's no. My question for you: are you having a problem with adoption of this technology in hospital systems or patients at home? Are you making money? How's it going for you?
So honestly, when people hear about this, they want to do it. We are meeting tomorrow with Dr. Brian Lin. You may have heard of Dr. Brian Lin because he is an oncology professor at Stanford who then found out that he had stage 4 cancer. So there's many news reports on him as to how he taught this way oversold out class on oncology, both from the caregiver and patient point of view. So when he heard about this, he didn't ask about the studies. He just looked at our website and said, yeah, okay, great. Okay, here's how we're going to implement this at Stanford. So that's the path that we're having there. it's not a tough thing to get folks interested in. The problem is when you get down to the nitty-gritty of actually having to have the app loaded onto the patient device or having to have the data collection and things like that. And that's when the folks who are more bureaucratic get involved, and then they tend to bog it down and slow it down. So that's been our main stopping point. That, and we're not funded yet. So we can only work with so many facilities so quickly. So I know none of you are entrepreneurs, but that is common here in San Francisco, and we're going to be going out for it. The president of the company, Scott Jensen, he's a lawyer, and he's been raising funds for other companies in the past. So once we have funding, we'll be able to expand much more greatly.
Yeah, the reason I'm asking is just, it is a challenging question, but a good challenge. I mean, I think the other hospitals will leverage the same with using dogs that come to the room and we're Disney, so we have Disney characters to come in, do exactly the same. And the hospital is good with that because first, all these things come very much for free, they're this foundation bringing it. But it is non-controversial. All people like pets, all people like superheroes, all people like Disney characters. But the humor can something that can be good for someone can be offensive for another person.
Absolutely.
So I can see why there's a hesitation on adoption because they don't know what is it they're gonna get and how it's gonna be perceived.
Well, there's two responses to that. One is that, and I'm actually going to show you the app on screen here, one of the joys of using my own computer. The good thing about this is that, first of all, it's a choose your own adventure. So if you like classic TV like Seinfeld or All in the Family or Abbott Elementary, you can watch that, and that might be your cup of tea. If you like kids content, which we have loads of, we have 40,000 videos altogether. So there's SpongeBob, for example. So you're choosing your own adventure. So if you're seeing something offensive, it's because you chose it. But with the facial recognition software that we're going to be adopting, we'll be able to tell from your expression whether you liked it or not. We'll be able to recommend more of the same or less of something you don't like. But we are vetting the videos. There's a team of 4 of us who go through the videos to make sure that they're not offensive. I saw other hands.
Any other questions?
Yes.
Look, that's an excellent presentation. Thank you, because this is more a discussion. Look, laughter is very kind of underplayed, especially within the medical fraternity. As you know, the more serious you are, the more you're considered as wise, and that's been an issue from a medical perspective. And I know in the Eastern cultures, I think there's a lot of clubs in India. They all do that.
Laughter yoga originated.
Yeah, that's right.
Yeah.
But I think this has to be propagated more within the medical industry. The laughter medicine. Really, I think that I loved it seriously. It's such a simple thing. We have it, but we don't want to use it because we are so scared that this is considered as a weakness or even less intelligent as compared to if we display this quality. And that's we need to. This stigma needs to go away within the medical industry or the medical fraternity. I think.
I couldn't agree more, obviously. But there's a couple of studies that show that doctors who use humor in their practice are sued less.
That's a good point.
That's a good point. And we have one more question.
Or
2 more questions.
So in your work, do you identify and focus on the neurotransmitters that are being activated when people are using your app, and are you displaying that in your research and investor presentations, things like that?
Right now, all of our data has been subjective, so we can't go that deep. There's a pioneer by the name of Dr. Lee Burke who actually used EKG caps and blood draws and urine and that sort of a thing with his patients. And they did a comparison of showing people America's Funniest Home Videos versus the violent scenes from Saving Private Ryan. And the difference was very large. The difference is very large. And by measuring vital signs at the Oncology Institute, the way we're doing right now, we're getting closer towards that. Nobody wants to, use an app that has comedy videos on it. Oh, and you have to give blood. That would be a roadblock, I think. Yes. There's one more question there.
Hi. So, like, who are your competitors? What are your threats currently to your business model?
As I showed on the slide, there really are no competitors. The main competition that we hear is, well, why do I need this? I can just watch YouTube myself. And here's the difference. YouTube and Facebook are in the business of capturing your attention and showing you advertisements that relate to your data, right? We're in the business of making you laugh. It's a big difference. Also, if you look at YouTube, first video that you find will probably be very funny. The second video that you find might be maybe funny or unrelated. And the third video will most likely be something that they know is going to trigger negative emotions in you because you are much more likely, according to Facebook and YouTube and those tech companies, to stay involved and engaged with something that elicits negative emotions from. We do the opposite.
Anybody else?
Thanks. I have a quick question here. Laughter yoga has been around for more than 30 years in India. But that's just a comment here.
Mm-hmm.
My question to you is, are the benefits observed as a result of the joy that happens as a result of laughter? Because there's some people who engage in silent laughter. They're just laughing inside. So is it the joy which is invoked, or is it the actual physical process of laughter?
I'm quoting Dr. Sanjay Gupta when he worked with Dr. Lee Berg, and the mere anticipation of laughter produces the same results. And whether that's joy or not, we can't measure emotions, but we can measure laughter, and we can measure the serotonin and dopamine and endorphins that are being raised, and that's been done many times in explorative studies. And we can show that adrenaline and cortisol, that Jason's going to be talking about, can be lowered as well. So that's what we can measure. Thus far, again, it's only been subjective. How do you feel? Soon it'll be objective. And that's kind of where we're going with it. Yeah.
I'm just a bit surprised. There's not much more acceptance, considering that things like dog therapy or pet therapy is very well accepted in the hospitals and oncology.
Right.
So this should be accepted too, considering we have very strong quantitative data. I'm just surprised.
That has been the Sisyphean chore of my life, has been to collect more and more data. So 5 studies, we're on the 6th. We're hearing good things from the NIH, if they still exist in a week, about a study we applied for there as well. And everything is about data and evidence, right? So that's what we're doing. We're collecting data, we're collecting evidence, and once we reach, I would say, the 6th study's results, because the 5th study hasn't been published yet. They're still going through the papers on that one. But once the studies are published, I think that's going to be very helpful. The idea of dogs or clowns or puppies or Disney characters, those are all lovely and wonderful. They're just not scalable. It can only be one dog for one person in one room at a time. This can be all patients at all times using this. And I worked with the clowns at USC at the Norris Cancer Center there. And the clowns themselves were $55 an hour. And there had to be 2 clowns, and there had to be an additional medical person inside the room. And so suddenly you're getting to thousands of dollars per day to maybe hit 8 patients, 10 patients. So this is much, much, much more cost effective, more scalable.
I had a question that I think, I don't know if it's a question or comment. I work with moms having babies, and the first thing that a child wants when they're in pain is their mom. They don't want to laugh. You know, so I think catching it early, like connecting that laughing about this could be good, but sometimes when people say, I'm in pain, that's no laughing matter. You know, so I think there's a disconnect of pain and laughing at the same time. I believe that it is helpful, but I think also that first we have to comfort the person in pain with a mother love and figure, and then laugh about it.
Oh, I agree. And if we can get mothers to hold the phones in front of the kids, even better, right?
Yeah, that would be helpful.
Yeah. And it is an interactive experience, and there are videos for the kids and for the moms on this as well. So, yeah.
A laughing mother would be.
A laughing mother, yes. A laughing mother, yes.
I don't have a question per se, but I have a comment. I feel like if you start like a MD laughter club, patients and patients, and just like some amount of laughter therapy, like I've been a part of laughter club back in India, where people just need a laugh and they don't have a, they don't have an agenda to laugh. They just like somebody starts laughing and then it's like it's contagious. So something like that would be very helpful, not just for the patients, but also for the physicians, because I see that even the physicians here have a lot of stress. So I think it will not just balance the patients, but also balance the physicians work.
Oh, absolutely. And we've worked, the first study that we did at USC was for physicians. The second study was for healthcare providers as well. So we absolutely want to help you for sure. As far as what you're talking about, there is spontaneous laughter that occurs when you see something funny. A little poodle was walking along and the poodle suddenly fell over and did a roll around or something. That would make you laugh. And that is spontaneous laughter. The idea of creating laughter inside of yourself, laughter yoga, self-inspired laughter, it's sometimes called. That is also great. We're happy to have you do that. We just can't do that because we can't just have a command on screen that says laugh now, right? Just laugh for no reason, right? We can't do that. And Americans are unfortunately more cynical than that. So if you tell an American to laugh, they will frown. We're not as nice people as you folks in India, so sorry.
Well, I feel like I've been here for like 10 years now, and this laughter club that I attended, I was like 6 or 8 years old back in India. And it was so awkward for me to see like just go there and somebody starts laughing and then the next person laughs and you have to laugh when you're in that circle.
Oh.
And it was just a great experience to just understand that laughter is contagious and then how quickly you'll catch that is just like it's just very, it's unavoidable.
One of the things that we are going to be doing as we expand is having the ability to share the comedy videos. And statistics show that you are 7 times more likely to laugh when you're in the presence of other people than when you're alone. All right. You might look at something and say, it's pretty funny. Right? But if you're with your partner or your family, then you see something funny, you're much more likely to laugh. It is a absolutely group sort of thing that we do. Laughter dates back to the most primeval of mankind, right? So we are working on ways to be able to share it. And in fact, at one of the Oncology Institute offices, the chemotherapy chairs are in a circle. So it is going to be such a blessing for us when we're able to do that and have everybody see the same video, and you can bounce a video from one person to the other, or just send it to a relative or have them send it back. The interactivity of it, you are absolutely right, is key for this. Yes.
This brings me to the topic of distress screening because I work as a clinical effectiveness consultant for Southern. And I also work on distress screening because any patients that have score over 6 and above need to have like a social worker consult. So I don't know if your studies have gone to that extent, but then you can always look up distress screening and how, like maybe you can compare people's like cancer patients distress screening.
Yes. So as what we're doing right now, if you can see up close, no, but as you can see on screen, this is the study that we're doing right now. It includes the NCCN distress thermometer, It includes the Edmonton Symptom Assessment System Screening Tool, the ESAS, as well, and several other tools that are used for exactly that screening we're doing right now. So you must have gone back in time and been there with us when we started this. Good job.
Anything else?
I just want to say thank you and thank you for bearing with my technical incapabilities. So thank you.
Frankly, what I'm.
Oh. You like it? Thank you, Barbara. All right, thank you.
A round of applause for Professor Klein. Baroness team, I still see faces, a few faces there in the morning, so bravo to your commitment. Okay, so our next speaker, we have, Ms. Fatma Farheen. In a world where data drives all the decisions, healthcare is no exception. And we have strategist Ms. Fatma Farheen joining us. She'll be presenting on optimizing patient care through a data analytics framework.
Thank you for the intro. Good afternoon, all. So I'm Farheen, a senior BI analyst at Johns Hopkins Medicine. I'm a little nervous. This is my first presentation, so bear with me. I'm excited to share how we are leveraging the data analytic platform and how we are improving the patient care at Hopkins. So more about Hopkins. Hopkins is a world-renowned health system based in Baltimore, Maryland, known for its leading medical research, education, and patient care. So we have 6 academic and community hospitals: the main Hopkins Hospital, the Bayview Medical Center, Howard County Medical Center, Sibley Memorial Hospital, Suburban Hospital, and the All Children's Hospital. So the mission of Hopkins is to improve the healthcare of the community and the world by setting the standard of excellence in medical education, research, and clinical care. So diverse and inclusive, Hopkins educates medical students, scientists, healthcare professionals, and the public, conducts biomedical research. So it's known for its world-renowned research. So AI started with Hopkins all around. Okay. Provides patient-centered medicine to prevent, diagnosis, and treat human illness. Nationally ranked, Hopkins is like nationally ranked on the US News and World Reports. The All Children's Hospital is ranked in 11 and number 1 in the Maryland. A little about my analytical team at Hopkins. So there is a wide range of analytical operations that are happening within Hopkins Medicine. So as you can see, we have the research team, quality team, population team, planning and market analysis, the financial team, hospital operations team, and the ambulatory team. So I belong to the hospital operations team, where we deal with a lot of emergency medicine data, the inpatient, outpatient surgeries, the laboratories, the imaging, all those stuff. So I'm going to start by saying some of the patient safety key facts that I pulled out from the World Health Organization. So some of the facts that prevalence of harm in healthcare. So it says like approximately 1 in 10 patients is harmed while receiving their hospital care. And this is more relevant in case of an ED, emergency room, where there is like so much chaos in the room trying to get to the patient. Healthcare associated infections. So approximately 10% of hospitalized patients in low and middle income countries acquire healthcare associated infections. So as you can see, more than 50% of all these harms are preventable. Diagnostic errors. So diagnostic errors is causing in United States alone, it's causing to like 10% of patient deaths, account for and 16 to 7 of all harmful events in hospitals. Medical radiation exposure. So there are more than 3.6 billion X-ray examinations happening annually worldwide. Inappropriate or unskilled use of medical radiation can lead to health hazards both for patient and staff. So as you can see, patient safety is very important. Patient safety relies on how we are collecting the data, how we are storing the data, and how we're actually using the data in terms of like healthcare data. Healthcare data is huge, and nowadays it's like so huge that you can see data everywhere, but it definitely comes with challenges. So I have jotted like 4 challenges out of them. First is the multiple data sources. So when it comes to healthcare, it's not only one location of the data repository where you can just find and go and find all the answers for it. So it's not only the medical record where you can just go in and then get all the information of the patient. There are like multiple data sources like the wearable devices, the insurance, or like the medical records, or like even within the medical records, there might be like the financial billing, all those things. So it's quite challenging to integrate all those multiple data sources as a single source and then try to evaluate what you're trying to find out. The second is unstructured data. As you know, most of the healthcare data like imaging, procedural notes, or like doctor's note that Dr. Wage was saying in the morning. So it was like, it's all unstructured around. Data privacy and security, as you know, challenges with the healthcare data, the privacy and managing sharing of the healthcare data is quite strict, and it's have to comply in with the privacy regulations, which can limit. It's challenging to like share across the universities when they're trying to do some research. So even with the next is data quality and standards. So while it comes to reporting, data doesn't come in like the single format across all the globe. So it comes in different formats, missing data, duplicates. So it's quite challenging to get to the point where you're trying to integrate them to meet those standards. So to overcome these challenges, we need a solid data analytic framework to transfer the raw data of the patient care, and then like data analytic framework to improve, to transform the raw data into something actionable insights. So I'm going to share what we use at Hopkins as our analytical approach to get to the raw data, and then finally the audience is like improving the patient care. So as you can see, the analytical approach has like five-step process, where first is like the data collection, where you're trying to collect the medical records or the healthcare records or the wearable device or everything, trying to integrate everything into one medical record. And then there will be some ETL process. ETL process is like we're trying to transform the electronic records into something like more a structurable format. And then we are trying to store in a central repository so that everything is at one place, which is making it easier to analyze for a data analyst like me. And then we are using the reporting tools. We probably use other tools too, but these are the main. Tableau and Power BI are like our main hub for all our reporting needs. So our audience usually is the clinicians, nursing staff, nursing leadership, and the executive leadership for their reporting needs. I'm going to share like how it impacted at Hopkins, but also in general. So having a data-driven analytical approach definitely improved the clinician decision making. So analytical analytics help providers make informed decisions using patient data. Our dashboards give insights into patient history, enabling personalized care. So one such dashboard is the first one that you're seeing over here, is like a geriatric dashboard, where it was designed specifically for the older adults at our Bayview Medical Center. So they were trying to figure out what's going on with the flow when an older ED enters an ED, older adult patient enters an ED. So this dashboard has all those specific interventions that an older patient go through when they are in ED, like the delirium, 480 screenings, or maybe the urinary catheter use, or like NPO status, are they on any diet, all those things. So this has enabled a set of physicians to look at what's going on with the patient flow, and then also they can also look at like the HIPAA data, which is hidden right now, but this also has like the HIPAA data where they can go and see about each particular patient with their MRI numbers and check what's with the history of those patients, which help them for the preventive care. So we have came to insights that 50% of the trauma activations are happening because of the falls, especially in the older patients. So this dashboard has enabled like, okay, this is happening in certain kinds of patients. So when they are in the ED, we know how to approach to them. So that's like more a personalized care developed by the physicians based on this dashboard. Similar to a psychiatric dashboard where they are accessing like how the screening is done, how the assessment is done, and how we are redirecting a psychiatric patient to a psychiatric unit when they come to ED. And then the second one is like optimized resource allocation and operational efficiency. We have a ton of dashboards improving the operational efficiency. So, so what it's doing is like data analysis optimizes hospital resources like beds, staff, supplies, ICU beds, all those things, and ensuring there is availability when we have patients lying waiting in the waiting room. So the first one is like a operational occupancy dashboard where it's showing like how many patients are coming in with respect to like the admits and discharges, and then they're trying to overlap it with like an operational occupancy so that they could clearly estimate the number of ICU beds in the ED, so that they can have like they can estimate the wait time availability of the patients. And then a similar one for the nursing metrics for the nursing leadership team with the metrics on like for the nursing leadership with screening shifts, so the triage goes, all those things. The last one is the regulatory compliance and reporting. So there are ton of internal Hopkins reporting that's happens, and then we do some external reporting to the state of Maryland, CMS reporting, Vision reporting, all those things, and we have like the dashboards that are developed specifically reporting, and these were like really helpful during the COVID time when they were looking constantly at the ED volumes and ED metrics, how the patient flow is going on. So this one in particular showing you like the map of the Maryland closer to like the Washington, where they were looking for certain zip codes and looking at the population of where the homeless people are lying, and then like with the zip code, and then trying to find out are there any health disparities happening within the Maryland population. Okay. To continue, so everyone is talking about AI. I want to highlight the applications of AI in healthcare and how at Hopkins we are using it. So predictive analytics, we have built large ML models that predict the patient outcomes, risk of diseases, and like hospital readmission. This were really helpful with the 30-day readmission rate, sometimes with the 72-hour readmission rate, and then yeah. Second is the medical imaging and the diagnostics. AI analyzes medical images like X-rays, MRIs, CT scans to detect the abnormalities. Natural language processing, NLP, extract insights from the clinical notes, discharge summaries, pathology reports, and converts them into like the structured data so that it could be used for a reporting purpose. Conversational AI and virtual assistants, Hopkins has developed the chatbots that are used for like the virtual appointments and then like basic medical questions, all those things. So where is AI fitting in our analytic framework that we were speaking? It would fit under the reporting. It could be integrated into the reporting or could replace the reporting. Hopkins has also integrated the triage go. That's like when a patient enters ED, a nurse identifies depending on the symptoms and assigns a number from 1 to 5, 5 being the least sick, and then redirects them to the appropriate room. But we have like an AI triage go that's integrated into Epic right now, where the nurse just enters the symptoms, vitals, all those things, and then the triage go will actually assign the number, and then the patient is delivered to their appropriate room. So it's gonna reduce the time that nurse is actually spending doing the administrative work. So to conclude, data alone doesn't transform healthcare. Insightful actions does, powered by analytics. By turning data into actionable insights, we can provide proactive care and improve patient outcomes. Thank you.
Thank you, Fatma. You're doing a great job turning numbers into life-saving strategies. Anyone has questions? Any questions from the audience? Okay. Okay, guys. So how many of you stress drives your life? How much from 0 to 10? How much number would you give to stress as a part of your life? Oh. So yes. Who said 11? There you go. So Mr. Jason Munson, right? So he's going to speak on the neuroscience of stress, unlocking peak performance in healthcare and beyond. So let's welcome Mr. Jason.
So first off, I wrote a book called Rewire for Calm. It helps you to identify when you are in a stress cycle and help you to get out of it. It is going to be available on Amazon very soon. You can't buy it just yet, but would anybody like a copy today? Yeah, okay.
I think stress was
Okay. Would you like to have better teamwork and collaboration?
Yes.
Would you like to have a culture that drives innovation? Would you like your people to show up and take ownership for their roles and deliver results? Okay, let's see if this works for me. Imagine what it would be like to lead a team where everyone takes ownership for their roles, delivering results with purpose and with passion. A place where creativity fuels innovation, keeping you ahead of the competition. That might seem like a dream, but today I'm going to show you how to make that possibility a reality. My name is Jason Munson. This is the neuroscience of stress, unlocking peak performance in healthcare and beyond. And due to a childhood trauma, I have a condition called blunted affect, which means that my facial expressions don't accurately affect my emotions. So I can be feeling happy or reflective, and a lot of people perceive that as being angry. So just know that I think all of you are very valuable, and I think what you do is totally awesome. That being said, I believe that we are living in a stress pandemic, and I believe that stress has a negative impact upon our health, upon our relationships, and upon our work. But I also believe that when we are trained to manage and lower the amount of stress that we are in, it affects our performance and we produce better results. So before we get into this information, I just want to say thank you for showing up today, being here, investing in yourself, what you're doing here today can have a profound impact, not only upon you, but on the people that you work with. And I'm truly honored to be here with you today. So since we're going to be spending a few minutes together, can I share just a little bit about myself? Would that be okay? My wife and I have been together for 20 years, and it is a relationship that is still full of love and magic. We have two sons, Xavier and Brody. Xavier is the one on the left. He is my biological son, and Brody is my adopted son. He's my biological nephew. Over the years, I've been able to build successful businesses that have allowed us to homeschool our kids, giving them the best education possible, while keeping us close together as a family. And this success has enabled us to do what we want when we want. This is us at Yellowstone National Park just this past September. We live in beautiful Lake Tahoe, California, where during the wintertime, we like to ski. And during the summertime, we like to swim in the lakes and go hiking and mountain biking and have bears walk through our neighborhood. It's pretty awesome. I also have a passion for kite surfing, which takes me to breathtaking places around the world. I'm also a big Disney fan. I love being inspired by creativity and imagination. My life today is really good. I get to do something that brings me joy and fulfillment. As a consultant for NeuroChange Solutions, it's my mission to inspire and transform businesses and organizations into thriving, cohesive cultures that have a positive impact, or that benefit all stakeholders and have a positive impact on the world. I truly love this work, but life hasn't always been so great for me. Back in 2022, I had what most people would consider to be a dream job. I was an Amazon seller, and I could travel to anywhere where I had internet connection. And I was that guy that people picture when they think about working online. I was making a lot of money. I had a really free schedule. I didn't have to answer to a boss. I was living this very rich life. I was married to this beautiful woman. I got to be there in the morning when my kids got out of bed, and I was there to put them to bed every night. And I lived in this beautiful place. But the truth, I hated it. I was constantly stressed out and angry. My wife felt like she was walking on eggshells, afraid of my explosive temper. I felt trapped. I would actually say that I was chained to my laptop and handcuffed to my cell phone. And I felt terrible because I believed that I should just be grateful and happy for what I had. Everybody else wanted this. Why wasn't it enough? There were way worse jobs where people had less freedom, but I didn't feel free. I felt guilty. I felt guilty for wanting to do something that would bring me joy and fulfillment, because somehow wanting that meant that I wasn't grateful for what I had. So I kept going, forcing myself to stay in this career that from the outside looked perfect, but on the inside, my soul was just dying. And then one day it became too much. I finally cracked and I spiraled down into a depression. And I did everything I could to get out of that because I just wasn't a depressed sort of person. So I tried all the positive things. I went to the gym and I hiked up those mountains and I swam in those lakes and those rivers. And I tried all the negative stuff too, but no amount of TV or alcohol was making this feeling go away. And after 6 weeks of it just getting worse, I finally gave in. I needed help. But help was going to be a week away. And I knew that help was going to come in the form of a pill, which wasn't going to solve my problem. It was just going to be a Band-Aid. And I didn't want to be numb in my life. I wanted to be there at the beach. I wanted to kiss my wife and feel it. But my world was just collapsing. And I was scared and I was desperate. And I needed something now, not a week from now, and not a pill. So I started diving in and doing some research. And what I found was that I was poisoning my mind without even knowing it. And that first day, it changed everything for me. What I discovered on that first day was that I could not be focusing on my problems and negative emotions while at the same time focusing on a vision of the future and positive emotions. I could be in one place or the other, but not both. And my problem was I didn't have a vision for my future. So I spent some time that day learning some tools and techniques for changing my thinking patterns. And I put those tools to work. And you know what happened by the end of that first day? My depression was just gone. And I felt all that stress just melt away. So I continued learning and applying and eventually teaching what I had discovered. And there's this one thing I noticed showed up when people were suffering or they weren't getting the results that they wanted in their personal or professional lives. And that thing is stress. So I have a formula for managing and lowering stress. But first, I want to talk about what it's like to be in stress and what it does to us. A lot of us have this idea about how we're supposed to show up in life. And when things don't turn out the way we want them to, we might say something like, I can't take this anymore. This really sucks. I'm at my max stress level. Don't want to do this anymore. Is there something wrong with me? Or why can't I handle this? And for some of us, we logically know what we're going through is not all that stressful, but somehow we're at our max level. And there's this saying that goes around that pressure makes diamonds. How many people have heard of that phrase or something like that, that pressure makes diamonds? Yeah, okay. The truth is, you can take the biggest, most brilliant diamond. If you put enough pressure on it, it will crack. And why most people think that they are handling their stress okay, the research has shown that if you are not trained to handle the stress in today's world, you are in stress for 70% of your day. And when something happens 70% of your day, it just feels normal to you. The problem is that no organism can survive in long-term stress. We experience stress when we encounter a threat in our environment, like a wild animal that might hurt us. But what happens when it's coming from a person, like a coworker? That can be much harder to get away from. And you can't just reach across the conference table and strangle them, right? So what happens when our bodies go into stress? Well, the first thing that gets activated is our sympathetic nervous system. And this is the part of our brain that manages that fight, flight, or freeze response. We get very focused on our outer environment and what is the cause of the stress. And some systems in our body get really activated. So our pupils dilate. They're going to let in more light. Our blood vessels are going to constrict. Our heart rate is going to increase. Our respiratory system changes. And our muscles tense up. All the energy from the body is going to the extremities. We're getting ready to either run or we're going to attack. Some other things shut down. The digestive system shuts down. The reproductive system shuts down because it's not time to reproduce. And there's no energy left in the body for a long-term building project, like making a baby. And then also, the immune system shuts down. No organism can survive long-term stress, and people are in this state for 70% of their day. And they do this for 10, 20, 30 years or more, and it leads to disease and disorder. And research shows that over 80% of doctors' visits that they used to believe were related to genetic or hereditary conditions are now related to stress. So what happens inside of an organization when people are showing up and they're stressed out? Well, this is what we found. They have slower decision-making, suppressed passion, isolated divisive thinking. There's low engagement, weak, unclear communication. The customer has a poor experience and the team works fragmented, and people are less productive. How much do you think it costs when people show up this way inside of a business or an organization or a hospital? It's a lot. But the good news is that when people are trained to manage and lower the amount of stress that they are in, they have higher performance, they produce better results, and guess what? Goes straight to the bottom line. Organizations make more money or save money. When you work with me, you'll typically see results like this within 30 days. So long-term stress doesn't typically come from just one thing. It's usually from a series of things. And if you continue to experience the same situations regularly and you continue in stress for a period of hours or days, we would call that a mood. But if it continues on, or that negative experience, emotion continues on for a period of weeks or months, we would call that a temperament. But when it lasts for years or for decades, now that's when it becomes a personality trait. And while we might not be able to stop the stressful situations from coming into our lives, we can get really good at shortening the period of time that we experience stress so that it doesn't become a temperament. It doesn't become a personality trait. So I said that I had a formula for lowering the amount of stress that you're in. And the formula is to be greater than our environment, our body, and time. And I'm going to get into what each of these mean. So starting with our environment. To be greater than our environment, we need to understand what our environment is made up of. Our environment is made up of people, objects, and things at certain times and places. I'm going to skip that one to speed it up a little bit here. So the problem is that when we go out into our external environment and we unconsciously allow people and objects and things to affect how we're thinking, how we're acting, and how we're feeling. And when this happens, we are surrendering control of our personality to our environment. And this is what causes people to go into stress. And this is what causes people to stay in stress for 70% of their day. So if you can't think greater than your environment, then you're going to become a victim to that environment or to your personal reality. So what do we do about this? So in order to think greater than your environment, you must focus on a compelling vision of your future. So for this guy, has anything changed in his outer environment? The markets, job, work, money, company's relationship, those are all the same. What's changed? He's now focused on this compelling vision of the future. Everything else for him is the same, except for what he's focused on. And his environment is no longer controlling his personality. Good with me so far?
Yeah.
Yep. Good. Okay. So let's talk about what it means to be greater than your body. A man in one of our research studies was wearing a heart rate monitor when he got into an argument with his wife. His baseline heart rate was around 60 BPM. His wife said something that upset him, and his heart rate shot up to around 140 BPM, and it stayed there for almost 20 minutes. They stopped fighting, and his heart rate dropped, but it remained around 80 BPM for a total of an hour that he was agitated. And by the way, he was a passenger in the car, so his physical movement had not changed. Most people are going from one situation like this to another throughout their entire day, which is how people stay in stress for 70% of their day. So what do we do about that? So to be greater than our bodies, we need to be greater than how we feel, be greater than your habits, be greater than your past memories and experiences, be greater than your familiar emotions. And I'm just going to speed up a little bit here for time's sake. So there's two ways that the body becomes the mind of stress. And the first is the conditioning process. And this is when we have these cycles of thinking and feeling. So something happens and you feel slighted. This person disrespected me. You have that thought that I've been disrespected. And it causes you to feel angry. You're feeling angry, the brain checks in with the body, and it comes up with more thoughts to reinforce the feeling of anger. And people go through this cycle of thinking and feeling, thinking and feeling. And sometimes it lasts for decades. And this is how people turn into angry people or positive people, which creates this state of being of anger or happiness. So thoughts are the language of the brain, feelings are the language of the body. The second way that the body becomes the mind of stress is through our habits. A habit is when your body has done something so many times that it knows how to do it better than your conscious mind. So that conditioning process of thinking and feeling, that's going to keep you in a familiar past, and the habits are going to keep you in a predictable future. The way we get out of this is we have to consciously make a different choice, have a different thought, make a different choice that leads to a different set of feelings and emotions, which change the results that we have. And the hardest part about change is not making the same choice as you made yesterday. So let's talk about what it means to be greater than time. There's some really interesting research that has been done on the relationship between stress and performance. And I wish I had more time to share more of it with you. So I'll just share one study. This was one from the Kansas Journal of Medicine. And it found that there was a clear inverse relationship between perceived stress and productivity among employees. So high stress was significantly correlated with low productivity, particularly affecting workers' satisfaction. So how do we manage and lower stress? We have to be greater than time, or stop thinking about time. Become so present with what you're doing that you lose track of time. Be in that present moment. Resist the urge to tell the stories of your past. Quit reliving or wallowing in the past and stop trying to predict your future. This is really hard because our brains are essentially designed to predict the future, mainly just to keep us alive. Overcome the need to anticipate the next moment in the future. So would it surprise you to know that we can take your past and put it on your tomorrow? We have regular routines that are highly predictable, and the things that cause us stress in our life are highly predictable. And since 90% of the thoughts that you had yesterday are the same as the day before, we could literally take your past, your yesterday, we could put it on your tomorrow, and we can predict almost exactly what you're going to do. And if you can't be greater than your past, then your past is going to become your future. To be greater than time, we need to be in the present moment. To be in the right now, it's the only place that we can create from and make a different choice. So when you are greater than your environment, your body, and time, you can prepare, you can better prepare for situations that are going to cause you stress, and you can shorten the period of time that you're in stress. Can you see how this helps you as a leader? Can you imagine what it would be like if you and your team and all of the employees in your company had these skills? I work with businesses and organizations to lower stress, to decrease burnout, and to improve performance and to get better results. So let me share with you some feedback that we've gotten from some people that we have worked with. So Renee says, being more aware of my habits and patterns is allowing room for growth and an opportunity to change. And this is some of the feedback that we've gotten from people. They say that they are less stressed, they're more creative, they're more productive, they achieve their desired results. These are some of the companies that have benefited from this training. And they were early adopters in the sense that they wanted to have this information first. They knew the power of this information. They recognized the power of neuroleadership. And this is some of the feedback that we got back from them. They say their teams make faster decisions. There's stronger, clearer communication, more collaborative thinking, more productive. Would you like to experience this with the people you work with? Heather Day says, this is wonderful work. I'm very interested in how this can help the corporate world. Andrew Lee says, we all left with tools to start using in our lives immediately to begin changing old self-limiting thought patterns and create a new future. Okay, so if you would like to improve your performance and get better results, take out your phones right now. I'm going to show you how to get this. If you're a leader and you would like your team to have faster decision-making processes, clearer communication, more collaborative thinking, and to be more productive, if you take out your phones, I'll show you how to do this. Go to meetwithjason.net, book an appointment with me, and we can discuss what the upgrade will look like for you and your team. When you get there, you're going to tap on Discovery Call, pick a date and time where we can meet, and we can talk about how this can benefit you. Elliot Bagoon said, I had an opportunity to attend one NCS workshop and it was a game changer for me. Peter Edge says, as a result of this program, we have now created a new RCA culture that we envisioned. So last opportunity, go to meetwithjason.net. It's been wonderful to be here with you guys. I'm loving all your presentations. Thank you so much. I'll leave you with this one last thought before I leave, which is knowing is not enough. We must apply. Willing is not enough. We must do. Thank you.
Jason, thank you for being vulnerable and sharing your journey with us. It's so inspiring and learned so much from you. I have one question, Jason.
Sure.
As we were discussing earlier as well, that in time, as the journey, as the things that you have mentioned, they are not for the faint of heart. So in times when you are in that zone of stress, what is one thing that keeps you going on your mission?
The ideal vision of the future. And I find that I have to constantly redefine that vision. So the key is with a vision of the future, and the movie The Secret, there's been stuff about this, law of attraction. But the key is it's not just having that vision of the future of how you want things to turn out or how you think that they could turn out. It has to be the ideal vision. If there was no limitations, what would that be like? And then the key is to activate that, you have to fall in love with it. Fall in love with with your future, with this ideal vision of the future, and feel what it would feel like to be there as if it's now. The body's so objective, it doesn't know the difference between what you have imagined and what you are actually experiencing. The body thinks that it's there. And then you just start looking for the breadcrumbs. What are the synchronicities that you find in life that are leading you towards that future? That's how I got here and standing before you right now.
Anyone else would like to have any questions?
Right behind you.
Question. So, most of the stress, especially in adults, and that which was caused by trauma, how do you separate yourself when trauma is still in your face? How do you separate yourself and move on? Keep a positive life, even though the things that hurt you are still there.
Yeah, that's a good question. So if I understand you correctly, like if things are still happening to you right now, a woman that I met, when I was working and doing this training, she lived in a war-torn country. She lived in Lebanon, and there's just constantly bombs going off inside of her house, around her. And so what she did is she would bury herself under as many pillows as possible, and she would just go to a better place in her mind. She just started thinking about what it would be like to live in a peaceful place, and she just went there and she just felt what it would feel like to be there, and it was all she could do. There wasn't anything else she could do. She couldn't remove herself from the situation. She was there, and by focusing on that, she saw a way out. Like a way out came for her, and she took it. And she ended up here in the United States, and now she's doing some fantastic work with helping people through energy healing. So it really is, you have to create a reality that's different than where you're at, and you have to think in that place and be in that place, and then look for the changes. Great question.
Thank you. Thank you, Jennifer. A big round of applause for this. So, next speaker for today is Ms. Neha Chaurasia, and she is a dedicated strategist and passionate advocate for critical thinking in clinical practice. Let's welcome Ms. Neha.
Hello everyone, how are we doing today? Good. I think it's slowed down after we've had lunch. So I prefer presenting in an environment where it's like a little interactive because I love hearing from you as I'm speaking and I believe it's like as much as I'm speaking here, I also want to learn from your experiences. So I think I would want it to be a little more interactive. So I'll keep asking you questions and I'll try to make it as interactive as possible. So as I'm introduced, I'm Neha Choresia. Okay, let's go to the next slide for that. A little about me. I am a dentist from India. I've worked as a dentist for 3 years back in India. And then I did my master's in business administration from back in India in healthcare administration. And then I came to the US. I realized that the regulatory standards are way different for US and India. So I did my second master's, which was Master's of Science in Healthcare Administration from California State University, East Bay. And I was always interested in quality, so I did my CPHQ, which is Certified Professional in Healthcare Quality. I'm also Six Sigma Green Belt. I am certified change management practitioner from ProSci. I'm part of ACHE. I'm a member of ACHE. I'm a member of NAHQ. And I like creating awareness about patient safety and quality. And I think that's my passion. So today I chose this topic to speak about whys in healthcare. And if you think about whys, I feel like it's a broad spectrum. Like if you think about the whys, you would think like, why is somebody talking about the whys in healthcare? But then I believe everybody here is in healthcare and you understand the importance of whys. So let's speak about why finding the why is important. Any feedback or any questions you have about why would you find a why in your organization or on a project that you're working on? Okay, let me give you a hint. For example, if you have a patient that you are scheduled for 8:30 in the morning, shows up at 8:45 in the morning, you've scheduled 30 minutes for the patient, but then you realize that the patient has taken up 45 minutes. That means your whole schedule for the day has like moved a little. What does it impact? I'm telling you, the answer is right here. The whole schedule for the patients, like for the whole day, is impacted, and that definitely impacts the patient experience or patient satisfaction, because all the patients are moved a little bit and nobody wants to be in the waiting area waiting for their appointments. So definitely it impacts patient satisfaction. When we look at other whys of why we do things, like this was my biggest question when I came from the clinical side to the management side. Like a clinical side prepares you very well for the clinical side of your work area. They tell you how to be a good dentist, but they don't tell you how to be a good manager or how to manage your practice really well. And I think that when you land into the water, you learn swimming. So I think that's how I got introduced when I was just a dentist. I did not have any of the management degrees, and I started working in a clinic, and I managed the clinic single-handedly for 3 years. And being a person who was fresh out of college, I was like, yes, I know everything clinical. But then, how do I manage the human resources? How do I manage the metrics? Why am I looking at the data? So I think that's where I started looking at the why. And I think the journey has led me here where I am today, where I'm working as a clinical effectiveness consultant for Sutter Health, for the quality improvement department. But if I look at the whys, I feel like whys have been with me since childhood. Like I was one of those difficult children who always used to ask, why am I doing this? Why am I supposed to do this? Why are you asking me to do this? Like, why should I do it? Like, is there any benefit to doing that? So I feel like my why has always stayed with me.
Response did you get?
Ah, tell me about it. But now I think it makes more sense that the whys that we are doing, the things that we are doing or the things that we are not doing is for a reason in healthcare. And to my experience, it has been either compliance, regulatory, patient safety, process improvement, or patient experience and patient satisfaction. So everything we do touches these points. And I feel like that's why we do things. Now, I went into IHI, which is Institute for Healthcare Improvement, and I found some toolkits over there, which I found really interesting. And I'm sure all of us use some of these tools at our workplaces to improve processes and improve patient satisfaction and whatnot. So some of the toolkits that we have here are FMEA, SBAR, 5 Whys, flowcharts, cause and effect. Is anybody aware of any of these tools? Yes. SBAR. Can you give me the full form for SBAR?
Yeah. ISBAR is what we use for the clinical interventions in terms of intervening situation. And then the E stands for sorry? Background. B stands for on background. It's a intervening situational. Yeah, what?
Background.
Background. Okay.
B is for background, A is for assessment, and R is for recommendation. So I feel like I use all of these tools, like these are to find out the whys in healthcare. Like, if I'm coming across any issues or any processes that I need to improve as a consultant for Sutter Health, I definitely look out for, like, SBAR is something I use on a daily basis. Especially if I have to give feedback to somebody, I would write an email with SBAR of what the situation is. Then what is the background of that situation? Why I'm asking for a change and why does it matter? Because I feel like in healthcare or in any industry, if you tell somebody to change something, they're like, why? Why are you asking me to change? Like change is difficult, and that's what we've heard from so many presentations here. And I believe the background gives you a good, a good background of why you asking something to change, like why there's a reason that you need a change. A is for the assessment and R is for the recommendation that you're recommending to people. I use flowcharts because, for example, if I have to like learn a process, like the nitty-gritty of processes, I would use flowcharts, and that would give me like good background on what are the, what are the pain points of every processes. And how I would do that is I would not speak to the directors, rather speak to the people who are really working in that lab, or in that process directly. So I'm aware that I'm taking the feedback from people who are directly in touch with the process, and not somebody who knows the process from a bird's eye perspective. The other tool is cause and effect that I use a lot, and I think we are going to discuss that a little bit more in detail today. So now, how to find the why? We have discussed the importance of why so far, and now coming to how do we find the why. So when I need to find a why, like why something's going wrong or why we need to improve a process, what I would do is firstly, I would gather a group of interprofessional stakeholders who are familiar with the problem or event. And as I mentioned before, I would not choose just the leaders. I would prefer somebody who's like in the process, who's like working with the process daily on and off, who has hands-on experience with the process, because those are the people who would have a lot to say about what's going on. Leaders know the process from, I feel like, from a superficial level, but you would only get the details of what's going wrong from somebody who's like putting their hands into the process every single day. So I feel it's very important to get those interprofessional stakeholders and people who are really working and putting their hands on processes. Secondly, I would ask for what is the problem? Like, I would ask people, like, let's define the problem. Like, let's not complicate, because I'm sure we all have experiences where we bring like five people in a room together to discuss a process, and they are like, five people are talking about five different things that are going wrong, and we never reach to a conclusion, and then we have to reschedule a meeting, which happens a lot of times in a lot of businesses that I've seen. So in order to be on point, we need to define the problem or event in clear, plain language. Thirdly, we need to define the problem as a pattern and not just an isolated event. I feel like isolated events are many and they are spread through, if we think about healthcare. But then if you think about improving the processes, we need to look at what are the patterns. Do we need to improve the processes as patterns? For example, if you have near miss events, we need to look at all those events that are happening. Can somebody give me an example of a near miss event?
Medication or can be
Well, a missed medication, like something that's just about to get caught, I would say is a near miss event. But if there's a medication event, I would rather call it as an adverse event. Yeah, yeah. But thank you for that answer. Like it's definitely something that we are all looking at, especially US healthcare system. We are definitely looking at barcode compliance, and we are looking at, medication compliance, and how do we reduce medication errors. Fourth point, we would look at why, like ask the question why to the main question. Have the team together and ask why are we, why did it happen? Ask it 5 times until you get to the root cause of the problem, and then solve the problem. So here is an example of a patient received the wrong medication. So I'm sure we all work in healthcare and we've all seen some problems related to medication errors. Whether you want to accept it or not, it's quite common in healthcare. We do not want it to happen, but then it happens because sometimes things go wrong, the processes go wrong, whether it's a person-centric issue or it's a process-centric issue. It's just something that we need to address. So why and how do we get to the core problem of how this issue happened, or why did this issue happen? So I would start with, why did the patient receive a wrong medication? One of the answers that I could get is the nurse did not complete patient identification. Now, to have some engagement here, can somebody give me an example of, or can somebody tell me how many patient identifiers should you use? Yes, at least 2. We use 3 just to be sure that we are like identifying the patient really well. Now sharing an example of myself, I went to a dental clinic and here in the US, and they asked for my social security number. And it was so weird. Like I was standing on the desk and there were other people as well, and this woman is clearly asking for my social security. I was like looking at all the other people who are on their phone. So social security is not a number that you ask for as a patient identifier. Any example of a patient identifier? What would you ask a patient? Yes, birthday. Anything else? Yes, that's right. Thank you. So the second question was answered as the patient did not have a wristband. So a lot of hospitals here, especially like the hospital that I work for, we have like a wristband, like a barcode. So we use the barcode to like scan, and that's how we know that the patient is the right patient, and that's how they are supposed to get the medication they're getting. So in this example, I would say the patient did not have a wristband, or the wristband was removed for a procedure and not replaced. So then we would ask why the wristband was not replaced. And if the answer comes up as the printer was not working, we would ask why the printer was not working, and then how many patients did it impact. So that is how we would get to a root cause of a problem. So this is just a template that I wanted to share with you all. I mean, I'm sure we all do this in our real life situations as well, not just like healthcare. We always try to get to the why. But then a lot of times I feel like we look at the superficial level of detail, like we look at the superficial problems and not go to the deeper levels. But if you try and go to the deeper levels, you will be able to find that these are all like system issues or the process issues that we need to fix. Now, does anybody know what this diagram is called? Yes, that's right. Thank you, Velan. This is called fishbone analysis. Does anybody know any other name for this? It has one more name. Yes, another name. It's called Ishikawa diagram because it was created or it was invented by Ishikawa from Japan. So that's why it's called the Ishikawa diagram. If you look up online, it's also called as the 5M diagram, which is like instead of those patient front desk providers and all these three things below, there's like 5 M's, like it's method, mother nature, manufacturer, manpower, and one more M. It's also called as the 5P diagrams that has the similar 5 Ps as compared to the 5 Ms. So it's basically like looking for the reasons that go towards an issue. In this case, we are looking at delays in clinic and practice flow. So we have, so for example, if I have to, if I have to brainstorm with my team about why there are delays in clinic and practice flow, can somebody give me an example of what is a common reason for a delay? Yes, definitely. If you think about US healthcare system, I would definitely think about staffing the first thing. Any other? Like when you go to a clinic, why would you think there's a delay in getting seen? Yeah, maybe. We never want that to happen, but things happen. So when I'm brainstorming with my team in order to find a root cause analysis or in order to find like what is the main reason or what are the reasons contributing towards delay in clinics, I would look at the patient, front desk providers, method, technology, and culture. And this you can just come up with your team. You can just like sit together and think about the main 5 things, and then you can deep down drill into what are the patient related reasons. So for example, the patient related reasons in our example here are patients are running late to appointments, or patients didn't get pre-registered through EHR, which is employee health records, which is we use Epic, you might use something else. But then also like patients are having a hard time finding the physician's office due to poor signage. So this is just something related to patients. There can be front desk reasons like staff shortages, as we just discussed. There can be reasons related to staff arriving late due to congested employee parking lot. There can be related to providers, like providers are running over patient slots, overtime patient slots. As I mentioned before, 8:30 appointment happens at 8:45 and everything then goes downhill. Quick note, how many of you have ever in the US been to an appointment and have been seen immediately? You have been. Oh, that's great. I've never had any hand up in any of the presentations that I've done because I feel there's always a delay and there's somehow like it never happens on time. Like no matter how much they say that, you'll be seen on time, it's very difficult to be seen on time. There can be other reasons like providers meeting with vendors during clinic time, which I used to avoid when I was a dentist because I know how much it's irritating to patients to like sit in the hallway and wait for the physicians when they're talking or speaking with the vendors, and they feel like their time is not respected well. Providers running late in the morning or arriving late after lunch breaks. Now, this is just an example. This is not taken from my healthcare system or from my clinic. This is just a general example that I found. But it gives you a clear example of what are the different, like how would you brainstorm something to like come up with a reason or come up with reasons. And this is just one of the tools. The other tools I would use is FMEA, which is failure mode effect analysis. And I think I prefer that more because people can categorize and people can like calculate the risk scores more, and it's more analytical as compared to brainstorming something like this. So I like that analysis where you have a number and you have a weightage on what's causing the issue more as compared to the other reasons in your brainstorm pool. So this is just something I wanted to share. And I also wanted to share that I'm a part of Sutter Health, as I mentioned. And I take care of the reliability coach program where we always talk about how do we prevent errors and how do we make sure that we do not repeat the same errors again and again. And I feel by doing such things and looking at FMEAs and root cause analysis, we are doing a good job of keeping ourselves in check of all the errors that we are encountering. And I'd like to take your questions if you have any at this point in time.
Any questions from the audience?
Well, so it's not like a question, just a comment. In professional colleagues, I also quality and clinical comments at my healthcare organization. So what we do is, yes, this 5 whys is something which we use traditionally identifying any adverse events. And what happens usually when you do this 5 whys is that we end up in finding out a reason which actually gets personalized to a person. But we also try to introduce a combination of 5 whys, risk assessment, and FMEA for any kind of adverse event or a sentinel event that gives you a better insight. So you not only end up identifying a person, but you also identify the process gaps which can be fixed as a clinical context.
Definitely. Sure. And actually, I'd just like to make a comment there. So Sutter Health, like my organization, we are trying to achieve we have a reliability coach program. So I lead the reliability. So I'm a reliability champion for my team. And we are trying to achieve a place where there's like no blame, no shame. So, because there's like so many hands touching a patient, there at some point or the other, like we all know that there happens errors or there happens events that are not supposed to happen, but also to create that environment, we are not making it like person centric because like think about it, being a nurse when you know that things are happening and you are the reason because of which people are brainstorming, I think it can be really awkward. So we are trying to have like a culture of safety where people can accept their fault and like learn and grow. rather than like shaming or blaming or like, making it like person centric. We are trying to like look at the process more than what could we have done to improve the process for that person or that environment for that error to not happen. Yes.
Dr. Neha, just curious, what did the numbers look like? What's a before and after? Before you got involved with a particular issue and then after, what did the numbers look like?
I feel the numbers are different depending on the different categories. Like I have started, so I just joined this place like 6 months back. And I work on like currently my projects are improving readmissions for congestive heart failure patients, and then I'm also trying on improving mortality for COPD and pneumonia patients. So numbers have improved, but I feel like it's a very short time to like put a significant amount of change over there. Like I feel 6 months is a very low amount of time to like categorize that. And then this reliability coach program or the reliability champion that I'm at, we are trying to like improve errors. Like that's overall Sutter Health and overall for my hospital. The numbers are definitely improving, but I don't have the metrics to share now. And I don't think this would be like a good place to share like my clinical data here because it would be against the Sutter Health guidelines. Yeah.
Thank you, Ms. Neha. I love the level of curiosity you have.
Thank you.
And I believe this mindset leads to innovation.
Thank you.
Thank you so much for your presentation.
Thank you.
So our next speaker is our keynote speaker, Dr. Barbara. Let's welcome her. She'll be talking on improving fall risk assessment to reduce falls in assisted living communities.
No. So thank you for putting up with me one more time here today. Back on July 13th, 2020, about 7:30 in the morning, my husband and I decided we were going to go play pickleball. Everybody knows pickleball? Yep. So we were just kind of getting warmed up, hitting the ball back and forth across the net. And he hit a ball and it just touched the top of the net and bounced. And I thought, oh God, I got to run to get the ball. Stubbed a toe. Now I'm running into the net. If the net's running like this, I'm kind of at this angle. And in my head, I said, don't grab the net. Don't grab the net. Got to the net, grabbed the net, hyperextended both my shoulders and broke them both. What can you do with no arms? You can't feed yourself. You can't get a drink of water. You can't comb your hair, brush your teeth. You can't use the restroom without somebody helping you. Since then, I am very aware of where my feet are. My proprioception is a little enhanced. I was in my 60s when this happened. And as I was finishing my doctoral program, I had to come up with a project. And having worked in a variety of healthcare settings, I knew that falls were a big issue. So I decided to not look at falls themselves, but how do we assess for fall risk? And there is a tremendous amount of information out there about oh, these are the things that contribute, but how do we get there? What tools do we have to assess for fall risk? So that's what I'm going to talk about today. Uh-oh, come on, advance. Okay. So falls are a safety issue in all healthcare settings. Doesn't matter if it's in a clinic. You go to the clinic, what do they say? Have you fallen in the last 6 months? You go to the hospital. Have you fallen in the last year? Wherever you go, they're asking you about falls. It's one of the ways that we measure healthcare quality. It's the leading cause of accidental death in New Mexican adults age 65 and older. That's pretty scary. I chose the assisted living setting because it's not a long-term care facility like a nursing home. It's not like community dwelling adults, although that's how they are considered by the state of New Mexico. So there's limited evidence that exists about fall risk assessment practices in assisted living communities. So what's the significance for this? Well, first off, cost. Healthcare costs go up when residents or people have to go to the hospital. The hospital incurs the costs; those are transferred to the patients. Now let me scroll down here just a tiny bit. Hospital emergency room overcrowding, fear of falling. So I have a definite fear of falling. I make sure I know where my feet are at all times. Hang on, I'm trying to scroll down here. Come on. In 2015, there was a study that estimated the economic cost of falls, ranging from minor to serious, fatal. This report by Bergen and her colleagues estimated that the cost of falls for 2015 was $50 billion annually. That's a lot of money. Lots and lots of money. It's unsustainable for healthcare organizations. It's unsustainable for healthcare payers. And it's a burden on older adults when they have unpaid balances that their healthcare insurance doesn't cover. It takes a toll on their well-being, their mental well-being. It can lead to further declines in health as a person has such a fear that they don't get up and move or exercise. So again, in 2014, the total cost of falls in New Mexico was $257 million. So I inflated that. I did this presentation last year. So I inflated that to $2024, and that total increased to $341,741,737. That's an increase of over $84 million. Now, if we could reduce falls by improving the way we assess for fall risk, that's basically an $8.5 million savings that could be reinvested back into senior programs by the state of New Mexico. They already have all kinds of fall programs in place, exercise programs, everything like that. But we have to change the way we assess for them if we're going to get more accurate results. So falls are often underreported because, oh, I'm going to get in trouble. My patient fell. So there's a lack of transparency and accountability. It can lead to underreporting, again, because, oh, I don't want to report this. So I'm just going to say, oh, I don't know what happened. You know, I found her on the floor next to the bed, when the person really has been in the caregiver's 6-foot area. The caregiver turned around to do something. The resident may have had some sort of cognitive issue, tried to stand up, stood up on the foot pedals of the wheelchair, and down they went. So the current New Mexico Department of Health regulations for assisted livings say that during waking hours, facilities have to have at least one caregiver, one staff person, for every 15 residents. Now, some of the communities in New Mexico are quite large, 150 people. That means that 10 people are responsible for watching 150 people. And if you're showering one of your residents and the person next to you is taking somebody down to the dining room and one of your residents falls, whose fault is it? It's that person who is assigned to that resident. So the staffing is a big issue. The initial resident evaluation should establish a baseline in the resident's functional status and thereafter assist in identifying any changes. This last one, the evaluation will, at a minimum, include the following abilities: behaviors, status changes, safety needs, high-risk behaviors, history of falls, agitation, wandering, fire safety issues. So person comes in, they're looking to join your community and say, have you had a history of falls in the last 6 months? Yeah, I fell about 4 months ago. What kind of activities do you want to do? Shut the door right there. Didn't try to, well, what were you doing? What kind of medications do you take? What activities? Do you exercise? Do you use assistive devices? But that's how it happens. And I've seen it happen time after time after time. The nurse doing the assessment is in a hurry to get through it because she's got meds to pass for somebody else. And yeah, I fell 4 months ago. Oh, okay. Write it down, and move on. So, oops, hang on. Go back. So those are the current regulations. My hope is that some of my research on fall risk assessment is going to make changes to staffing. I would like to see one caregiver for every 5 residents, because these are active people. They're up and they're moving. They're moving around their apartments. It's not like they're staying in bed. We have staffing ratios for acute care hospitals. We should also have staffing ratios for assisted livings. So that's my hope, is that it improves that. So the purpose of this study was to reduce falls by 20% between October 1st and December 31st of 2022. It was also to improve staff knowledge related to falls and fall reduction strategies. Oops. Come on. There we go. So the question asked was, in adults age 65 and older, does using the Morse fall scale, the medication risk score, and universal or individualized fall reduction strategies compared to using the Morse fall scale alone reduce falls over 3 months in assisted living communities? And then in assisted living staff, does undergoing an educational intervention on fall risk assessment and reduction practices compared to no intervention increase fall knowledge? So I used Orlando's deliberative nursing process. I like her model because includes the person in every aspect of the care. Literature search, of course, PubMed, CINAHL, Medline, Google Scholar, Cochrane Databases, systematic reviews. And I was looking for English language articles published in peer-reviewed US journals between 2012 and 2022. So initially, I retrieved 943 articles, and the first round of reviews excluded 851. After a second round of screening and looking at articles, I ended up with 36 articles for synthesis. 4 themes were identified in the review, and each was supported by very robust evidence. Those themes included tools for assessing fall risk factors, consequences of falls, and fall reduction strategies. You can see over on the left-hand side here, I had 11 level 1 studies, and then a level 2. So I think it worked out to about 33% of the articles were level 2 or higher. So my framework that I chose was the Perry's Promoting Action in Research Implementation in Health Services. And I liked it because it was very simple. It took the evidence, it took the facilitation, and it took the context, overlapped them, and in the center, you have your success. Because this was part of a doctoral program, I obtained permission from the assisted living community, the University of Missouri, Kansas City, IRB, and the School of Nursing and Health Services. I used a prospective quasi-experimental repeated measures design. My instruments were the Morse-Fall scale, the medication risk score, and the AHRQ fall knowledge test. Participants were recruited from the assisted living area of a large, what do they call it? Life, can't remember what they call it, but they go from everything from independent through skilled nursing. So residents had to be age 65 and older. They couldn't have a diagnosis of a neuromuscular disease, any dementia or cognitive decline. And then recruitment, because this was in the end of 2022, COVID was still waxing and waning. I was allowed to come in and do 1 meeting with staff and 1 meeting with residents to explain the program and try to recruit participants. I educated the staff also on the requirements, and they were requested to try and recruit folks. We'll get to this.
4 minutes, Barb.
Okay, so residents would be assessed on admission. The scores would be calculated. If a resident had falls, changes in condition, or hospitalization, if they fell, had a change of condition, or hospitalized, they were reassessed and returned to step 1. They were monitored for falls, changes in medication or condition or hospitalization. And then at the end of the research period, they were reassessed again to see if there was a change in status. Resident demographics, I only had 5 participants. I was very disappointed, but then I realized that there were opportunities still to be had. So the Morse-Fall scales, median score was 67.5 pre-implementation and 70 after. So there was an increase, which indicated a greater risk for falls. That's because one resident fell. Pre-implementation medication risk scores, median was 5, median was 5 post-implementation also. Come on. Staff demographics, I had 12 staff complete the AHRQ test for fall knowledge. I was not allowed, because of COVID, back into the building to do the educational intervention. I had people from all different races, all different levels of education, resident aides, nurses, CNAs, people who had worked for the community for 30 years. 9 out of the 12 thought that falls were a normal part of aging. 12 out of the 12 said that falls are preventable. And 9 out of the 12 thought that falls were a problem in their community. So pre-implementation, I had 11 surveys returned, 11 tests. The median score was 30. Post-implementation, I only got 6 back, but the median score went up to 60. And I'm sure that it would have been lower post-implementation if I had had those 5 extra tests. Falls per 1,000 bed days. Pre-implementation, 57 residents, 5.5 falls per 1,000 bed days. Post-implementation, because there was a significant decrease in the number of residents, the falls actually went up to 7.7 falls per day, bed day. So the successes, the residents learned what their fall risks were. The mean pre and post study scores identified changes in fall risk, and the mean pre and post study fall knowledge scores indicated increases in fall knowledge. And comparing them to benchmarks in the studies, they were right in line with that. So limitations were validity. So the inclusion and exclusion criteria was well thought out. Recruitment strategies, limitations were small sample size, inability to conduct the educational intervention, and then differences in staff practices and definitions of falls, because there is no one definition of a fall. And in the literature that I found, that was the same practice. I'm going to just flip through these real quick. Take your time, establish early and frequent contact, and conduct a background investigation. It's useful, but the study didn't demonstrate a reduction in falls as anticipated. References. And there's my study published by UCG. I know. Wow. So thank you for letting me entertain you again.
Thank you so much, Dr. Barbara. Big round of applause for that. And a second round of applause for sharing us today the sessions. This is
You still play pickleball?
No. Stand in the trap and just do this. No, I don't.
Oh.
Well, you stubbed your toe and I knew I was. You know, it was like, okay, where pins fall, don't grab the damn net, don't grab the net.
Try pinball. Pinball.
You know, like that. Ball. Ball.
Okay, so our last presentation for today is by Professor Nitika Parmar, and she would be presenting on mapping the oral biome of disease and healthy individuals in response to natural and synthetic sweeteners. So let's welcome Professor Nitika.
Hi, good afternoon, everyone. It's a pleasure being here. I am actually quite distinct from all of you. I am an experimental biologist at California State University, Channel Islands, located in Camarillo. And when I mention this to others, a lot of people with a very straight face ask me whether I take a boat to work because the campus says Channel Islands, and I have to tell them we are not on the islands, we are in Camarillo. So it's a very beautiful area. For those of you who do not know the campus, it's halfway between Santa Barbara and Los Angeles. And it used to be a mental hospital earlier. So right now it's a university. So a little bit about myself, Nitika Parmar from CSU Channel Islands. I gathered my bachelor's in biophysics honors school, my first master's in biotechnology, and second master's in biochemical engineering from IIT New Delhi. And then I sought to come to the US to seek a PhD, which I did at UCLA in molecular biology. And then I sought a postdoctoral fellowship in cancer biology, which I also did at UCLA. And then I moved into academia. I was not too interested in moving into the biotech industry because I wanted my intellectual freedom, which is very easy to practice in academia. I could do anything I wanted to. In those days, the grants were very easy to come by. Right now, as you said very clearly, we don't know what's going to happen a week from now. Thankfully, I don't have any NIH grants. I have state California grants, which hopefully are not going to be impacted. So my area of research is actually quite a bit. I've been trained in cancer biology. I'm a molecular biologist by training, so I do a lot of gene signaling pathway stories, trying to find out what proteins are involved in cancer and so forth. But I moved my interest area to something very different, which is not what I normally do. I happened to attend a Nutri Genomics conference about 7 years ago before COVID, where there was a lot of talk about what we eat really impacts how the DNA is being methylated or the genetic profile is going to be different depending on what we eat. And so that got me really interested. And this entire project, which is focusing on sugar substitute or sweeteners that most of us do use today, came about just like a tube light when I was walking down the aisles of Costco and I happened to see these huge number of sweeteners, artificial sweeteners. We have natural sweeteners like stevia, monk fruit, agave syrup, maple syrup, and then we have these artificial ones, really nasty ones, Equal and Splenda and aspartame and acesulfame K, all those are present in the diet sodas that we drink. So I got very interested in this area and I started a project with my undergraduate and graduate students in my lab about 3 years ago. And we have done a lot of research since then. And the title of my talk is Impact of Artificial and Natural Zero-Calorie Sweeteners on the Growth, Metabolic Footprint, and Chemical Sensitivities of the Human Oral Microbiome. It's a mouthful here, literally. So if you feel that you're not catching me as I speak, since I'm going to talk a lot about biological experiment, please feel free to stop me. So before I do that, I want to ask questions of you, and please be honest. How many of you do take sugar substitutes, whether they are 0 calorie or full of calories? Okay. How many of you have done some background research trying to find out what the long-term impact of these sweeteners are? And how many of you found bad information about those? Good. All right. So the problem with the sweeteners today is they're not regulated by FDA. And there are no long-term observational studies which have been conducted to determine what the long-term impacts are on human beings. There have been some studies on rats and mice to show that some of these artificial sweeteners actually are carcinogenic in nature. So that's a red flag for all of us. So that's how I started my project. And one thing that really interested me was the oral microbiome. I'm going to ask you a question here again. How many of you are vegetarians, hardcore vegetarians from childhood? Fantastic. You're going to be very different. How many of you are vegan? Absolutely no animal products. Okay. How many of you are on a raw food diet, which is pretty austere, none of us? And how many of you been non-vegetarian or pescatarian since childhood? Okay, so we have a diverse population, and this is exactly what I wanted to find out. How the oral microbiome differs with regard to its ability to grow in these different sugar substitutes. Depending on your diet, depending on your health status, do we have different microbiomes in a mouth, essentially? Now, the mouth has millions and billions of bacteria, not just bacteria. It has fungi, it has different kinds of, hopefully not pathogenic bacteria too, depending on a disease status, but most of it is bacteria. And the oral microbiome is extremely important, as is the gut microbiome, which dictates our health. We know about the gut-brain axis, which is it's a pretty hot area right now. How what we eat is actually going to impact our emotions, our behavior, our overall health. So this is where I started my research here. And the outline for my research, I was given about 20 minutes, and I'll try to wrap it up in 20 minutes. Is I'll give you a little bit of a background about the sugar substitutes that I'm working with, and then move on to the methodology. And most important part is what kind of data we gathered, and finally end up with challenges and future outlook. So some of these compounds may look familiar to those of you who have been taking sugar substitutes. There's a lot of sweetness in the world today. There's a lot right now. And the problem is we don't know how pure they are. Is the honey that we buy, are they pure? I've heard of honey being contaminated by colored pigments so that it looks golden or brown, but it's really not honey. Same thing with coconut sugar. We have sugar alcohols like xylitol, erythritol, and so forth. And erythritol was really big 2 years ago in all zero-calorie foods until a report came out that excessive erythritol uses causes strokes and cardiac disease, which was terrible. And so people stopped using erythritol. And then we have some novel sweeteners like stevia and monk fruit and tagatose. And now for those who are diabetics, the zero-calorie sweeteners are extensively prescribed. And I've shown you an image right here. We have equal, sweet and low, sweet leaf, Splenda. It's abounding here. So we don't know which one is the best for us, which one is really good for us. We don't know because there's no long-term studies done on the same. So what I sought to do with my students was very simple. It was a very, very simple project which lasted for about 2.5 years. Our whole goal was to gather human subjects. And of course, the research was approved by the Institutional Review Board on our campus. And our goal was to get about 50 different human subjects, but we got about 20 because it's a very labor-intensive project. We got mouth samples from faculty, staff, students, friends, family, and so forth, using a proper informed consent form. And we gave them a questionnaire asking them about their dietary inclinations and their disease status. And then we collected their mouth microbes. Most of it is bacteria, and we started growing them in the lab in different media conditions. What we were doing is we were removing the glucose from the media that the bugs love to grow. And we were substituting that glucose with all these 16 to 18 sweeteners that I showed you earlier in my slide. And our whole goal was to find out which of these sweeteners can be metabolized or utilized by the microbes coming from mouth of people with different dietary inclinations and different disease status. And then we set out to do what we call metabolic footprinting, where we expose these bacteria to different carbon and nitrogen sources to find out how they are different from each other. And that was an extremely long process because these biolog plates are very expensive to work with, and we work with about 20 of those right now. So what was the data that we gathered? Well, the first thing we wanted to know from our human subjects was their dietary inclination. And we had people with all kinds of dietary inclinations: vegetarians, vegan, paleo, Mediterranean, low carb, diabetics, pre-diabetics, and so forth. And our main condition for selection was that, first of all, we only gathered the mouth bacteria from adults. And those adults should not have any oral diseases or any bloody gums because we didn't want to collect bacteria from those. Our lab is an academic lab, so we're not qualified to deal with pathogenic bacteria. And one condition was they should not be taking any antibiotics because that would change the microbiome in the mouth. So these were some simple criteria. And the process for collection of the microbes, as I'm sure all of you know, is basically a simple swab where we swab the gums and the tongue as well as the palate to collect the bacteria from the buccal cavity. And my apologies for the small font here, but this is just showing you the kind of data we collected based on the dietary inclination of the human subject, the diet, how long they were on that diet, and particularly important was what kind of sweetener were they eating for a long time, whether it was high fructose corn syrup or honey or sucrose and whatnot. For me, more important was whether these individuals had any ensuing diseases. So we were lucky enough to get some samples from individuals who had Hashimoto's disease or cancer or diabetes, pre-diabetic as well as IBS and GERD. So we were able to get some samples from individuals who had different kinds of diseases. And finally, we also asked individuals whether they took dairy or they were resorting to mostly non-dairy milks, such as almond and oat and soya, because all that would actually change our oral microbiome. So this is our first piece of data where we collected the bacteria and we grew them on what we call LB media. The bacteria love these media, which is composed of glucose. So our glucose is a positive control, and no glucose there's no carbon source in those foods. So these bacteria should not be able to grow, and rightfully so, they die because there's no carbon source. So what we found was monk fruit was very well metabolized by pretty much every oral microbiome sample that we analyzed in these 20 human subjects. Now, monk fruit is composed of mogroside. It's a very intense sweetener, probably 5,000 times more intense than sugar, regular sucrose. And the others, which were kind of moderately utilized comparatively with glucose, were maltitol, erythritol, stevia, and some of them are sugar alcohols. So we're still trying to decipher why these are metabolized and why the others are not metabolized, something that we are still pursuing here. And then this is a whole series of data that we collected, which just shows you what is the propensity for these subjects. By the way, these are all human subjects. We cannot identify them. They have been given numbers. And for instance, subject number 5 has Hashimoto's disease. And you can see predominantly, it's a very similar profile. They like sorbitol, they like monk fruit, they like stevia. So it's a very similar profile, barring a couple of them which are very different. But the one that I found most interesting was the lifelong vegetarian and a person who's diabetic was able to utilize pretty much every sugar substitute. Unlike the others, where you can see there is hardly any growth in all the other substitutes that I've talked about. So this was very interesting. This was a first view that depending on the dietary status as well as the disease status of an individual, there could be a different propensity to utilize the different sugars. Now, how this is happening at the cellular level, we don't know. That's exactly what my goal is in the next 1 year, to find out which protein pathways are being utilized to actually metabolize these sugars. And very interestingly, We also found the same in a pre-diabetic sample, again, diabetic and pre-diabetic. If you compare them with the others, for instance, GERD and IBS, you can see more sugars are utilized here compared to, regular non-disease individuals versus individuals with acid reflux disorders. So we have all this data. Our goal right now is to put our thinking caps on to find out what exactly to make out of all of this data.
Can I interrupt?
Yes, please.
If you talked about the vegetarian, they metabolize the sugars. Is it good? Or so the bacteria metabolizes those sugars, is it what I understand?
Correct.
So what does it mean from a clinical practice?
That's exactly what I'm trying to find out. That's exactly, for me, I'm very interested in looking more like molecular pathways. So we do know glucose is broken down in, the whole TCA cycle in it. So we don't know, for instance, what do they do? Do the bacteria have enzymes to break down lactitol, xylitol? We don't know. We don't know. So that's something. Now, whether this is a reason for concern or a reason for joy, even I don't have an answer for that. So we have gathered a lot of data, but the interesting part begins now. Where do we go from there? What do we conclude from all of this data? So, but good question. That's especially for diabetics. And I'm trying to explore cancer samples right now, which is primarily my area of interest. So that was the first part of the study. The second part of the study is doing a quick high throughput assay where we buy these 96 well plates and they're sold by a company known as Biolog. And they have 25 different panels. These panels for carbon utilization, nitrogen, sulfur, phosphorus, toxic reagents, anti-cancer reagents. So you basically buy these panels and you start seeding your bacteria in them and you let them grow 24 hours or 12 hours overnight. And the next day, you do what we call a cell viability assay to determine which ones are growing and which ones are not growing. So it's pretty simple, except that the plates are very expensive. And typically a plate looks like this. This is just a representative carbon utilization panel entitled PM2A. So you can see that it has a lot of different carbon sources, dextrin, gelatin, turinose, we have glycine, and maltitol and so forth. So rather than doing all of these individually 96 times in my lab, what we did was simply buy a plate and threw all our bacteria in there. And I'm just going to show you some raw data. This is how the raw data emerges. Remember, we're looking at 96 different compounds and we're looking at 20 plates. So we're looking at a huge number of data points. To make sense out of it is going to be a little bit of time consumption for us.
3 minutes.
Yes. So this is basically what we found in terms of utilization of carbon sources, where the highest was, different kinds of carbon sources like arabinose, salicin, and the lowest was capric acid, which was very common in most of those 20 different samples. And likewise, when we started we started looking at nitrogen utilization panels, for a lifelong vegetarian, we saw it was pretty much similar across the entire panel, except that there were certain dips and certain raises for certain compounds. So again, what does this mean? We're trying to analyze what this exactly means. And finally, we did chemical sensitivity assay. And one result that worked out very interesting was this sample is coming from a diabetic patient where they were found to be extremely sensitive to an antibiotic known as novobiocin. And why they were so only the diabetics and not the rest, we're trying to decipher this as well. So through these assays, we were able to determine that yes, there were some differences with regard to dietary influences and disease status. But where do we go from here? So just to cap here, the oral bacteria collected from the mouths of different individuals do show preference. The preference is mostly for monk fruit, maltitol, sorbitol, and stevia. And the difference is with regard to their diet and disease status. And there are certain compounds which are absolutely not liked by most of the oral microbiomes, such as capric acid. The diabetic individuals and the vegetarians show a very interesting and unique profile, different from all the others. And one of them had a high sensitivity to novobiocin. So the challenges are the oral microbiome does not contain just bacteria. It contains different kinds of bacteria, aerobes, anaerobes. So how do we make sense of it? Which bacteria is really responding to this? Are there other kinds of organisms which are playing a side role here? We don't know. And for long-term experiments, since after we collect the saliva samples, we have to start processing it pretty quickly within 24 hours. So we cannot store it because that will change the bacterial profile. And of course, we don't know whether the microbes who are staying in our oral mouth are going to behave the same way as they are being grown in a test tube or a microbial tube. They may not like it. So we're not too sure about that. So right now, our future work is exploring other PM panels. We just explored 5 of them. We have 15 more to go. And we are trying to explore other artificial sweeteners which are coming out in the market, trying to see. And one thing we want to do is utilize more samples coming from individuals who have cancer, particularly those who have been on cancer chemotherapy for a while, because that will really change their oral microbiome. And one of my students just 2 days ago, he just came to me and said, why don't we look at individuals who are on Ozempic, essentially? And for weight loss treatment, does that really impact their oral microbiome? So that is something, and he was able to find one individual who is currently on Ozempic for past 1 year. And we are trying our best to get the oral sample from that particular individuals to see whether we will be able to do the similar experiments on those. So this is a very condensed presentation that I have. I have almost 2.5 years worth of data, but I've just given you the gist of it here right now. And that's just a list, partial list of my references. And I'm very grateful to be invited. And thank you so much for your attention. By the way, if you want to donate your oral microbiome to me, please email to me and I'll be happy to send you the kit and you can email it back to me. Unless you are close to Camarillo, you're most welcome to come to the campus and give us your oral microbiome sample. Would love to have it. Thank you. I'm happy to take any questions
I
or
was going to say,
suggestions.
we probably have a lot of questions for you, and you are our last speaker. So we have a question here.
Thank you. That was an excellent presentation. Thank you. I've been very interested in the gut-brain axis because we are looking at the association of the gut microbiome with the Parkinson's disease. As you probably know, that's quite a bit of an involvement with the Parkinson's disease and the protein and also the gut microbiome moment. Then there is quite a bit of treatment with the photobiomodulation treatment, which is the area of looking at that. So would you be looking at any cognitive impairment associated with the oral microbiome? Because that's what we are looking at with the cognitive impairment. Because there's a lot of glycosylation happening here, especially with the sugars. Mm-hmm. And one of the significant factors is the chronic small vessel ischemic disease, which is the periventricular, which is the midbrain small arteries are getting thinned out or sort of thickened with decreased circulation, especially with increased glycosylation, which results in vascular dementia. So whether this, would you be looking at some sort of a cognitive impairment and association of vascular dementia associated with this?
I would love to, but I'm not an expert. Neither have I been trained. I would be interested in a collaboration. Absolutely. Yes.
Because through the University of London, we can actually do that.
I would love to.
Okay, so that'll be good.
I'll touch base with you.
Thank you.
Any other questions or comments or suggestions?
Jason.
So you're battling up against an industry that globally produces $3.11 billion in revenue. Are you receiving any pushback from any companies, organizations, associations because of your research?
Not yet. Not yet. I have presented this data pretty much not at major global conferences, just very regional within California. And it hasn't been disseminated widely as of now. It's mostly in the academic circles. So the pushback, I'm not sure. And I think I need to gather a lot more data and provide convincing responses that this is the detrimental impact, like the gentleman just said. If you can show some cognitive impacts or even biomarker levels changes in the blood. The problem is we're not a clinical lab, so I'm not licensed to do any of those pieces of work. All I can do is at the molecular level, and that's what I'm interested in. At the gene level, what's happening at the protein level, that's what I want to explore. But I do want to collaborate with the clinicians where we can do a very sound and a solid study to actually show that these could be very harmful in the long run. Now, when we say long run, it could be 5 years, 10 years, we don't know. So that's a pretty long longitudinal study. So no pushback yet. Hope not. I mean, I myself take monk fruit and, I'm relying on it not causing any problem to me in my liver down the line. Any other questions? Thank you so much for your attention.
Professor Nitika
Yes.
Parmar.
Yes.
Thank you. I'm going to want to talk to you because I chewed xylitol gum.
Okay.
Yes.
Thank you.
All right. There's your presentation. Well, that concludes our day. And I think Barbara wanted to get everyone to go out to Fisherman's Wharf for dinner. Is that right?
Yeah. Maybe, what time is it?
It's 4:22 now. At 6
Down here?
in the lobby.
Take an Uber over to the wharf and just kind of walk around and find a restaurant.
That's a good idea.
Okay. Some of us will be meeting at 6 p.m. in the lobby. And let's say thank you again to Max. To the elusive Dr. Smith. The legend, Dr. Smith, the legendary Dr. Smith, or maybe just a legend. And to all of you for coming, and thank you very much. And I hope to speak with all of you again. Take care.
Can you say something? Tomorrow?
Please can.
Say that again.
You can attend from anywhere. You can attend from.
Only virtual?
Yeah.
So if we're staying here in the hotel, we can stay in our room. There's nothing gonna be happening here.
No.
Okay. I just wanted to be clear.
Thank you.
Max, I don't know if you have the ability to do that on the calendar. You put her in a chair on the end. And then you can Photoshop her into the.
Yeah.
That's okay.
I just
Any other documents?
Okay, so what are these figures? So you have a pediatric. So years ago, I was studying comes in. Yeah. What will be filed. Yes. So, yeah, the risk, like cancer,
Yes.
Time.
Yeah.
Risk of dying. The risk of sleeping, falling, dying, or shouting, 1 out of 20. The evidence of neuro. That's how we do things. But we can work on the future what I can. Do you know what you need to care now? So, so you really connect with them around that. I see. Like we were. Yeah. So that's it.